from Serve Together Foundation. So, warm welcome you all for this one-day seminar on Ponseti method of Clubfoot management. Uh, Dr. Veena, Deputy Director, is joining another 2-3 minutes. She is in her chamber, and the mission director will come around 11 o'clock for inaugural. Meanwhile, so instead of delaying, I request you one by one can introduce yourself. Then we can start the session. Once ma'am comes here, officially we can start the session. Please, from which district you are representing, and one or two words. Sir, you please sit and introduce.
I am Dr. M.C. Vijapur, orthopedic surgeon from Siretti, Gadag district.
I am Dr. Janardhan, Taluka Hospital, Bhatkar, Karwar district.
Dr. Nischal, Tirthalli, Shimoga district.
I am Dr. Santosh Kumar Rao, Taluka Hospital, Ankola, Karwara district, sir.
Dr. Balchandra from General Hospital, Sirsi, North Kerala district.
Dr. Guru Raj from Koppal district.
I'm Dr. Lokesh, General Hospital, Mulpakal.
Dr. Rajkumar, Orthopedic Surgeon, Chanpatna, General Hospital.
Dr. Anil, District Hospital, Ramanagar.
Dr. Farooq, General Hospital, Magdi, Ramnagar district.
Dr. Krishnamurthy, Orthopedic Surgeon, General Hospital, Kunegal, Tumkur district.
Dr. Shivayogi, General Hospital, Vasanagara, Shumaga district.
Dr. Guru Dikshit from Kolar District Hospital. I am Dr. Sushant Nadkarni. I am a orthopedics postgraduate from KIMS Hubli, and I am very proud to sit beside my teacher of UG, that is Dr. Shivayogi sir.
Dr. Suresh from District Hospital, Sikbalapur.
Dr. Suresh from District Hospital, Tumkur. So myself, Dr. Ajay, I am working at Indira Gandhi Hospital.
So I am Dr. Abhishek, I am from Indira Gandhi Institute of Child Health.
My name is Mohan Belthor. I am originally from Bangalore but now working in Phoenix in Arizona, United States. Thank you all for coming.
Good morning, I am Dr. Ashish. I am from Pune, Dinanath Mangeshkar Hospital.
Thank you everyone.
How many of you are already treating club feet, like children with club feet? Can you raise your hands, please? Okay, good. So when you go back, will you be treating children with club feet with the Ponseti method? Is that or will you just be making referrals? You will be treating? Okay. So this course will be a combination of some lectures. We had more lectures, but because we're starting late, we're going to cut down on the lectures. Because what we want you to go is more, the technique of how to do it. So we'll concentrate more on that. The lectures are already available. Gopi can send you, the PowerPoints. So, but we'll give you some few lectures which are important, but rest of them, because of lack of time, we'll just send it to you, okay? But we'll concentrate, spend more time on the techniques, and if you have questions, we are happy to answer anytime. Feel free to raise your hand, we can answer the questions, okay?
Okay, we will start with, because already we are going so much of late, and it is a great pleasure, and it is my dream in 2008 to see Dr. Mohan in physically. So today he is in our midst as a faculty. Not only that, he is a chief medical advisor for the Serve Together Foundation. So I can talk about him, so lot we can say, tons of knowledge on orthopedic and traveling globally, training a number of doctors across the world. So great that Dr. Mohan Belentu is in our midst. So we will welcome him with the claps. And his close friend, Dr. Ashish Ranade is here. He is all the way came from Pune. So he is one of the best leading orthopedic surgeon. He is also practiced in USA and doing more than 30 years of experience in orthopedic. So welcome you, sir. And I would like to invite our own and young and dynamic Dr. Abhishek from Indira Gandhi Institute of Child Health. Some of them knows that last year he is also faculty here, and he is the standby anytime. He is helping us, and more than 8 years experience in the especially Ponseti method of Clubfoot management. So with this introduction, I would like to we will start the session, and when Dr. Veena ma'am comes, we will pause and we will proceed. I invite Dr. Mohan Belentu to start with. Thank you.
I think light should off, right? Light should go off.
Let's start. Power.
So as you all know, clubfoot is one of the most common deformities in childhood, especially in the lower extremity. And the incidence is about 1 in 500 cases. Okay, of 1 in 500 live births, children who are born, about one will have a clubfoot. And it can be unilateral or bilateral. Okay. Next slide, please. So the cause for clubfoot is it can be multifactorial. It's a combination of genetic and environmental causes, but most are idiopathic. There are other groups. For example, it may be associated with syndromes. It may be secondary to neuromuscular conditions like arthrogryposis or spina bifida, etc., and also secondary to some skeletal dysplasias like dystrophic dysplasia, etc. But the most common form is the idiopathic clubfoot, where the cause is a combination of environmental factors with some genetic predisposition. It's thought that the contractile proteins on the inner and back part of the foot, that means the posteromedial part of the foot, causes or pulls the foot into that position during the child's birth or during the child's development. Okay, and they have identified some genetic pathways which code for that, but it's not a single gene disorder. Okay, like PTX1, TBX4 is the pathway that's been identified. Next slide, please. So the incidence varies in different parts of the world. For example, I think in India and China, the incidence is supposed to be around 1 to 2 per 1,000. Like in Polynesia, that's the incidence is more, up to about 6 to 7 per 1,000. So there's some variation in the incidence in different parts of the world. But overall, if you look at the world, about 200,000 children with club feet are born every year, and about 80% of them live in low and middle income countries, and only 20% in the developed world. But if you see who are the doctors treating clubfoot, where they are, about 80% of them live in the developed world, and only 20% in the low middle income countries. So there's a big disproportion between where the children are and where the trained doctors are. So as a result of which, currently we have a lot of children with untreated club feet all over the world. And the number of new children with club feet born in India is around 35,000, but I think that's according to the last count. But I think from speaking to people here, I think it seems like it's more like 50,000. And in Karnataka, at least according to the numbers, estimate is around 2,200 children with club feet. Okay. This is just a bar diagram showing the prevalence of the incidence in different parts of the world. Next slide, please. Now, why should we treat this? Because before treating any condition, we need to understand the natural history of the condition. So if you don't treat it, it's not going to stop the child from walking, but it's going to make it difficult, like this child here. You can see they walk on the upper and outer part of the foot, and over time they develop some calluses, deformities in their feet, which makes it difficult for them to walk, especially on uneven surfaces in the villages, things like that, and then to run, etc. So because of that, they are also not able to wear regular footwear, and that makes it hard for them to do activities, like various activities of daily living, sports, etc. Okay, and over time, the callus, the skin can break down, and it can result in ulcer formation, and that can get infected and resulting in it can also cause osteomyelitis, resulting in they could lose their leg. Sometimes if it gets really bad, they could even die. And in addition, because of all that, it's difficult for them to get, if you look at a child or a young adult with this condition like this, people are kind of reluctant to employ them for especially manual labor or other works, especially in the rural areas. So they constitute a significant economic burden. Not only that, these children are considered like a social stigma. It's kind of difficult to get them married, especially if they are like girls, etc. So for all those reasons, it's important to treat this condition. Next slide, please. So this is an X-ray, weight-bearing X-ray of the foot in an 8-year-old, showing how the bones deform over time if it's untreated, and it can also result in osteoarthritis of the joints of the foot around 30-40 years or so. Okay, and you can see how this girl is walking, and she has to have special footwear because she can't have regular footwear. So next slide, please. And that's how the bone becomes deformed. Initially, the bone is normal; it's just a soft tissue problem. But as the child grows, if it's not corrected, then the bones will also become deformed. Okay. So why are so many children all around the world untreated? Previously, the word neglected used to be used, but now we use like late presenting or untreated club feet. Okay. The reason is many of them, they are not aware that treatment is available. The parents, and maybe they don't have doctors that are trained in this method. And also, if the treatment may be available, it may not be available in the area where they live. It may be difficult for them to travel. And lastly, even if treatment is available, it may not be appropriate and may not be adequate. For all those reasons, we have a lot of untreated club feet. So, but if they are treated with the Ponseti method, you can see it can be very nicely corrected, almost looking like a normal foot, and the child is able to wear regular shoes and able to participate in all activities of daily living. And Ponseti's results from Iowa have showed like 30-year results and 50-year results that they're almost functioning like normal young adults, and even up to the age of 50 or more, they're almost 95% will have good results. And these results have been reproduced all over the world, not just in Iowa or in Ponseti's hands, but in other people's hands. As opposed to, so the Ponseti method is is not completely non-surgical. It's minimally, there is some surgery involved, but the surgery it remains outside the joint, so it doesn't damage the joint and the capsules, etc. As opposed to open surgical method, which was being used until the Ponseti method became popular. With that, the results they deteriorate with time, because when you cut the joint capsule, then damage the joint cartilage while correcting deformity, the long-term results have shown that about only 45% of them will do well in the long term. Okay. So as of now, there are various methods available, but world over, next slide please, the Ponseti method is the current gold standard. It's because it's easy, it's efficient, effective, and also cost effective and economical, and the results are reproducible all over the world. Okay. So Ponseti initially started, he was actually from Spain, and then because of the Spanish Civil War, during the Second World War, went to first Mexico and then made his way to United States to learn more. That was in 1948. He went to Iowa, and the professor there asked him to look at the results of Clubfoot treated by surgery. When he was looking at the follow-up of these children, many of them, almost all of them, didn't have very good results in the long term. So he was thinking, like, how can we make it better? And by chance, he managed to understand the anatomy and how the subtalar joint works, and he was able to discover this method by chance. And he started using this method in 1948, but he didn't publish his first paper until 1963. But then he was not a very good speaker, and there were other people who were promoting other methods of clubfoot treatment, like Hiram Kite. So he just quietly did his own work in Iowa and then kept quiet, and he retired in 1990. But he published a lot of papers as well, but none of his method didn't become popular because of that, because he was not able to promote it very well. But then in 1994, he came out of retirement because he got bored, and he wrote this book, which was published in 1996, on the treatment, fundamentals of treatment of congenital clubfoot. And people read this book, and then they wanted to learn from him. So a bunch of young pediatric orthopedic surgeons from all over the world went to meet him. And you can see, I want to point to Shafiq Pirani. He was originally from India. His ancestors were from India. They went to Uganda. He himself has polio, but he works in Canada, so he was very interested in this method and wanted to give something back to all over to Uganda and all over the world. So he went to him to learn. Dr. Harzenberg was another guy from US. This is Dr. O'Hara from UK. So they all went and learned from him. They started using it, and they started publishing their results. And also this 30-year results was published in the JBJS, that's the Journal of Bone and Joint Surgery from America. And following that, people got interested. And also these people started promoting it. So they sent their trainees. So for example, Dr. Harzenberg sent me and Ashish, when we went there in 2005 and 6, to Dr. Ponseti for a couple of weeks, for a week. And then we went back for some more training later. So we personally learned the method, like many of them did from Ponseti himself. And then we started using it, and we saw that, it was easily reproducible. It's a method which requires a little bit of attention to detail, but it's easily reproducible if you stick to the proper technique. Okay. And then Dr. Pirani did further work and showed very clearly using MRI and things how the method works. It depends on two things: the viscoelasticity property. Viscoelasticity is the property of the body. And it depends on the viscoelastic properties of the foot, because in a small child, everything is in cartilage, so it acts like a sponge. There's a lot of water in the cartilage, so because of that, you can easily mold it into shape. You must have noticed, like small children, they tap their head to mold it into place, right? So similarly, the foot as well is the same thing. You can easily mold it into a good shape, the correct shape. And he showed that very clearly with the MRI, which was published in, I think, 2001. And then following that, he started the Uganda Clubfoot project, where he was able to train people like bone setters in Uganda, and they could even treat it very well. So this program was well established. And he also developed a manual for use all over the world. So people started using it all over the world. Next slide, please. So currently, It's being used in more than 200 countries around the world, and it's the current gold standard treatment for club feet. So let's just briefly look at what it is. Essentially, it's not non-operative method. It's a relatively less operative method, or minimally invasive method, you can say. And it involves two parts. Okay, the first part is called, diagnosing the clubfoot, and then second part is called the casting part. Okay, that's the first stage of treatment. Serial stretch casting. We apply a long leg cast, and you starting from my good point, starting from the left side. That's how the foot is, and gradually over a period of 5 to 6 weeks, you gradually correct all the deformities. There's 4 deformities. It's called cave. Cave means midfoot cave. Cave means high arch in the middle part of the foot. We'll show you as we come. So you can point the caves. And then the forefoot adduction. A stands for forward adduction. That means the front part of the foot is turned in towards the midline. V stands for hind foot whereas that means the back of the foot is turned in. And then equinus means the ankle and foot is pointed down. So we start with cavus, that's the order of correction, and then adduction and varus are corrected at the same time. And then the last part is equinus. Okay? And the second part, once the casting is done, the only thing we can't fully correct is ankle equinus, so that's where about more than 90% of children require a tenotomy of the tendon Achilles. That's where the tenotomy comes in. And then after that, one final cast for 3 weeks. And then, so by 9 weeks, most of the club feet are corrected. Okay, that's part one. And then when the child comes out of the cast, we then start the bracing protocol. That's called stage 2. So in stage 1, the doctor does all the work, and the parents are helping him. In part 2, the parents have to do all the work because they have to brace the child. They have to kind of sort out. It's not easy, but doable. So, and we recommend bracing full time for 23 hours a day for the first 3 months. And then after that, part time starting from 16 hours per day during the first year, then 14 hours, then 12 hours, until about 5 years of age. Why 5 years? Because the growth happens very quickly, and a lot of growth happens in the first 5 to 6 years. After that, the growth kind of slows down, and also most of the recurrences or relapses happen 90% of the time before that age. After that, it's less. So that's why the recommended age is about 5 years when you can stop bracing if the foot is doing well. Okay, and go back, and then Ponseti published, not Ponseti, the people from his place published 30-year results, and then again Marquende and Ponseti published 50-year results, which show that about 90 to 95% of club feet can be well corrected, and then later the results are maintained at 30 and 50 years. Almost 78 to 80% are continue to do well. Okay, so and then mostly the surgery. Some patients may require what is called as a tibialis anterior tendon transfer if they relapse. Some other minor surgeries, but for the most part, 75 to 80% of them will do really well even at 50 years, and they can do almost everything. Okay, next slide. So the foundation, Serve Together Foundation's mission is to make the society free of children with clubfoot. Okay. You can all come forward here. There's lots of empty chairs. Okay, so the aim of all the public health Ponseti mission is like public-private initiative, and also build awareness in the community as well as in the doctors that this treatment is available, and then build capacity like training like we are having today. Train the doctors and also the public health workers in recognizing, diagnosing clubfoot and treating it. And lastly is review mechanism to follow up the children till they are fully grown. Okay. So currently, I think in 2021 they started with 3 clinics, and in 2021-22 we were able to extend it to about 10 clinics. I think currently we are still, even though we're still at 10 clinics, and the aim is to provide treatment for about 750 children, but eventually the goal per year. So eventually the goal is to reach about 1,500 children over the next 2-3 years per year. Okay. I think currently we have clinics in 10. We have 10 clinics in 10 districts. It's not yet covering all the 30 districts, but I think Cure also has about I think 14 districts. Their clinics are available, but only 6 districts are not yet covered in Karnataka at this point. Okay, and these are different organizations that are helping us. So, thank you. Do you guys have any questions? If you all want, you can come to these chairs. Unfortunately, this is what we have currently. And also, can you all see? Okay. I think these PowerPoints also will be sent to you, so you can also go through them in your own time. So you don't have to write anything down. Okay. And the main key is the workshop, which we will be demonstrating. That's the key things. Okay.
Gopi? Scoring and should we? Okay. We'll proceed.
I think I can have Dr. Mohan here. Can we have Dr. Mohan over here, the Chief Medical Advisor for Serve Together? Well, ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. Probably orthopedicians ಎಷ್ಟು ಜನ last year ಬಂದಿದ್ರಿ? I think I have few hands going up. One, ಒಬ್ಬರೇನಾ? ಇಬ್ರು? Okay. At the outset, we really thank you because you had a long journey. ಕೆಲವರು ರಾತ್ರಿ travel ಮಾಡಿರ್ತೀರಿ, ಬಂದಿರಿ. Thank you so much for having come till here. We still hope that the number will start increasing. Yeah, very good morning. I'm Dr. Veena, the Deputy Director for RBSK, RKSK and the Health and Wellness Center. ಎಷ್ಟು ಜನಕ್ಕೆ Health and Wellness Center ಬಗ್ಗೆ ಗೊತ್ತಿದೆ orthopediciansಗೆ? Anybody knows about Health and Wellness Center? No? Very pathetic. Anyways, how many know about RBSK? Few hands going up very slowly. RBSK? It's there since 2013 onwards. Okay, how many of you know RKSK? Full form ಗೊತ್ತಿದ್ಯಾ? RBSK, the full form. Orthopedic. Perfect. Thank you so much. Well, I thought we'll have one round of brief introduction to know ಯಾವ district in the ಜಿಲ್ಲೆಗಳಿಂದ ಬಂದಿದ್ದಾರೆ ಅಂತ. Can we start from here? So please sit down. From Raichur. Okay. Salahuddin. You are from the district hospital. You are from Sindhunur Taluk Hospital. Okay, please. Yeah. Sira. Okay. Dr. Suresh. Yes. Thanks, Dr. Suresh, for coming. So I have Suresh Square here from Chikbalapur. Okay. You are from Hubli. Okay. Kim's Hubli. Okay. Shimoga. Yes. ಹೊಸನಗರ ಈಗ ಬಂದಿದ್ದಾರೆ ಒಬ್ರು. ಮುಂಚೆ ಅವರು ಆಯುರ್ವೇದಿಕ್ ಡಾಕ್ಟರ್ ಅಷ್ಟೇ ಇದ್ರು ಹೊಸನಗರದಲ್ಲಿ. It's complete because he was running the show for almost about 8-9 years alone. If you know the history. Yes. Excellent. You have a new building also that's come up. Okay, you're from Kolar. Okay. Kalagatli, Dharwada. Okay. Dharwad, okay. You must be knowing then, Dr. Shrikant. There is something called DEIC in Dharwad. Gotila. Very pathetic. You have a district early intervention center in Dharwad hospital. Ali makkalige refer aagta ilva. Matte DEIC andre gottilla. Please go back and check because a lot of people will require your help. Fine. Yeah. Okay. We also had invited people from Pavagada. Nobody has come. We thought that's a far reachable, like, you know. If I'm correct, Suresh? Ha, Bandila. Okay, okay. Fine. Can I have the next person to introduce, please? Ramnagara. ನಾನಿದ್ದಾಗ ನೀವು ಇರಲಿಲ್ಲ ಅನ್ಸುತ್ತೆ. When I was a nodal officer, I've never seen you in Magli. You've recently come, okay. Again, you're new on Dr. Anil? Okay. Chenpatna, okay. Mulubagal. So we have Mulubagal, Malur from Kolar district. Correct? Chikbalapur and the Shidlikatta and the Bandidare? Okay. Ha. The next one. From Koppal. Navalgund. Okay. Okay, thanks. Yes. I think you must be having a load of cases over there. Shikaripura. Okay. You two were not there when I was a nodal officer at Shimoga. You're on deputation there. Okay. Okay, nice. Sirsi. Okay. Ankola, again Uttar Kannada. Okay. Bhatkal. Okay. Gadag. Okay. Fine. I couldn't have the introduction of the guest speakers. I think we have Dr. Abhishek and Dr. Ashish there. Yeah. Yeah. Thank you so much for having accepted our invitation and come down today to train our doctors. Thank you so much. Okay. ಎಲ್ಲರೂ ಎಷ್ಟು ಜನ ಐ ವೆಲ್ಕಮ್ ಡಾಕ್ಟರ್ ಮೋಹನ್ ವಾಸ್ ಆ್ಯಕ್ಚುಲಿ ದಿ ಚೀಫ್ ಅಡ್ವೈಸರ್ ಫಾರ್ ಸರ್ವ್ ಟುಗೆದರ್. We've heard your voice over last time, I think, over the virtually we had met you. It is really a good pleasure to see you today, and we are expecting our mission director to join us anytime. Before that, a small little trick in the morning. ಎಲ್ಲರೂ ಲೆಮನ್ ಸ್ಪೂನ್ ಆಡಿದ್ದೀರ ಆಟ ಯಾರಾದರೂ ಚಿಕ್ಕ ಮಕ್ಕಳಿರುವಾಗ? ಎಲ್ಲರಿಗೂ ಗೊತ್ತಿರ್ಬೋದಲ್ಲ ಲೆಮನ್ ಆ್ಯಂಡ್ ಸ್ಪೂನ್ ಆಟ. ಆಟದ ಮುಖ್ಯ ಉದ್ದೇಶ ಏನಿದೆ ಅಲ್ಲಿ, ಅಂದರೆ ಆಟದ ಗುರಿ ಏನಿದೆ ಅಲ್ಲಿ? ಫಸ್ಟ್ ಬರೋದಲ್ಲ ಅಲ್ಲಿ. ವಾಟ್ ಈಸ್ ಇಂಪಾರ್ಟೆಂಟ್ ದೇರ್ ಈಸ್ ಟು ಕ್ಯಾರಿ ದ lemon till the last the mind. Then what is the difference between that of an achievement and a success when you take this lemon and spoon race? If anybody can explain. Lemon and spoon race alli yavadu achievement yavadu success? Achievement is? Okay. Anybody else who can improve on it? Correct. Now, how do you correlate that with life? Correct. Then, which is achievement? What is achievement and what is the success then? Is there a difference between achievement and success? If you all agree, correct? Anybody else? Anybody else? Say, for example, people say, yes, I achieved a gold medal. That is an achievement. What is a success is to carry that lemon, balancing it and reaching there is a success in life. So what I mean to say, a small note why I started this today in life is that everybody needs to have a quality life. All of us deserve to have a quality life. Similarly, the children, whether born with a clubfoot or any other deformity at birth, also we should ensure that in our journey of life, we ensure that they also become successful, so that a care is taken right from the time of birth and they reach their life with a quality way. So this is where I feel that an achievement difference from that of a success. So we need to concentrate on success and not achievement. Achievement can be today's example. Today you have won some award or something. Achievement for this year. But after some time that becomes old. Later you try to target another one. Whereas success, what I thought I'll start with a brief note of a difference between that of an achievement and success. Well, most of us don't even have time to think of what I'm doing this morning, what I'm doing till evening. We start a day as early as maybe 5 o'clock in the morning, and by the time we reach home, when I take into my consultation, 9:30 I reach home, till 9 I'm in the office. And I feel, what have I done at the end of the day? Am I only running behind files? Am I really doing a quality life? So this is what I put a question mark to myself, but I try to find happiness in whatever I do, whatever work I do, yes, I try to find the happiness. So this is where probably I'm trying to find myself successful in whatever given possession. I think it's the same with all of you, including Dr. Mohan. We have no time to enjoy if the birds are chirping. I've never heard it in Bangalore. Maybe I'm not concentrating on that. Maybe there are birds which are chirping, but ನಾನಂತೂ ಯಾವತ್ತೂ ಕೇಳಿಸ್ಕೊಳಕ್ಕೆ ಟೈಮ್ ಇಲ್ಲ. ಯಾಕೆ ರಸ್ತೆಯಲ್ಲಿ ಕೂಡ ನನಗೆ ಫೋನ್ ಕಾಲ್ಸ್, ನನ್ನ ಮೊಬೈಲ್ದ ವಾಟ್ಸಪ್ ಯಾವುದೋ ಒಂದು ಮೆಸೇಜ್. ನಾನು ಒಂದು ಸಲ ಅದು ನೇಚರ್ನ ಎಂಜಾಯ್ ಮಾಡಿದ್ದೀನಾ ಅನ್ನೋದು ಕೂಡ ಒಂದು ಸಲ ಯೋಚನೆ ಮಾಡಬೇಕಾಗತ್ತೆ. ದಿಸ್ ಮಾರ್ನಿಂಗ್ ಐ ವಾಸ್ ಟೆಲಿಂಗ್ ಮೈ ಡ್ರೈವರ್ ವಾಟ್ ಅ ಪ್ಲೆಸೆಂಟ್ ವೆದರ್ ಅಂತ. ಅವಾಗ ಹೇಳ್ತಾ ಇದ್ದ, ಮೇಡಮ್ ಫಸ್ಟ್ ಟೈಮ್ ನೀವು ನನ್ನ ಹತ್ರ ಮಾತಾಡ್ತೀರಿ, ಇಸ್ ದೇರ್ ವಿತ್ ಮೀ ಫಾರ್ ದ ಪಾಸ್ಟ್ 2 months. ಇವತ್ತು ಫಸ್ಟ್ ಟೈಮ್ ಮಾತಾಡಿದ್ರೆ ಮೇಡಮ್ ಪ್ಲೆಸೆಂಟ್ ವೆದರ್ ಅಂತ. ಸೊ ದಟ್ಸ್ ಹೌ ವಿ ಆಲ್ಸೋ ಡೋಂಟ್ ಬ್ಲೆಂಡ್ ವಿತ್ ದ ನೇಚರ್. So I think let us all make it that way, that we blend with nature, be with nature, and ensure that everybody is also enjoying it. Okay, moving further. Now, what is the vision and mission of me calling all of you over here? I have a vision for Karnataka. Like I had a mission for cleft lip, wherein we were successful in making 1,000 smile Karnataka ಅಂತ the project 1 ವರ್ಷದಲ್ಲಿ ಮಾಡಿದ್ವಿ. 1000 ಜನ ಮಕ್ಕಳು ಯಾರಿಗೆ cleft lip ಇತ್ತು ಅವ್ರಿಗೆ ಕಂಪ್ಲೀಟ್ ಸರ್ಜರಿ 1 ವರ್ಷದಲ್ಲಿ ಮಾಡಿದ್ವಿ. That was a goal of Karnataka. So this time, for this year, I have moved ahead to do at least 1,000 Clubfoot surgeries in Karnataka, and my final vision is that to ensure that it is a Clubfoot free Karnataka. Madboda? Haga madbekadre, I need all your support. A support could be right from the intra-departmental support, or it could be from the intersectoral, it could be a private or a public. You agree with me? So we need to coordinate and do the work to achieve this particular vision. Then in case I have a vision like this, how do you really achieve the mission then? Mission cannot be done alone. Can anything be done alone? Whether you are all orthopedic surgeons, ನಿಮ್ಮ ಓಟಿನಲ್ಲಿ ಹೋದಾಗ ನೀವು ಒಬ್ಬರೇ ಮಾಡಲಿಕ್ಕಾಗತ್ತಾ? ಇಟ್ಸ್ ಅ ಟೀಮ್ ವರ್ಕ್. ಸೊ ಲೈಕ್ವೈಸ್ ಇವನ್ ಅ ಕ್ಲಬ್ ಫುಟ್ ಇಸ್ ಅ ಟೀಮ್ ವರ್ಕ್ ವೇರ್ ಇಟ್ ಹ್ಯಾಸ್ ಟು ಬಿ ಫಸ್ಟ್ ಆ್ಯಂಡ್ ಫಾರ್ಮೋಸ್ಟ್ ಅವೇರ್ನೆಸ್ ಕ್ರಿಯೇಟ್ ಮಾಡಬೇಕು. ಜನಕ್ಕೆ ಗೊತ್ತಾದ ಮೇಲೆ ಅದರದ್ದು ಐಡೆಂಟಿಫೈ ಮಾಡಲಿಕ್ಕೆ ನನಗೆ ಗ್ರಾಸ್ ರೂಟ್ ಲೆವೆಲ್ ವರ್ಕರ್ಸ್ಗೆ ಅವ್ರು ರೆಡಿ ಇರಬೇಕು. ದೆನ್ ಕಮ್ಸ್ ದಿ ಪಿಕಿಂಗ್ ಅಪ್ ದ ಕೇಸ್ ಬೈ ದಿ RBSK ಡಾಕ್ಟರ್ಸ್ or whoever it is, or the child born at your own facility. Train your pediatricians, train your staff nurses. They pick it up and then the case goes for an early intervention. Who would like to undergo surgery? Whether small or big. If you can imagine the mental trauma a mother or the father has to undergo for a minute surgery also, it is unexplainable. You agree with me? So instead, when you identify it earlier, there is something called a gold standard treatment for a clubfoot, and that is called Ponseti. In the journey of my vision, when I got to know that I'll not be able to achieve it alone, we started having hands with the so-called Serve Together Foundation. So last year, in the month of June, if I'm correct, Gopi, last Feb 22, we had an MOU. And last year, I think we could do about 473 cases. Well, when I look into the total cases in Karnataka, it comes to around 2,200 cases is there in Karnataka as on today. And the RBSK teams have identified about 1,620 cases last year. So till date, I have these number of cases. So I thought maybe single-handed with Serve Together, I may not be able to reach the goal of covering 2,200. I'm extending my tentacles even to the private hospitals, private institutions. Yelli agli delivery aadre, we are ready to do it free of cost, including cleft lip, cleft palate. Free surgery. Remember, the transportation is also paid for the parents. One day, the food kuda now cleft lip alli kodthivi, but cleft foot right now they're just budding. So these treatment given at the government hospital with the available resources like your plaster of Paris, whatever it is, the Serve Together, they have agreed to give us one counsellors at the district level, and we have got a good networking, how to pick it up, refer, comes to the facility wherever you are. So the first step is that to ensure that you're all trained in Ponseti method and you really do it, and at the end of the year, probably, I hope, we'll all be happy to showcase that Karnataka can do or could do 1,000 Ponseti methods. Can you all Can we all pledge today that we can do it to the level possible? Right? Yeah. So this is my vision and mission to go ahead. I thank Serve Together Foundation who were keen enough. They started with 5 centers and today they are ready to take up for 10 districts. They have extended their support to 10 districts. There could be some glitches in between. ನಮಗೆ ಸ್ವಲ್ಪ ಕೌನ್ಸಿಲರ್ ಶಾರ್ಟೇಜ್ ಆಗ್ಬೋದು, ಪ್ಲಾಸ್ಟರ್ ಆಫ್ ಪ್ಯಾರಿಸ್ ನಮಗೆ ಹಾಸ್ಪಿಟಲ್ ಇಲ್ಲದೇ ಇರ್ಬೋದು, ಅಥವಾ ಮಗು ಬರುವ ಟೈಮಲ್ಲಿ ಡಾಕ್ಟರ್ ರಜದಲ್ಲಿ ಇರ್ಬೋದು. Whatever could be the glitches, I think we need to really close that gap and ensure that every child leads a quality life. With few note, I think I'll leave it to Dr. Mohan if you want to just speak, because once MD comes, probably he will be addressing you. So thanks a lot, and I wish you all the very best for the rest of the session.
Thank you, ma'am. Thank you.
Thank you for the kind words, and thank you all for coming here. So like I said, I would like to thank Dr. Veena N, Deputy Director for RBSK, as well as Dr. Naveen Bhatt, the IS Officer and Medical Director for the National Health Mission, for working with Serve Together and hopefully starting the program where we can rid or have a state where there's no child with clubfoot. They've all been fully addressed and treated. So currently we are working to bring world-class care for children with club feet. And in future, we hope to extend this kind of treatment to all children with musculoskeletal disabilities, with both public and private support. And then thank you all for working with us. Our aim is to reach the unreached and provide family and patient-centered care at their doorsteps. Okay. So currently, I think the main focus is, in addition to the casting treatment, we are currently using something called as the stain-baked brace, because bracing is an important part of, like I said, the second part of clubfoot treatment. That is not as well tolerated by the patient because it's not comfortable. So currently we are working with Iowa Clubfoot Solutions bracing company to bring that brace here. And currently I think Serve Together is the distributor for all over the country, and hopefully we aim to provide this brace which has a better compliance rate, has demonstrated better compliance in various families and patients all over the world to the people here at as low cost as possible and preferably free, but we're working towards it. So thank you all for coming here. So can we proceed? Thank you.
Hello. Yeah. So now we'll move ahead and talk a little bit on pathoanatomy of clubfoot. So before we understand the proper technique on how to correct, we need to understand what is the pathoanatomy and what is the mechanism that goes behind the whole Ponseti's technique. So I'll not go into the anatomy, most of us know it. So basically what is clubfoot? There are 4 main components, that is cave, as already told by Dr. Mohan, C for cavus, A for adductus of the midfoot, V for varus of the hindfoot, and E for equinus of the hindfoot. So here you can see that there's a cavus, which can even be seen in this. Then you have the forefoot or the midfoot adductus, and the heel varus. You can observe the heel in varus here. And then you have the equinus of the hindfoot. So these 4 are the components of your clubfoot. Now this is the model, this is the dissected specimen which was dissected by Ponseti himself, where you can see that there is a severe tibiotalar plantar flexion with medial inclination of the talar neck, and then there's severe displacement of the navicle with wedging of the navicle. The shape of the navicle changes, and eventually there's medial displaced cuboid, and the cuboid shape changes. There's adducted and inverted calcaneum lower down there, and you can notice that the shape of the head of talus is changed into more of a wedge shape. So all these are the bony changes that take place in a clubfoot. So the same thing was demonstrated by Pirani through various MRI imaging, where you can see the tala neck is medially inclined, the heel being in varus, and there's oblique calcaneocuboid relationship, and there is a navicular dislocation from the tala head, which is seen in this MRI. So if untreated, they end up with a permanent or a more bony deformity, which tends to become permanent and difficult to correct later on. So coming to the pathoanatomy and mechanics, three things that you need to understand. One is something known as carpopedal unit, acetabulum pedis, and certain kinematic couplings, which we'll cover in the next 5 minutes. So first coming to something known as carpopedal unit. So what is a carpopedal unit? So carpopedal unit includes all the bones apart from the talus. So the talus you can see is marked in grey or black here, and all the other bones that surround the talus, that is the calcaneum, the cuboid, the cuneiforms, and the metatarsal together, they form a carpopedal unit. Now why is it called a carpopedal unit? It is because the function has a unit, they move together. So when you, we'll show it you in the subsequent demonstration, when you move the foot during your Ponseti method, if you observe in the skeletal model that comes around, all the bones move in synchrony with each other, except for the talus. So that's why it is known as a carpopedal unit. So it's similar to the hip joint where you have the femur head and the acetabulum. So similarly, all the bones around the talus is like the femur head here in the foot, and the remaining bones, that's the articular surface of the navicle and the calcaneal, they form the acetabulum. So this is the second point where I told it's known as acetabular pedis. So it mimics the acetabulum in the hip joint. So the calcaneopedal block forms the acetabulum, and the talus forms the femoral head component in the acetabular pedis. So we'll just stop for 5 minutes, the director has come, and then we'll continue. So we'll just continue till Sir comes in. So two things, calcinuclear block and acetabulum pedis. So having understood that, so all of you all I'm sure know what are the movements that happen around the ankle. But the most important what we need to know is what is supination and pronation. So supination is a combination of three movements that's happening. One is the adduction. You all can all do it in your own foot and check it out. So there's adduction happening along with flexion and inversion. So that is supination. In supination you have adduction, flexion and inversion. Whereas in pronation you have abduction, extension and eversion. So this is the most important movement that you need to understand to know the dynamics that's happening in the foot. So having known Okay. So having known that, Ponseti basically used all these advantages of all these kinematics and the unit to have a better outcome and better result. So moving ahead, so almost all motions of the foot around the ankle happens around the talus. So if you see in all the models that's being passed around, you can see talus is more or less in its fixed position and all the movements happen around it. The whole foot revolves around the talus. So including your ankle joint, the talocalcaneal, the subtalar joint or the acetabulum pedis, everything moves around the talus. So having understood that, so we will first move to one of the drills where you can place your thumb over the talar head and then you can one. So and slowly try to abduct the foot. So keep your thumb over the talar head and slowly try to abduct or dorsiflex. We'll just stop for 5 minutes and then continue.
So it's not like this, it's more like this. So
We'll at least make Clubfoot free Karnataka. And for this year's goal, we have 1,000 Clubfoot Ponseti markets. And as a mission mode, we have joined hands with the NGO so that we'll be able to counsel, then also create awareness in the public and ensure that the ASHAs, the BHCOs and the RPSK doctors can pick up the cases at the earliest in the ground. Similarly, when the cases are referred to the district or taluk level hospitals, our pediatricians are ready to do the Ponseti method. So this is the mission. Hence today we have orthopedicians from 10 districts who have come here today, because served together is going to cater the service to 10 districts. So looking into these statistics as per the prevalence in Karnataka, so we have about 1 in every 750 cases is a Clubfoot case. And the RBSK figures shows that it's been an increasing trend. Well, in 2021 we had about 1,119 cases, while in 2020 we had 1,622 cases. So when I looked at the 2,200 cases, we are able to cover 2/3 of the cases through RBSK, both extending our services to private as well as to the public. So everybody is coming down for a Ponseti method. So we thought like this is a one good way where we can help the public by joining hands with NGOs. So this is the reason why we have organized one-day workshops. So we welcome you for this particular workshop. And Gopi, as a can you give us, sir?
I request Dr. Mohan and Dr. Ranade to also come forward. Sir, I would like to introduce you Dr. Mohan V. Bellantur, basically from Bangalore, settled in USA Phoenix University. He is vast experience in this pediatric orthopedics, and he is our medical advisory board. And honorably he is coming and helping us in the training, teaching the doctors and all other things. Please welcome Sir Dr. Mohan. Dr. Ashish Ranade from Pune. He is one of our close friends as well as a very good co-workers in many conferences. So great pleasure that he is with us. Dr. Abhishek is from Bangalore. Three are the faculties today. So please sit, sir. So with this, I request Dr. Mohan Bellantur to give a small sample to the sir. Thank you.
Inaugurate this session by watering a plant. This will commemorate to say that when we try to water the sapling or a plant, it grows to a good tree. Likewise, we ensure that there is a quality life led by every child that is born on this earth. I request our mission director sir to kindly address the gathering.
Good morning, everyone. First of all, I would like to thank the Foundation for joining hands with NHM Karnataka and making sure that we can address the Clubfoot cases not just in and around Bangalore but in all the districts of Karnataka. As has been told by our program officer that we have roughly around 2,200 cases being detected, being prevalent in Karnataka. The fact is that we have been able to cover only 1,600 cases in the previous year, and before that we were covering 1,200. While there may be another 20 to 25% people who may be affluent enough to take the treatments in any private facility, but still we are missing out, losing out another 25% of the cases every year. The problem is that what I have seen in the previous medical curriculum also before when I was a doctor, that the older the child grows, the difficulty to correct the clip is also difficult. And the quality of life, it won't guarantee 100% correction, and there may be some residual likeness present over there. So we need to catch them all and we need to catch them young. For that we need to train all the doctors, especially in the government as well as the voluntary private doctors in these facilities, so that we can cover all the Clubfoot people. I think we are also having another integration with one more NGO. And we have been, I'm really happy to say that in the last year we were covering nearly around 14 to 16 districts. But now this year we are covering all the 31 districts and training all the doctors of those districts. So that every district will be having such pockets of doctors who can treat them locally. The issue which we were facing is that the commutation issue for the patients, the poor patients' parents, and also the loss of livelihood for 1 or 2 days when they had to bring the parents regularly. So to correct that, we have been spreading our wings and we have got gracious help from the voluntary organizations like Serve Together who have been training our doctors and building the capacity so that we can go back and treat the patients in a much more easy, faster and much more effective way. So I also thank all the doctors who have come from all the districts of Karnataka, and I wish that you take full utilization of the training and also go back and use this training and do wonderful operations. Thank you.
Thank you so much, sir, for your time and your continuous support for us. It is a great encouraging to work with the NHM, and that is a dream that we want to reach every district, not only that, every taluk also to occupy this method and move forward. Sir, we have some beneficiaries. If you have time, I can ask one person to speak about it. They are from KC General Hospital, Nagama. So they are all the way coming from near to Mysore.
Good morning, all doctors and ma'am, sir. I am Nagamma from T Nursepuram, Mysore. ನಮಗೆ ಮಗುಗೆ ಫಸ್ಟು ನಮಗೆ 5 ತಿಂಗಳ ಸ್ಕ್ಯಾನಿಂಗಲ್ಲಿ ಈ ಥರ ಮಗುವಿಗೆ ಆಗಿದೆ ಕಾಲು ಅಂತ ಗೊತ್ತಾದಾಗ ನಮಗೆ ತುಂಬ ಭಯ ಆಯಿತು ಏನು ಮಾಡೋದು ಅಂತ. ಸೊ ಆಮೇಲೆ ಡೆಲಿವರಿ ಆದಮೇಲೆ ಡಾಕ್ಟರ್ಸ್ ಎಲ್ಲ ಸರಿಯಾಗುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರು. ನಮಗೆ ಎಲ್ಲಿ ಒಳ್ಳೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡಿಸಿ ಸರಿಯಾಗುತ್ತೆ ಅಂತ ಗೊತ್ತಾಗಿಲ್ಲ. ನಮ್ಮ ಹಸ್ಬೆಂಡು ಗೂಗಲಲ್ಲಿ ಸರ್ಚ್ ಮಾಡಿದಾಗ ಸರ್ ಟುಗೆದರ್ಸಲ್ಲಿ ಸರ್ ಗೋಪಿ ಸರ್ ಕಾಂಟ್ಯಾಕ್ಟ್ ನಂಬರ್ ನಮಗೆ ಸಿಕ್ತು. ಸರ್ ಜೊತೆ ಒಂದ್ಸಲ ಮಾತಾಡಿದಾಗ ಸರ್ ನಮಗೆ ಧೈರ್ಯ ಹೇಳಿದ್ರು, ನಿಮ್ಮ ಮಗು ಕಾಲು ಹೇಗಿದೆ ಅಂತ ನಿಮಗೆ ಗೊತ್ತೇ ಆಗಲ್ಲ, ಆ ರೀತಿ ಚೆನ್ನಾಗುತ್ತೆ ನಮ್ಮ ಫೌಂಡೇಶನಿಂದ ನಮ್ಮ ಬಂದು ಮೀಟ್ ಮಾಡಿ ನೋಡಿ ಅಂತ ಸರ್ ನಮಗೆ ಒಂದು ಧೈರ್ಯ ಹೇಳಿದ್ದಕ್ಕೆ ನಾವು ಬ್ಯಾಂಗ್ಳೂರಿಗೆ ಅಡ್ರೆಸ್ ಹೇಳಿದ್ರು. ಬಂದು ಗೌರ್ಮೆಂಟ್ ಹಾಸ್ಪಿಟಲ್ ನಮಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಎಲ್ಲ ಕೊಡಿಸಿ ನಮ್ಮ ಮಗು ಕಾಲಿಗೆ ಚೆನ್ನಾಗಿದೆ. ಥ್ಯಾಂಕ್ಸ್ ಗೌರ್ಮೆಂಟ್ ಆ್ಯಂಡ್ ಸರ್ ಟುಗೆದರ್.
ಇಂದ್ರ
ಗುಡ್ ಮಾರ್ನಿಂಗ್ ಸರ್. ನಾನು ಫಸ್ಟ್ ಸ್ಕ್ಯಾನಿಂಗ್ 3 ತಿಂಗಳು ಸ್ಕ್ಯಾನಿಂಗ್ ಇದ್ದಾಗ ನನಗೆ ಏನು ಗೊತ್ತಾಗಲಿಲ್ಲ. ಆಮೇಲೆ ಡೆಲಿವರಿ ಆದಮೇಲೆ ಪಾಪ ಇದೆ ಅಂತ ಗೊತ್ತಾಯಿತು. ಅದು ಸ್ಕ್ಯಾನಿಂಗ್ ಆದಮೇಲೆ ಆಮೇಲೆ KC ಜನರಲ್ ಆಸ್ಪತ್ರೆಗೆ ಹೋಗಿ ಬರ್ಕೊಟ್ರು. ಅಲ್ಲಿ ಹೋಗಿ ತೋರಿಸಿದಾಗ ಡಾಕ್ಟರು ಟ್ರೀಟ್ಮೆಂಟ್ ಇದೆಲ್ಲ ಕೊಟ್ಟು ಸರ್ಜರಿ ಮಾಡಿ ಮಾಮೂಲಿ ಶೂ ಆ ಥರ
ಸರ್ಜರಿ ಮೀನ್ಸ್ ಟೆನೋಟಮಿ ಮ್ಯಾಮ್. ಟೆನೋಟಮಿ
Hi, good morning all. Very good morning. ನಮ್ಮ ಮಗುಗೆ ಸ್ಕ್ಯಾನಲ್ಲಿ ಹೇಳಿದ್ರು 5 ತಿಂಗಳಿದ್ದಾಗ ಈ ಥರ ಕ್ಲಬ್ಫುಟ್ ಇದೆ ರೈಟ್ ಲೆಗ್ ಅಂತ. ಅವನು ನಮಗೆ ಫುಲ್ ಟೆನ್ಷನ್ ಆಗಿತ್ತು. ಆಮೇಲೆ KC ಹಾಸ್ಪಿಟಲ್ ಡೆಲಿವರಿ ಆಯಿತು. ಆಮೇಲೆ ಅವರು ಅಲ್ಲೇ ಹೇಳಿದ್ರು ಈ ಕ್ಲಬ್ಫುಟ್ ಫ್ರೀಯಾಗಿ ಮಾಡ್ಕೊಟ್ಟು ಸರ್ವ್ ಟುಗೆದರ್ ಟ್ರಸ್ಟ್ ಅಂತ. ಸೊ ಗೌರ್ಮೆಂಟ್ ನಮಗೆ ತುಂಬ ಹೆಲ್ಪ್ ಆಗಿದೆ. ಮಗು ಕಾಲು ಸರಿ ಹೋಗಿದೆ. ಹಾಂ ಸರಿ ಹೋಗಿದೆ ಸರ್. ಥ್ಯಾಂಕ್ಸ್ ಟು ಗೋಪಿ ಟ್ರಸ್ಟ್.
Thank you. So we have a number of cases like this, sir. I want to bring you a notice this recently. 10 days back, we received a baby in Kolar District Hospital, where the baby thrown out in front of an orphanage because of Clubfoot. When they identified and trying to counsel them, very sad that by birth only babies like that, where they can give a life, we don't want like that, they rejected. But the RBS team contacted me, now baby is under care and the orphanage is taking care. It is a golden job, like no, we are changing not only the treating the Clubfoot, we are giving a life to that. So thank you so much. With this note, I request sir you to extend mementos to the faculty. So Dr. Mohan Belendur, please. Thanks sir for your support in your busy schedule. You are always helping us. So Naveen, come here. Dr. Ashish Ranade. So they are always available for us in many suggestions and how to take forward. Dr. Abhishek. So, sir, we are aiming for every doctor in Karnataka to be benefited in this training. And the second line, we are looking for the every district have 2 or 3 pioneer doctors on this method, and every 10 doctors will be training for the trainers. Dr. Abhishek is one in that. In the line, they are under the Mohan sir supervision. So not but I want to extend my sincere thanks to Dr. Veena for please accept our small token of love. So she is always suggesting, guiding. Thank you so much, ma'am. Sir, we please release the 10 clinics list, sir. Thank you, sir.
So we'll go ahead. So first demonstration that we wanted to do is something known as calcaneopedal block. So if all of you all have the model there, you all can place your thumb over the tala head. So with your thumb over the tala head, if you abduct the foot, as you can see in this video, you can notice that all the bones around the talus moves. They move together as a unit, except for the talus. All the other bones move as a unit. So that is known as a calcaneopedal block. And this has been utilized by Ponseti in correcting the clubfoot. So moving ahead, yeah, the same thing shown in a different angle, if you can notice. So correction of the rear foot with this carpopedal unit, correction of the rear foot and the midfoot can be accomplished by just abducting the forefoot. So you need not touch the hind foot or the calcaneum to correct the heel varus or the equinus, or just correcting the forefoot adduction will help you correct the hind foot varus. So there's something known as kinematic coupling. This was about the carpopedal unit. Now coming to a kinematic coupling. So imagine this was defined by Fobov in 1872. So it's like a boat which is sailing in a sea, a turbid sea. So there are multiple movements happening at the same time, if you can imagine that. So there is a row, yaw and a pitch that happens in the boat, as you all can see in this video. So you can see the boat is moving in multiple directions at the same time. There is a pitch, there's a yaw, and there's a tilt that is happening at the same time. So similarly, when you're doing certain movements in the foot, there are other coupled movements that happen without you having to actively correct it. So similarly, we are going to use those kinematic coupled movements to help correct the clubfoot. So the first movement is, with abduction, the foot goes into eversion. With abduction, the foot goes into eversion. So you are actually keeping a supinating force and abducting at the same time. So when you are abducting, you will notice that the forefoot goes into eversion by itself, even without you having to put it into eversion. So you are giving a apparent supination force continuously as you abduct, but the kinematic coupled movement will bring the foot to neutral. So the same thing can be observed in this video. So as you abduct, you can see that the foot is coming into eversion from supination. That is, it is coming to a neutral position even without.
Just one thing I want to point out, the position of the hand, that just to show you, but it should ideally be in line with the foot. So when you're doing it in the patient, it should not be as shown here. The right hand, it should be more in line with the foot.
Yeah, this is just to demonstrate here. This is not how we hold it when we are casting. So that we'll show it to you in the subsequent talks. So the same thing can be seen in CT imaging also. As you abduct, the foot goes into eversion. So as the foot is abducted, the inversion or the apparent supination spontaneously corrects to neutral. So this is the first kinematic coupling that you need to understand. And why we don't pronate is the foot itself takes it into eversion. So we don't actively pronate never pronate a clubfoot. The foot kinematic coupling will bring it to neutral by itself despite your supination force. So the second kinematic coupling that we need to know is with abduction, your heel varus corrects or becomes valgus, comes to neutral. So if you can see in this video, as you abduct the forefoot, I think the video is not playing, so I'll just demonstrate it on the model. So as you can see, as I abduct the forefoot, I'm not touching the heel. So this is the second kinematic coupling. As I abduct, you can see the heel from valgus going into a neutral to valgus position. This is me without having to touch the calculation. So this is the second kinematic coupling. So from varus to valgus. So this is the second kinematic coupling. So the heel spontaneously comes out of varus as the foot is abducted. So this is one of the deformity that we want to correct. So it is kinematically coupled and it corrects with abduction. So and then we have the final kinematic coupling, that is abduction and extension. So as you abduct, if you all notice the subtalar joint, as you abduct, you all can notice that the calcaneum goes, subtalar joint goes into extension. So you all can see it here. So if you all can notice it here, as you're abducting, the calcaneum is coming into extension. So the subtalar joint is going into extension. This is the third kinematic coupling. So as you abduct the foot, the subtalar joint goes into extension. So this is important why you have three other movements which are kinematically coupled with abduction, and abduction becomes very important, especially when you're doing your Ponseti method. Ensure that you get adequate abduction. That's what we say, get abduction of almost 50 to 70 degrees in newborns, so that you can activate all the three kinematic couplings, and which in turn corrects the other deformities. So by abducting, you're correcting your heel varus, you're correcting the supination force, as well as you're correcting the equinus. You're bringing about extension in the subtalar joint. So without adequate abduction, there is still going to be some remnant deformity which might not be corrected and might end up with a recurrence later on. So this is important to understand the three kinematic couplings. So this is the same thing which I told. With abduction, you can see that there is extension happening. So finally, the last drill that I want to show is something commonly known as Kite's error. So this is when you block the calcaneum from moving. So what Kite did was, he blocked the calcaneo-cuboid joint or the calcaneum from moving. So when you block this and try to abduct, you're blocking literally all the dynamic, the coupled movements. So when you block the calcaneum, you can see it doesn't move from varus to valgus, and even the extension is blocked. So Kite's error was that he blocked the kinematic coupling by keeping his thumb or the hand over the calcaneo-cuboid joint. So these were the kinematic coupling. So what you need to know, one is the carpopedal unit and the three kinematic coupled thing to understand how the whole Ponseti method works. Now having understood that, there's something known as retracting fibrosis, which is seen in, which was described by Ponseti, that most of these connective tissues around the foot are like an elastic. There's a lot of collagen which recoils back, just like a lady's hair, you straighten it and it recoils back. So that is one reason why you put the cast as every week, and you don't give a break between removal of a cast and cast application, because the recoil happens and the deformity worsens further, or, doesn't correct completely. And
so creep, stress relaxation, those are all viscoelastic properties. So creep means time dependent deformation. So that means when the foot is like that, you put it in a slightly corrected position, put a cast on, and if you hold it for a week, over time, there is some stress relaxation. That means whatever tension is there in the tissues will ease out. That allows you, when they take out the cast next time, it allows you to push it some more next time you put it on. That's called creep or time-dependent deformation. That's a property of all viscoelastic structures, and our body is also a viscoelastic structure. So that's one of the properties we use to correct club feet.
I just wanted to make one comment. Few years back, I think there was a presentation or paper from someone from Mangalore region that they used to do casting whenever the child comes. Anyone doing that practice, or what's your experience with that? So there was no fixed schedule. Whenever child comes, they would do, as per the patient convenience.
That won't work very well because you have to do it every week. The fastest you can do if they're coming from outside is every 4 days. If you go sooner than like every day, it won't work because it needs time for the tissues to undergo stress relaxation. And usually the maximum you can go is up to 2 weeks. So between 4 days and 2 weeks is the time between one cast and next cast. In older children, we do 2 weeks because tissues are not as viscoelastic or not as, because there's more bone. Cartilage is all now calcified, it's bone, so it doesn't relax as well. So we give more period, like sometimes you have an 8-year-old come, that means you do the cast every 2 weeks for them. Usually in most infants and up to 2-3 years old or a little bit more, you can do every week. And if they're coming from far off, you can do maybe up to 4 days. That's called like rapid protocol, but usually the gold standard method is every week.
so the Ponseti method utilizes all these 4 principles that we spoke about. One is the carpopedal unit, the acetabulum pedis, the kinematic coupling, and the retracting fibrosis. All these 4 are utilized by Ponseti to correct the deformity. So basically, whatever is adducted, inverted, and flexion, you're bringing into abduction, eversion, and extension at the end of your treatment. Thank you.
So it's almost like a train. If you put a wagon on the train track, so Ponseti method is like, as long you put the foot on the correct path, it automatically will correct. If you don't put it on the correct path, it's going to get derailed. So that's what Hiram Kite did. He didn't put it on the right path. So that's why it was not correcting. But if you put the foot in the correct path, like you put a wagon or a train wagon on a track, it will automatically go forward and correct. So similarly, if you correct it and then you just use one force, everything will correct. Any questions on the pathoanatomy and biomechanics of how the Ponseti method works? Ask the mic. In case of serial casting, do you advise a gap between 2 casting procedures?
No gap. Ideally, they say remove the cast in the clinic and immediately apply it back, but probably logistics don't allow it, especially when parents are coming from out of station.
Yeah, I think we'll talk about that. So the source and things usually you should not be having. That means you're either putting too much pressure or putting pressure in the wrong place. Okay, so usually you should not have any source. Having said that, have I had source? Yes, maybe like once in a year or something, but you have to be careful. So we'll show you what are the things you can do to prevent that. But usually, no. If you give gap, you lose correction. So the parents ask, can we take it out the previous night, give the child a bath and bring him to the clinic? We usually say, no, they can take it out early in the morning that day, and then they can give them a bath, clean the child, and then bring. But not more than that. Every time you lose, if you give a gap of few days, they lose correction because the foot wants to go back to that position.
In preterm children, whether the protocol has been changed in foot.
Preterm, if they are not full term, is that what you mean?
Yeah.
No. The only thing is you have to make sure if they are very early, like if they are like 24 weeks or 30 weeks or something like that, then once you correct it, you can still correct it, but the shoe may not be available, correct size shoe may not be available. So usually I delay. If they come to me like at 30 weeks or 32 weeks, usually there are very few of them that come there. I don't start treatment until they're a little bit bigger. So like 40 weeks or something.
No, you said about the viscoelasticity.
Yeah, you won't lose that. You can still have that up to about, even I've corrected till about 14, 15 years. No problem.
What? Thank you.
Is there any statistics comparing heights and Ponseti?
Oh yeah, there's lots of comparative studies which have compared the two, and I think there's also a randomized control trial which have compared, and it's shown that Ponseti methods is definitely more effective.
You can start it immediately. So, yeah, soon after birth.
You can start it immediately. I usually give them time of about 3 to 4 weeks, because usually you're treating not just the child, the mother as well, and the whole family. Immediately after birth, you all know it's a very traumatic event, giving birth to a child. So the mother may not be, fully well. She needs a few weeks to get settled. As you heard, many of them may have postpartum depression and things like that. And they feel that the child is part of the mother. And they have this feeling that if you try to cause them in the right, like day after birth, the mother starts crying because she feels like, she feels like she has the deformity. So, and it's difficult for them to deal with it. So I usually have learned over time to give them some time, 3 to 4 weeks, to bond with the child, let them feed the child, get used to the child. But that is also important, because when you come for treatment, we usually tell them to adjust the feeding schedule so that they give a gap of about 2 hours before the last feed, so that they can feed the child while we are doing the treatment, while we are doing the casting. So for all those reasons, I usually tell them to get bonded with the child, go back home, settle yourself. Once you're ready, come back, and then we'll start. Okay? Because you want the mother to be on your side, because you are a team, like Dr. Veena said, we are all a team helping the family. So it's important for us to understand the mother's situation. If they are apprehensive, a little bit depressed, you give them some time to recover. And then when everything is settled, the family is all ready to go, then you can start. Okay? There's no rush to do it right after birth. It's not like an emergency life or death situation. Okay?
And many times, I agree with all those points, many times the pediatricians need to weigh the baby frequently. Like they develop jaundice. So in that case also, with the cast on, it is not possible. So good idea to wait for few weeks. Usually I tell them that once your pediatrician is happy with the weight, they are not going to weigh the baby every 3 to 4 weeks, 3 to 4 days, excuse me. Then we start that.
I agree with that. And then the other situation is sometimes they'll call you from the intensive care unit because the baby is admitted for some other reasons. For example, like necrotizing enterocolitis or jaundice or some other infection or whatever it is. And they also have Clubfoot, and they'll say, they'll consult you, you go see the child, and then the intensivists want you to cast the child there. I'd never do that. Okay? The problem is, because when they are admitted, they're giving them IV fluids and other things, so the weight of the child can fluctuate. Then the cast can get tight. This cast is not like a fracture cast, it's a very conforming cast. Okay, because of that, if the weight of the child fluctuates and they're giving like IV fluids and other things, they may say, okay, the cast is now tight, come and take it out now. Okay, so we can't do that. Okay, I just say finish this treatment, go home whenever you're ready, come back and then we'll start. And we can easily correct it. There's no rush to correct it within the first few months. But if you can start early, definitely yes, better. But you can get equal correction even if it's a few months old. There's nothing lost. You can still equally affect it. No, it's not at all a painful technique. It's very, very gentle. The amount of pressure you apply is just 2-finger pressure. I was seeing some of you were handling the model a little bit with more pressure, but that's what creates problems. It will make the foot more swollen and things like that. So it's very, very gentle. It's not at all painful. Some of the children may be more sensitive because when you touch their foot and after the casting, you feel that, I also see this, they start crying and things. It's not, so we tell the family it's not painful. It's just some have more sensitivity. They don't want their feet touched. So that's the reason why you distract them with the feeding at the same time, then everything goes pretty smooth. You can also play music. The mother can whisper to the child, like you heard of like a baby whisperer. So mother can keep talking to the child. We'll show you how we set up and all those things. So sometimes you can get in Amazon and things like that, various like baby whisperers and things. You can keep that there, or you can play music, have the child or mother or father talk to the parent, the child keep talking to them, and then everything will be fine. Okay.
Many places it's a common practice in India to give pedichloral to these kids, but that's very dangerous because we as orthopedic surgeons are not at all equipped if the child becomes drowsy. So I would strongly stay away from that practice.
Yeah, yeah. So you can get a quick health break.
We'll come to it in the subsequent talks.
We'll address it. Keep your question. It's a very important question. We'll address it during the casting session.
Yes, ma'am. So we'll have a quick 5 minutes break and come back.
Coffee tea is arranged here. 5 minutes break to get your coffee and come back, okay? And then we're going to start immediately. Okay? Just set up just for 5-10 minutes and then you can set them up. Live is a little bit better. You haven't taken this movie, okay? Set up 3 pieces. Whatever they want to, they can do very gently. Massage it hard. After it becomes swollen. I usually don't say no, I massage it. ಮಾಡ್ಬೋದು. Earlier is better. If you wait 6 months, there's nothing lost. Can I set up the models, 3 models? I think there was one here, right? We can just demonstrate at one place. We usually request the camera. Maybe I'll hold, you can cash, or I can hold, you can cash. Maybe you can cash. You use flash comparison. Okay, so you're going to concentrate the camera here now, okay? Then everybody will assemble here. We're going to demonstrate casting technique here. Okay? Yeah, he's going to, yeah. Hello? Yeah. Yeah, green mantra. So what we'll say is we'll demonstrate in one, then afterwards they can practice like three, right? We'll demonstrate in one. Me and Ashish will demonstrate in one place. Okay.
Check.
No, we'll call them here to stand around us. Set up here.
No, just project it because no, the video on the screen.
We'll project ಮಾಡ್ಲಿಕ್ಕಾಗುತ್ತಾ?
ಮಾಡ್ಬೋದಾ ಫ್ರಮ್ ಅಲ್ಲಿಂದ ಇಲ್ಲಿ ಪ್ರೊಜೆಕ್ಟ್ ಮಾಡ್ಬೋದಾ ವಿಡಿಯೋನ
ವಿಡಿಯೋ ಇದೆಯಾ ವಿಡಿಯೋ ಶೇರ್ ಮಾಡ್ತೀರಾ
ಇಲ್ಲ ಸೇಮ್ ನೀವು ಶೂಟ್ ಮಾಡ್ತಾ ಇರೋದು ಲೈವ್ ಮಾಡೋದನ್ನ ಇಲ್ಲಿ ಮಾಡ್ಬೋದಾ
ಮಾಡ್ಬೋದು ನೀವು ಅವತ್ತಲ್ಲ ಯೂಟ್ಯೂಬ್ ಇದೆಯಾ ಯೂಟ್ಯೂಬ್
Usually don't get to see in the back. That's why.
ಇದು ವಿ ಜಿ ಎ ಕೇಬಲ್ ಹಾಕಿರೋದು ಎಚ್ ಡಿ ಅಲ್ಲ ವಿ ಜಿ ಎ ಎಚ್ ಡಿ ಎಮ್ ಅಲ್ಲ ಹಾಂ ಅದೇ ಎಚ್ ಡಿ ಎಮ್ ಎಲ್ಲ ಕರಿ ಕ್ಯಾಮ್ರಾ ಯಾರಾದರೂ ಔಟ್ ಎಲ್ಲಿದೆ ಹಾಂ ಅದನ್ನು ನಾನು ತೊಗೊಂಡು ಇಂದ್ರ
So we'll go ahead with Pirani scoring assessment and scoring. So can you move to the side? So why is it important to measure, assess or record your progression in Ponseti's method? One, to know the severity and what stage of the treatment are we in, when to do a tenotomy, or should we continue casting. So it becomes important to know how the foot is progressing, and that's why you need to score it. Also, as I told, to know when to move next to the next step of the treatment, and also to identify if there's any resistance or to the treatment, or if there's any early relapse. The scoring helps you identify resistance to treatment as well as in identify early relapses, and gives you accurate records of the treatment, what is going on, especially if you're involved in some research activities, or as well as for documentation for medical legal purposes as well. So in general, always as orthopedicians, we are used to just seeing the limb. If a patient comes with a fractured limb or a deformed limb, we just see the limb and often ignore the remaining of the patient. We forget to assess head to toe. So it is always important to take a detailed history, know the birth complication, was it a term, preterm, was there any complications associated, is there any developmental issues, physical, intellectual difficulties, hearing or vision difficulties. So always assess the child head to toe, make sure you turn the child to the side, examine the spine, look for any features that might suggest of neurogenic clubfoot, such as a MMC or a spina bifida or hairy lump, or any sinuses in the back. So always examine the child as a whole, examine the upper limb, look for any contractures, mobility of the joints, look for the hip, look for abduction of the hip, examine the faces. As you can see here, there are two children with a syndromic face. This is a Freeman-Sheldon syndrome, and this is another child with Perry-Robinson syndrome, which is associated with cleft lip, micrognathia, and clubfoot. So make sure you see the child head to toe, not to miss out, because identifying these will help you classify whether it's a syndromic clubfoot, a neurogenic clubfoot, or an idiopathic clubfoot. And based on this, you know how the outcome is going to be and how long your treatment is going to take. So as I told before, always make sure examine the hip, because it can be associated with DDH in certain syndromic or even in idiopathic clubfoot, and assess the upper lower limb tone, movements, any contractures, rule out arthrogryposis or any syndromes that might be involved. So differential diagnosis, one is something known as postural clubfoot, which most of us underdiagnose or overdiagnose. So when you are able to correct the dorsiflexion completely, that is, you are able to correct all the deformities completely, and you are able to dorsiflex almost more than 15 degrees, then it is most likely to be a postural clubfoot. And all you need to do is reassure the parents, teach them some manipulation, and evaluate the child every once in a month to see how it is improving. Doesn't require cast. Occasionally, after 1 or 2 months, if it's still persisting or not improving, then probably you might have to put 1 or 2 casts. But most of these postural clubfoot don't require active treatment. And again, metatarsus adductus, the forefoot is adducted over the lateral border. There's no heel equinus or heel varus in this. So this is how you differentiate a pure metatarsus adductus from a clubfoot. Again here, observation is the mainstay of treatment. If it is rigid, might require 1 or 2 castings. Otherwise, again, no active treatment. This is another common association seen in clubfoot. We see a lot of children with umbilical hernia. Now coming to the scoring itself, this was developed by Dr. Shafiq Pirani. So mainly it has 6 components which are scored out of 1 each. It is 1, 0.5, and 0 depending on the severity of all the 6 components. So you have a midfoot contracture score, which consists of the curved lateral border, the medial crease, and the lateral head of talus, and the hindfoot contracture score, which has the posterior crease, the rigid equinus, and the empty heel. So you have.
So orthopedic examination, as you all remember, consists of 3 simple steps, or even in medical exam, inspection, palpation, percussion, auscultation, right? So in orthopedics, we call it more simple words. We call look, feel, move, okay? So in those, so you're measuring 6 things here, okay? In those, 3 are look, 2 are feel, 1 is move, okay? In the look one, when you look at the child's foot, you're looking for whether the lateral border or outer border of the foot, is it curved or not? Okay, we'll show you how to examine that. Then look for the medial crease, and then look for the posterior crease. So 3 look, okay? Inspection, three things. feel. You want to feel for two things: the lateral tail or head, whether it's prominent or not. If it's a full club foot, it's very prominent. Okay, as you correct it, it becomes less prominent and then disappears completely. You won't be able to feel it. So that's feel. And the other thing you feel is empty heel. That means when the foot is down like this in equinus, you won't be able to feel the heel. As you correct it, as the heel comes down, you'll start feeling it. So two things in feel. One, move. That means you see how much equinus they have. Okay, that's move. So it's easy to remember. Don't try to kind of by heart or anything. Look, feel, move. Okay, so 3 look, 2 feel, 1 move. Okay, that's it. Okay.
So having said that, we'll first look at the posterior crease. So each of these 6 components are scored has 1, 0.5 and 0. Now coming to the posterior crease and your medial crease are similar in your scoring. So 1 is when it is a single indenting crease. So single deep crease where you're not able to appreciate the base of the crease. So that is 1. It is a single deep crease but you're able to appreciate the base of the crease, it becomes 0.5. And if it is multiple fine crease just like a normal foot, it becomes 0. So 1, 0.5 and 0. So this is similar in a picture. You can see here there's a single deep crease where you're not able to appreciate the base, it becomes 1. Here it's a single deep crease but you're able to appreciate the base of the crease, it is 0.5. Here it's a multiple fine creases, 0. So empty heel, this is how we appreciate the empty heel, because you might place your finger over the wrong side and score it wrong. So ideally you keep your middle finger over the calcaneum and your thumb at the base of the foot, and in the middle at about 45 degrees you palpate for the heel. That is basically you're trying to palpate if the calcaneum is in its position or it's high riding or is it empty. So when you palpate and it is like your cheek, it is soft like your cheek, that becomes...
So stop for 1 minute. So all of you guys put your index finger on your cheek or the tip of your nose and feel it. Okay.
Feel the difference between the cheek and the tip of the nose. So if it is like your cheek, it is 1. Now if it is like your tip of the nose, wherein with little deep palpation you're able to palpate the bone, that becomes 0.5. Yeah. And then if it is like your elbow or like your heel itself, it becomes 0. That is, the bone is well seated down and you're able to feel it. So 1, 0.5 and 0. So this is with your empty heel. And this is what you move and see. That is, you try to correct the equinus. Now if it is anything less than 0, that is, if it is in equinus, you score it as 1. If it is coming up to neutral, you score it as 0.5, and if it is going beyond neutral, you score it as 0.
So it should be more than 10 degrees past neutral. That will be 0. Yeah. Like, so anywhere from neutral to 10 degrees of dorsiflexion is still 0.5. Our aim is to get it above 10 degrees of dorsiflexion. Okay.
So the same thing can be seen in images. So anything less than neutral is 1, up to neutral to 10 degrees is 0.5, and more than 10 degrees becomes 0. So similar like your posterior crease, you look for your medial crease. So if it is a single deep indenting crease, you label it as 1. Single deep crease, but you're able to see the base of the crease, 0.5. Multiple fine creases is 0. So here you can see that there's a deep crease running where you can't see the base, it's 1. Just a single crease, base is seen, 0.5. Normal multiple creases is 0. So can anyone tell what this is? How much would you score this crease? 1. 1 or 0.5? 1, yeah. So you're not able to see the base, even the posterior crease, you're not able to see the base. So you can score it as 1. So next, coming to lateral tala head coverage. So this is one important thing that you'll need to know. Now to score this, you'll need to know where the tala head is. So to identify the tala head, first I would take the reference point as the lateral malleoli. So first identify the lateral malleoli, and just anterior to the lateral malleoli, anterior and slightly inferior to the lateral malleoli is your tala head. So you don't need to go too inferior, just go anterior to the lateral malleoli and you'll be able to feel the tala head.
I think the other important thing is if you can't feel it, make the deformity worse first. Overcorrect it. Don't exaggerate the deformity. When you exaggerate the deformity, you will be able to feel it easily. Okay. Once you feel it, it's the first structure. So put your finger, like I said earlier, put your finger behind the fibula, and then your thumb. This is the first bony point. You see the lateral talar head. Exaggerate the deformity, you'll feel it, and then you can score. Okay.
So once you identify the tala head, now you're going to place your thumb over the tala head and try to abduct the foot, and then you see if the tala head is going in. So you grade it as 1 if the tala head, the talonavicular joint is dislocated and you're not able to reduce the navicular over the talus, that is, you're able to palpate the tala head clearly. So it is 1. Now you're able to reduce the navicle back partially and you're able to palpate both the tala head and partially the navicle, that becomes 0.5. And your navicle is completely reducing and your tala head is no longer palpable, it becomes 0. So 1 if your tala head is well palpated and navicle is not reducing back. 0.5 it is partially reducing and your tala head is slightly going inside. And 0 if the tala head is completely going in and the navicle comes back to its position. So this is your lateral tala head. And then finally you come to your curved lateral border. Curved lateral border, 1, you can either use a pencil which is kept against the lateral border of the foot, or you can use your first web space to assess it. So
Go back. Like that, or
so when you keep your pencil or your first web space, now if it is like a boomerang curve, like way below the metatarsal level, then it is 1. If it is gentle curve, 0.5. And if it is straight in line with your index finger or the pencil, it becomes 0. So first web space is most commonly used, or you can always use a pencil, which is much more easier. So this is 0.5 as you can see, and this is 0 where it is straight. The toes are not included when you're doing the lateral border, curved lateral border. So using Pirani score, you should make sure that you record this every time, so you are aware of where you are in the treatment protocol. And even when you're bracing, make sure you at each follow-up you record the score. You usually have these sheets which are available, which is given even in the booklet. You can utilize this scoring sheet and assess the progression of the treatment. Make sure you all can mark whether you all are casting it. You can put a C. If you're putting a brace, you can put a B. And you can put your initials, so the same person can follow up the child each time when the child comes back. So with this scoring sheet, you'll know where you're heading towards and when you need to do a tenotomy, or do you need to continue your casting protocol. So normally the score, as I said, you had the hind foot and the midfoot score. As you start casting, your midfoot score tends to gradually come down, whereas your hind foot score tends to remain the same almost until you do a tenotomy. Once you do a tenotomy, you can see even the hind foot score drops down and never becomes 0 initially, but eventually with time progression, it becomes 0. Even after tenotomy, your empty heel tends to remain 0.5 for a long time before it becomes 0. So overall, if you see till the tenotomy, it comes to about 2.5, and then once tenotomy, you see the score suddenly dip down. And then you follow up to look for any recurrences or relapses eventually. Thank you.
Okay, so now we will show you how to set up the patient and where to place the mother, etc., and where the the casting person and then the holder are located. If you want to come forward, everybody come here, because it will be difficult to see from the back.
Just a quick question. How many of you prefer to do casting? So anyone prefers to be the holder? So majority of them are casting.
Yeah. Okay. Mesreno? ನಿಮ್ಮ ಹೆಸರೇನು? ಇಲ್ಲಿ ಮಲಗಿಸ್ತೀರಾ ಮಗುನ? ಸೊ ಇಲ್ಲಿ ಬಂದು ನೀವು ಇಲ್ಲಿ ಕೂತ್ಕೊಳ್ಳಿ, ಇಲ್ಲಿ ಕೂತ್ಕೋಬೋದು ನೀವು. ಮಗುನ ಇಲ್ಲಿ ಮಲಗಿಸಿ, ತಲೆ ಈ ಕಡೆ ಕಾಲು ಈ ಕಡೆ ಮಾಡಿ, ತಲೆ ಇಲ್ಲಿ ಮಾಡಿ. ಸೊ whenever you're setting up, suppose the child has left-sided clubfoot, ಮಾತಾಡಿಸಿ, ಹೆದರ್ಕೋಬೋದು. Okay. So whenever you're setting up, if it's a left-sided clubfoot, the mother is sitting on the opposite side, okay? And then usually she'll have a bottle ready and she'll be feeding, okay? Or you can also have some lights or something like that to distract the child, or you can speak music or whatever, various distraction techniques. And then the person who is casting, usually here, okay? And the person who is holding will be here, okay? Okay, so you're, if it's a left foot, I'm holding it such that, so 2 fingers go here, thumb goes here, okay? I'm just holding like this, not a lot of pressure or anything, just gentle, okay? And then the other hand will be here, okay? Just holding like this, okay? The holder is the most important person. Mother can talk, and also if there is another person, like for example Ashish, so they will hold this, and then so that way it's not coming in way. And then you will be like this, and then if one of you can just hold here, yeah, no, stand there, and then Ashish can come here. Can we have some roll of Webril or something, Gopi? So I usually like to have a small piece of stock in it, like about this long, and I put it up here. It tegiboda idu cheddi tegiboda, tegitira ಒಂದು ನಿಮಿಷ. Thank you. Yeah, and then with the diaper, usually there's tape. If not, this needs to be high up like this, okay? And then the stockinette goes here, and then you're kind of holding the foot like this, okay? Yeah, play. He likes to play. What was it? Like Dr. Ponseti plays Beethoven. If you heard of Western classical music, I like to ask the mother, like, what would you like to play? They'll say whatever they want, they can play. Or if nobody, like something baby whispering, or there's usually different kinds of sounds, like waterfall sound, whatever you can play. Just put it here, and then the child, if nothing is available, ask the mother to keep talking to the child. That's it, okay? And you can see the child is quiet now. In spite of like 50 of us standing here, the child is not, is pretty comfortable. Yeah. Okay, so this is not ideal, because the child's foot is like this. You need like 2-inch Webril. This is too big. If it was there, then I would take a knife and I would cut it, okay? But I'll just show you, okay? And you start before, not just at the foot, you have to come beyond the foot, okay? And it's a very tight tight cast padding, okay? You can see he's pulling on it, but not like constricting it, but very conforming. And then I keep wearing my hand. I extend it a little bit to make it easy for him, and go all the way from toes to the groin, okay? And then 3 layers here, 3 layers here. Rest of it here is only 1 layer, overlapping of 50%, okay? It's a little bit, it's synthetic, it's not Webril, okay? So it should not be loose, kind of like this. It has to be really tight. This is also a little bit loose. I like, when I pull it, there shouldn't be this much space. It should be very, very tight. And then I usually, once he's done that, I keep it here. I keep my finger here, and then he'll cast above me, okay? So then we'll show you the casting on the models. Okay, so any questions? So the child is like this at the end of the bed, okay? If the child is further up here, it's hard for you. You'll have to bend over. They'll have to come right here, okay? And then the mother is sitting right here. And if it's bilateral, then after finishing this side, we swap over. She comes here, we go that side. The holder is here, okay? And then the casting person is here, okay? Any questions? And then usually we say don't feed 2 hours before, adjust the feeding schedule, and then bring a bottle. If they're not, usually we tell them when we see them first time, when we're diagnosing, tell them get the baby used to bottle feedings. That way, bring the bottle, warm the milk, let them feed. If they're hungry, they'll concentrate on the bottle. They're not worried about you messing with the foot, because when it gets wet is when they don't like it. And also after, if you do it after they're fed, they like to go to sleep, so you're disturbing the child, so she doesn't like it. The child moves a lot, and then the cast is not good. there's a lot of wrinkling and things, that's when you have sores and things like that. So that's the key. And if the mother is, if they're not used to bottle feeding, sometime I'll ask them if they're happy to breastfeed them while we are, if they don't feel uncomfortable, I let them breastfeed. In that case, it's a different thing. ಇಲ್ಲಿ ಕೂತ್ಕೊಂತೀರಾ ಒಂದು ನಿಮಿಷ ಇದ್ರ ಮೇಲೆ ಮಗುನ ನಿಮ್ಮ ತೊಡೆ ಮೇಲೆ ಇಟ್ಕೊಳ್ಳಿ. ಕೂತ್ಕೊಳ್ಳಿ, ಬ್ರೆಸ್ಟ್ ಫೀಡ್ ಮಾಡೋ ಥರ ಇಟ್ಕೊಳ್ಳಿ. So they can breastfeed them like that. You give some privacy and things like that, and then you can do the same thing. They are feeding the child and you're kind of holding here. You can put a towel on the mother's leg so her clothes don't get wet, and then you can just do the casting. I do it sometimes. It depends if mother is comfortable breastfeeding or not. I usually don't like, I like them to bottle feed, but if they say I want to breastfeed my child, I said okay, fine, we can still do that. Okay, but I'll ask them their preferences, whatever their, and then it's not rigid. Okay, so we usually try to do whatever they want, showing them they're part of our team. Okay, so that's very important. That's it. So thank you. Okay, any questions on this setup? No sedation. Yeah, fine. At least in my hands, if they're already fed, you try to do the casting, they won't like it that much. Yeah. Yeah. And also sometimes if they're feeding, like if they're breastfeeding and you see, after doing one side, if it's bilateral, you give them a minute to burp the child, so that way, and then you start the other side. That's it. Yeah, means there's not like one, it's like, there's no like one right way. But this is what worked for Ponseti and has worked for me. If something works better for you, that's fine. Essentially, you have to make sure the child is comfortable, mother is comfortable, and then you do it. That's it. Okay? Thank you. So,
After some time, we have one talk. And then
so you guys can stay here. We'll now demonstrate the casting technique, okay? We can get the model here, right?
Sir,
Oh, you want to show your video? Yeah. He's going to show a video, so you can just sit back for 2 minutes and then we'll practice the casting session. Okay?
they have set up a live relay. So
Okay, yeah.
you all can do and they can sit and watch.
Okay, sure. Hey, Gopi. Where is Gopi?
Gopi?
Is there any way we can cut this? This is too big. Yeah. So we are now going to do the technique, show the technique on video, and then we'll do the casting on the model. Okay? Use the mic. We can forward the slide for you.
Yeah. So
You can just play your video if you want. Yeah. We'll talk about it when we demonstrate, right?
okay, so we'll just go through the video. So where I do casting, it's not possible. I need to
Make like 4 or
change
5
the
rows,
place.
cut it.
So mother is sitting at top end, holding the baby. I am at the sort of lower part, and then my assistant, the holder, is holding the foot. So slight modification, but the same principle. I'm using a smaller soft roll.
2 inch is best. Okay, it depends on the size of the child. But in infancy, less than 1 year old, the 2 inch Webril works well. If it's an older child, then you may want to use 3 inch. But it depends on the size of the child. But in general, 2 inch is the best. Okay.
Then I'll be doing the below knee part first. I use 2 inch plaster of Paris. So you can see the phone that's playing music, the same music. The first roll I keep it little bit wet so that I can manipulate and make the cast well molded. I'm keeping that as a bunched up so that removal is easy. That point the holder will hold the leg at the top end. And again I am doing around the malleoli.
See, at no point you're touching the calcaneus. So you'll use double and single-handed holds. Double-handed means you're using two hands to hold the foot. Single-handed means you're using only one hand to hold the foot. Okay, we'll show that to you when we do the module. So with one-handed hold, he's holding the foot with one hand and molding with the other hand. So you can keep moving. So to avoid pressure source, again, it's important to keep moving your hand from one place to another. That way you're not in only one spot all the time. That again causes a lot of pressure on one area. Okay.
So usually if I'm doing right side, with right hand I'll do the inside, the medial side. With left hand I'll do the lateral side. That's how I I usually start at the top end so that I know where to stop and I'm not going too high. And
so you don't want to put the cast all the way where the padding ends. You want to leave about like half-inch gap so that when you roll it over, it forms a nice padding. The cut edge or the sharp edge of the cast when it sets doesn't rub on the skin. That's when you'll get sore again. Again, I like to use a stockinette, like a cut stockinette, so that way I can roll it back. It forms a very nice cast padding, so it's very, very soft. It does not cutting into the groin or anything like that. Okay.
And I folded back and forth on the convex side. I do not want to put too much plaster on the concave side.
That's called as a blob. That means the last part of the cast, you just make it into a blob, because when the parents take it out or when you take it out the cast, it's easy to find. If you make it fully flat, it gets laminated and it's very hard to find the end of the cast. So the blob kind of helps identify the end of the cast rolls or the end of the cast roll, so you can easily take it out.
And if you hyperflex the hip, baby cannot extend the knee.
Yeah.
So especially if child is little bit older, 7-8 months old, try that technique. It helps. Repetition. I think we stop. It's the same repetition of.
So now we will demonstrate the casting technique, so you can assemble again here, everybody. Lights on, please. So again, so this is the size you want. So if you don't have this size, if you have the bigger size, cut it, take a knife, cut it into it. This is synthetic. You can see it's not Vebrile. The ideal cast padding is Vebrile, because when I pull it should easily rip. It's not. So this is not the ideal cast padding material, but this is what we have, But I usually like Vebrile because it expands easily. Okay. That's one thing, material. So you need usually need 1.5 rolls of cast padding and maybe like 4 rolls of cast material. And then the stockinette piece. So get that ready, put the stockinette on, and then, so you can see the scoring is, this is the fibula, just first hold it here, okay. This is the lateral tailor head. It's not prominent, make it slightly overcorrect it, and then you will be able to feel it. Okay, then you have to hold it like this, okay. One-handed, so two-handed grip is this, okay. So this will go in line with the foot. So you're not holding it like this, okay? You're holding it like this, okay? So not here. It goes all the way to the, to the talonavicular joint, okay? This here, and this is here, in line with it. And then you're just doing this, okay? So you first of all, you elevate the first ray. That's the first thing, okay? That's going to correct midfoot cavus, okay? And then just keep it in that position and just take it as much as it will allow. Don't, no force or anything like that, okay? Just gentle, extremely gentle, that's it, for the first day. Next time, a little bit more, okay? That's it. So I'm not using any force, okay? So if you use more force, it'll, damage the tissues, it'll swell, and then you're on a slippery slope, okay? So that's the thing. And then you have to manipulate first before you cast. So same position, and then you can a little bit of manipulation, hold it for about like a minute or so, and then leave it again after that, okay? Again, manipulate, then leave it. So it also helps you assess like how far you can go, okay? That's manipulation. Yes. Yeah, manipulate for about 30 seconds to a minute. One, you will get the feel how much to push the foot, because not every foot is the same. Some are like soft, some are soft, stiff, some are really stiff, okay? So you'll know. Like a child with arthrogryposis, you can't like do that. It's very stiff. You won't get that. So you will also get a feel of how much far to go. Before casting, when you manipulate, that's how you're manipulating. And then also after that, and then you cast. Okay? No manipulation after casting. You'll just hold it in this position, and then you'll mold it, but no manipulation after casting. Because if you manipulate, it'll cause wrinkles in the undersurface of the cast. Okay, then the next, so two-handed hold is this. So you're holding with two hands. One-handed hold is this. So index finger on the lateral talar head, and the thumb underneath the first ray, and then you're just doing this. Okay. So if you want to hold that there. So this is single-handed hold, and then the other hand you're going to mold the foot above the calcaneus here and here. You're molding it, and then you're moving from two-handed to one-handed hold. Okay. This is two-handed hold. This is one-handed hold. Okay. You will get to kind of practice it. Okay. So I'm gonna.
So one question I wanted to ask all of you. Some variations I've seen. A lot of people put tincture inside. They think that prevents this soft roll from sliding down. I think that's irritant, and child skin is very fragile, so not a very good.
I've used it in some times because, for example, the cast slips. Like even though like you have to be truthful, I can never say that my cast never slipped. It has slipped in my hand too, especially if the child is chunky. Okay, and then sometimes the thigh segment is very short. Those kind of casts will slip. Okay, so sometimes if they've already slipped once, then I'll use tincture benzoin, because it does allow the cast padding to stay and prevent it from slipping. So I don't use it on every child, but use it sometimes. Okay.
But it is not skin friendly.
Yeah, that chance you have to take. Sometimes it can cause contact dermatitis, but not in every child. At least the ones I have used, it hasn't. Okay, but it can. I agree.
Some people talk about having a roller bandage, just cotton bandage, and on top of that they put this. Again, with the idea that allows the cast from slipping. No personal experience, but anyone does it.
Yeah, tincture benzoin.
Yeah, I don't use it, but there are people and there are studies out there.
No, when it becomes wet, no.
It is cotton. Yeah, it is already stiff. Starch
restricting the force.
Yeah, let's stick to Ponseti's technique. Okay, let's not. Yeah, you just put tincture a little bit here. Okay, all those things are not needed. Like I said, 1,000 case, one case you might need it, but in general, you don't need any of those things. Okay. Okay. Yeah. You don't need to hold it, just there and there, in line. Okay. Yeah. There. That's it. So he's holding. So I start. So this I'm not starting here, and this should be a little bit narrower as much as you can. Yeah. That's it. So I'm going above. Okay. The first roll, lift your thumb up. For the first time I put it on, I go without the thumb. As soon as I'm done with it, he'll puts it on, holds it, hold. Don't remove it now. Okay. Then I do 3 layers here. Okay. One. Yeah. No. After we demonstrate, we'll make three areas where three of us will demonstrate, and we'll go over it again. Okay. So 3 layers. Okay. At the end, and then you see it's pretty tight cast. Okay. And then 50% overlap after that. Okay. Okay. And then sometimes I may have to tear this if I feel there's a wrinkle or something. Usually we'll tear it. Okay. No wrinkles. Okay. And then overlap it 50%. Okay. See how I'm pulling on it? Because when I pull it, no space. It's not coming off. Previously there was space. I could lift it up. That means it's loose.
That was big too. That's why we should
Yeah.
use too big.
And then this, see here, overlapping 50%. Okay. Overlapping 50%. And then I stop there. Oh, I roll the caution padding all the way. That's not done in different levels. I just go all the way with that to the groin. That's it. Once that's done, and then again with this hand, you're not putting too much pressure, just gentle pressure, because you push very hard, the child will react to that. Okay, that's it. Now this is done. You can see when I pull it, it's not coming off. Okay, it's not loose like this, for example. So if it's loose, it should not be like that. Okay, so this is really tight. I'm pulling, nothing comes out. Okay, that means it's a conforming cast. Okay, and then at the end again we end up with 3 layers, because again it's padding the edges of the cast. Same thing here, padding the edges of the cast. Okay, after that then we start with the plaster. Okay, so then we'll make the 3 areas and we'll show you the casting next. Okay. What do you mean? Overlapping 50%. Yeah. No crossing. No figure of eight. This is what Ponseti taught me. Okay. No need. No need. If this thing, if you do it correctly, this should not be exposed. If it is, you can just put one half thing here. That's what Ponseti taught. If you stick to what he taught, keep it perfect. So the definition of orthopedic surgeon is one who tries to modify. First time he does this technique, you modify it. That's the characteristic definition. Do not modify the technique. Okay. You have to strictly, it's easy, but you have to stick to it. Strict. If you do below knee and then chalta hai, adu ಮಾಡ್ಬೋದು ಹಿಂಗೂ ಮಾಡ್ಬೋದು ಇಲ್ಲ ಅದೇ ರಿಜಿಡ್ ಆಗಿರ್ಬೇಕು ಅದೇ ಟೆಕ್ನಿಕ್ ದಟ್ ಈಸ್ ದಿ ಕೀ ಆಫ್ ದಿ ಸಕ್ಸಸ್ ಬರಬೇಕಂದ್ರೆ no deviation from what Ponseti did. Like he made me practice when I was there in the week. Every day I was putting on like 35-40 casts on the model, and he would come and inspect and say, okay, no, this is not good, this is not good. So he made me do that for like 7 days. Every day in the morning 2-3 hours we would practice just casting like on the model 30 times, and then we have to line it up for him. Then he'll say, okay, this looks good, then that looks good, and then he say, oh, this is not good. So he that is the key thing. If you do exactly what he does, it will work. Okay, if you try to change it, it won't work. Okay, or you'll run into some problem. Okay, that's the key thing. Okay, anything to add, Ashish? Okay.
The problem is we are applying with the ordinary cotton ball.
Yeah, this is okay. Like, yeah, if you don't have Webril, even ordinary cotton roll, you stick to the principles. That should work. Okay.
It is little soft. It's not pressed.
First step is, yeah, we'll come to that, the casting technique. Yeah. Okay, let's take it out or every week. Yeah. Okay. Okay, 3 models set up. Gopi? Yeah, let's distribute ourselves. We'll be in each 3 spots, and then you guys can break yourself up and then assemble, and then we'll show you again. Okay. Illond model ಹಾಕ್ಬಿಡಿ ಗೋಪಿ ಈ ಟೇಬಲ್ ಮೇಲೆ ಒಂದು ಹಾಕಿ. You can roll it up so we can use it again. ಇಲ್ಲಿ ಇಟ್ಬಿಡ್ತೀರಾ ಎಲ್ಲರೂ ನಿಂತ್ಕೋಬೋದು ಅಲ್ಲಿ. Gopi, gloves idea? No gloves? Do it here only, no? Edge of the table, it's easy. Do it here. It's because they can sit all three sides are open, that's why. Huh? Yeah, one is here, one there, no? We only have 3 instructors, right? Okay. So some of you come here. One of you can be holder for Ashish. He'll show. Oh. Table spoil. ಒರೆಸ್ಬೋದಲ್ಲ ಯಾರು ಒಬ್ಳು ಇಲ್ಲಿ ಇದನ್ನ ಹಿಡ್ಕೊಳ್ಳಿ, ಒಬ್ರು ಇಲ್ಲಿ ಹೋಲ್ಡ್ ಮಾಡಬೇಕಾಗುತ್ತೆ ಈ ಥರ. ಅಲ್ಲಿ ಹಿಡ್ಕೊಳ್ಳೋದು ಬೇಕಾಗಿಲ್ಲ, ಬರೀ ಇಲ್ಲಿ ಮಾತ್ರ. ಇಲ್ಲಿ ಹಿಂಗೆ. ಯಾ, ಐ ಆಮ್ ನಾಟ್ ಯೆಟ್ ಲಿಫ್ಟಿಂಗ್, ಐ ಆಮ್ ಜಸ್ಟ್ ಹೋಲ್ಡಿಂಗ್. ಓಕೆ, ಎಳಿಬೇಡ, ಅಷ್ಟು ಹಾಗೆ ಇಟ್ಕೊ ಅಷ್ಟೇ. ಆಮೇಲೆ ನಿನ್ನ ಈ ಥಂಬ್ ಬಂದು ಹಿಂಗಿರಬಾರ್ದು. ಓಕೆ, ಅಷ್ಟು ಬಿ ಸಿ ಹೌ ಐ ಆಮ್ ಹೋಲ್ಡಿಂಗ್, making myself as less prominent as possible. This above here, just 2 fingers, gentle. Hold it like this. Okay. Irgsu ಸ್ವಲ್ಪ ಇಟ್ಕೊ. Lift your thumb. Hold now. Don't come out now. Okay. Stay there. So 3 layers. Okay. Yeah, 3 layers there, and then you go up. Just because that's where the cast ends, right? The edge is sharp, so it gives good padding. That's why same thing above at the groin. So you can see here wrinkling. Sometimes I'll just pull this out. Here it's not cutting easily. So if that's the case, you can make a half cut here with a scissor or something. But Webril usually it comes off easily here. Okay. And then you see that little wrinkle. Otherwise, that's what will happen. And then you do that. Posteriorly also is wrinkling a little bit. So. And then you finish with 3 layers here, okay? You can hold, just hold it there. So again, make sure it's tight. Okay. I usually open it so that way I can easily get the edge. Okay. Leave it until all the bubbles come out. Okay. And then I won't squeeze it very much, just a little bit. Okay. You can pull a little bit, yeah, there. So again, start here. Okay. Yeah. And 3 layers here, okay? Yeah, means, no, usually you'll hold it in the corrected position there, and then I won't move after that. Okay? But you can still move a little bit. Okay? And then as I'm going there, I'm pushing here so that there's no space, okay? This is pull and push technique, okay? Yeah, usually you hold it in the corrected position like that and then roll there. Yes. Manipulate it into the position you want it in, hold it there, and then you apply. Okay. So I'm push and pull, okay? At the same time, you're applying. Okay, so there's no space. Okay? And then you finish below the knee crease, you don't want to go very high. Okay? Yeah, if you want to cut ಮಾಡ್ತೀರಾ? I'm not pulling. Yeah, I'm making sure that's how. Yeah, both. Yeah. Okay, there. And then this one you'll make a blob, right? So make it into a blob. The first thing I do, so you come out here, hold there. Yeah. So I do this here, okay? Okay. Then after that, I'm going to feel the fibula. This is going to the lateral talar head. So I'm going to first correct supination, okay? With the first cast. You see how I supinated? I raised the first ray, okay? and it should be in line with the tibia here, okay? Now I'm going to manipulate, so I'm going to change hands. So this is one-handed grip, okay? And then I'm going to mold it here, okay? So I'm going to mold it here such that it doesn't slip. Okay. And then I'm going to keep changing it, okay? Okay. So this is supination, so you're correcting the first ray, okay? That's it, okay? So it's how it's nicely molded. So that's how it should look, okay? It's not tight. So I'm not gentle, okay? Yeah. So once it sets, now we'll cut, okay? And polish it as well. It should look good. So and then after you do this, then you open this here. So and then you'll complete the above knee part, okay? Usually I make a slab here, like 3 or 4 layers, and then put it here because when the child kicks, it's going to break at the knee, okay? Yeah, so, and then when this thing is open here, okay? Usually Ponseti puts his hand here, then use a hunter's knife and cuts this, but I usually use scissors, small scissor. I cut this part, and then invert it, roll it over. If you have a scissor or something, a knife, okay. It's not safe, but you do it with this. Okay. Usually that's not safe. My scissor, I have small. Even a big scissor is good. But anyhow, you get the idea. So that's how you do it. Okay. So this will be like this. Okay. You can see the toes is right at the end of the thing. Okay. And then you go ahead and finish it. Okay. Now you can see now this has got nice molding here. You know, and it's supinated in line with the tibia. Sorry? Yeah, just overlap it so that it smoothens out. After you complete, you can use half of it to complete this. Okay. Yeah. Take it out and we will do the next one. Remote. Any questions with the first, like elevation of the first ray to correct forefoot pronation or the midfoot cavers? That's the first thing to do, okay, like this one. Yeah, remaining you'll keep it in supination and then abduct. That's the next thing. You'll correct A and V at the same time. Forefoot adduction, hindfoot varus you'll correct. Last one you cannot correct with casting is ankle equinus. It'll correct to some extent because equinus comes from two places, for ankle and subtalar joint. Because of kinematic coupling, the subtalar equinus will correct, but ankle equinus will not correct. So for that, we'll have to do the heel cortinotomy. Okay. particular age, whenever the foot is ready. So depends on when you start casting, right? Minimum, usually if it's an idiopathic regular club foot, usually 4 to 6 casts, I'm corrected. If it's more like an orthogrypotic foot or atypical club foot, it may take a little bit longer, maybe 8 casts, but it all depends on how the foot is. Okay, next. So hold again. So yes, like you said, hold it in the corrected position. Now we have already supinated, right? So and then so hold it like that. Yeah, no, don't put your hand there. Put it, don't just two fingers. Okay, hold it right here. Okay? Yes. So like that. Hold it like that. Supinate it and hold it like that. So that's the next cast. It's already you corrected supination. Next, you're going to correct adduction, forefoot adduction and hindfoot varus at the same time. So you can see it's a little loose. You already used this cotton thing once. That's why it's kind of loose. Okay, hold it there. Water. Okay, so you're there. And then yeah, and then you start overlapping. It's a blob. Okay, so now first thing I do, you hold there. Okay. Can somebody hold the model? So this is remains in supination. So I put my hand behind the fibula and then just do this. Okay. So just and then this hand remains on the lateral talar head. Yeah. Yeah. It corrects forefoot adduction, hindfoot varus at the same time. Okay. And then you hold it like that, and then you keep changing your hands. Okay. So this is a double-handed grip. Okay. Fiberglass you can't use. You can use soft cast if you want, but it's more expensive probably in India, 3 times more expensive. No, soft cast you can mold. I use soft cast, but fiberglass you can't. Yeah, fiberglass you won't be able to. But soft cast you'll be able to. And then you just continue until you're fully abducted about 60 degrees. The foot should be 60 degrees in relation to the tibia. So it should be out here. And then that means on the hind foot is in valgus, okay? and then that's ready for foot anatomy. Until then, you have to continue casting. Okay. So you do this, and then you cut this here, roll it over, and it will look good. Okay. So now you can see here, hind foot is still in a little bit of varus. Okay. So you can see. Okay. Hind foot is still in varus. It's not ready. When it goes to valgus, and then it's making about 60 degrees in relation to the leg, that means ready for anatomy. Then until then you're not. Okay. Questions? Yeah, you can take it out. Any questions? Even in relapsed club feet, you start with casting. Like you said, it's going to make it more supple, reduces the amount of surgery you have to do. So whenever you're doing relapsed club feet, like we'll talk about it, you have to obtain correction, and then you have to maintain the correction. Well, if they are, like I said, 8-year-old or something, 9-year-old, if the foot is a little stiffer, then yes, once in 2 weeks. Otherwise, usually once in. Yeah, most of the time, biceps, it depends. It's not like a fixed rule. Sometimes you'll correct it in 4 weeks. Sometimes it takes 6 weeks. Sometimes it may take 8 weeks. Like Mark Monday, now, once a week. Sometimes one of the is like 28 casts. So the top of the foot is very, very stiff. Took him 28 casts to get it corrected. So usually 6, around 6. Sometimes it is not, it depends on 4, you could probably get it corrected. I would say wait 3 weeks. That's just one roll for below knee, one roll above knee, third roll, the knee, you make a slab, like I said, 3 or 4 or 5 layers of slab, like this one, you cut it, put it, layer it together, put it here, then complete that, and then cut this, and then pull that back, and then final one will be finished. So you leave it in 4 rows. 2 rows of this, yeah. And usually if you're needing 4 rows, or more than 4 rows, that means your technique is not good. If it's less than 4 rows, then it's great. Usually 4 rows is fine. Okay. C is the first cast. A and B next. Cast number 5. And then E you'll get a little bit of correction, but then you'll have to do unless, how to know means if you are in doubt, do the tenotomy. If you don't get more than 10 degrees, sometimes we don't do in the ankles, we do in the mid-foot. You're thinking it's coming to screen it under the skin. If you don't get more than 10 degrees ankles, you have to do tenotomy. we are done with the casting. But I have like 800 questions. Okay, so we'll go to the next technique. So casting, any questions? So these models you can also buy, and Gopi can give you the information. Like we don't sell it, but there are some companies who sell it, and they can give you the information, and you can use it in your hospitals to train yourself and your residents, fellows, etc., whoever is doing the casting, or even just familiarize yourself more. You can do it. It comes in 3 different models. Like one is the first cast, second one is from 3 to 5, and the last one is number 6. So, and you can use it. Okay. What is the next topic we're talking about? After casting, like tenotomy?
Or there is a break and then
Tenotomy, should we finish or we are breaking for lunch?
just told 5 minutes of interaction, question answers, and then we'll break for lunch. There's someone coming.
Okay.
Then we'll break for lunch. Some project.
Okay, so questions. Maybe we can show the tenotomy technique, right?
Yeah, we can show the video.
Yeah, we'll show you the video. Like, how do you recognize when the child is ready for tenotomy? So, like I said, when out of the cave, C, A, and V should be corrected. That means no cavus, no forefoot adduction, no hindfoot varus. Hindfoot should be in valgus. The foot is abducted 60 degrees in relation to the leg. That means ready for tenotomy. And the Pirani score should be kind of drifting down. It should be around like 1. In my hands, usually it's around 1. Everything else is corrected, just ankle equinus is remain. Okay. That's when you're ready for tenotomy. And then usually, where can you do the tenotomy? You can do it in clinic or you can do it under anesthesia. I am happy doing both, but depends on what you're comfortable with. Usually, means there are studies which say that anesthesia under the age of 1 year is not safe for the child. Well, it's safe for the child, but it's a little bit more riskier than no anesthesia, obviously. Okay, but there are studies which show I do it under anesthesia in the OR. Another advantage is you can't teach. If you're teaching somebody like a resident or somebody, you can't do it when the child is awake. Then I am just doing it myself. I don't trust somebody's child is awake. I am not trusting it's like resident's hand or something like that. Okay. So if for that purpose, because our hospital is a teaching hospital, I've got a lot of residents and fellows. If they have to do it, then I usually do it on anesthesia, because if they don't get it, if it's incomplete, then I can do it again. Otherwise, the child is crying and then legs are all over the place. It's kind of hard after that. And also, if it's bilateral, sometimes it's difficult, because what you can do is you can put Emler cream, which is a local topical ointment, 1% prilocaine ointment on top, leave it for half an hour, or you can inject some local 0.5% Marcaine without epi. You can inject like 2 ml around the incision site, wait for 10 minutes, and you can do the tenotomy. Those are other techniques. But if you put too much local, it can also obscure the anatomy there. Okay, so those are some things that you have to keep in mind. What you need, what is the equipment you need if you want to show. So what you need is like you need a number 64 beaver blade. You know, the cataract blade is very, very thin. You can ask your ophthalmology colleagues, they can show you. So that's called as a beaver blade. So number 64 is very, very thin. The tip is very thin. Number 15 blade or number 11 blade is still, number 11 is too sharp and too long. Beaver blade is what I use and what Ponseti recommends. So we use that. Okay, the incision is less than half a centimeter. So the ideal position, okay, you need the beaver blade, and you need like a hemostat to make sure you can feel, and then you need like a suture. I usually put 1 stitch. I usually use foromonocryl and then needle driver. That's all you need, and you need a scissor to cut. Okay, obviously some betadine, or usually we use chlorhexidine. You can use betadine, and then drapes, like four towels and something like that should be fine. Okay. Okay, yeah. As long as it's a clean environment, usually the parents don't come in. I ask them to stay out of the room. Usually the holder is there, you are there, and then one nurse, if you have, they can help set up, things like that. Okay. Yeah. So clean. And how do you identify the location? Like, you don't want to do it right here. If you want to point, you don't want to do it right here. Okay, because the tendon attaches here, but it expands. Okay, so the chances of being incomplete is high. So we usually go about 1.5 centimeters to 2 centimeters above on the medial side. I usually use my thumb here and then feel the tendon and then like indent the skin. Then I feel where it is, and that's where I'm making the incision. Why medial side? Because medial side is the more dangerous side, because the posterior tibial neurovascular bundle is there. So you start from the unsafe side and go towards the safe side. If you start from the lateral side, your knife, if it comes across, it may take the posterior tibial neurovascular bundle, so that's unsafe. So medial side is safe side, lateral side is suicide. Okay, so sometimes you may ask, like, the peroneal artery and then sural nerve is there, but yes, but it's less dangerous than the posterior tibial nerve and arteries. So that's why. So 1.5 centimeters above on the medial side. Okay, next please. Yeah, I would go 1.5 centimeter. Okay, so again, you're looking for three things. You're looking, you're feeling, look, listen, and feel. Okay, you're looking for the correction. As soon as you cut the tendon, it's going to pop. You will feel it. Okay, and then you will see the correction, and then you will also move the foot. Okay, the ankle immediately will go into dorsiflexion if you correct it. So three things. One other thing is, I use the hemostat before I cut the tendon. Once I make the incision in the skin, I use the hemostat to feel the tendon, because you want to go behind and in front. The knife should be in front of the tendon, so you're going to feel it. The model is here. We can show you. So this is the right foot. This is the great toe. So the child is kind of like this, right? This is the medial side. You can see the neurovascular bundle. You can take it around and pass it around. The artery. So you start on the medial side, okay? And then I usually feel with the hemostat. Do you have something to simulate it, like a pen or something? So you want to feel here. I go behind and also I go in front. Create a space with the hemostat where I can put the knife. Okay. I put the knife there. I don't hold the knife here. Okay. If you hold it and move it, the arc of movement is very, very large. Okay. So I hold it here, and you can see the arc of movement is small. If you hold it here and you do this, the knife will come out through the skin there. Okay. I've done that. Some residents have done it, so then I had to suture it. So I usually hold it very close to the knife blade, and then just a small click, and then it will pop. And then you put it under tension. You just do that, and it will say pop. Okay. And then after that, I put the hemostat back in, and then check for completeness. Sometimes if there is an incomplete band, then again you go back and complete it. Then I move the foot to see if it's dorsiflexed completely. So all those things. Then after that, then you suture. If there's bleeding, you just keep it pressed for a few minutes. It will stop, and you'll fine. Sometimes if you get, there are reported cases. Dr. Ronade has also reported on it. Like cases of pseudoaneurysm may develop like later, but usually it's okay. Most of the time you're fine. Okay. So that's the technique of the tenotomy. Other things some people have reported is mini open. If you can make a little bigger incision, put the tenotomy, bring the tendon out all the way, and then you can cut it under vision. That's a little bit more safer, but requires a little bit bigger incision. I think somebody from Delhi described it. It's there, I think, in JCU or JPUB. You can do that as well.
Video.
Yeah, okay. Video is there, you can watch now. Injecting local, right?
Yes, sir. So first you inject local anterior to the tendon and just deposit some medial and subcutaneously. Prepare the part. So always make sure you palpate for the tendon, feel where the calcaneum is, feel the medial, the lateral border before you go ahead, and always start from the medial side. So look for the calcaneal end, so you don't want to cut the calcaneum, which is high riding. We use 11, sir.
Yeah, if you go to your ophthalmology place, I'm sure you have ophthalmology college in your places. You can buy a cataract knife. You can get a cataract blade. You can use that. That's much safer than number 11. And then after that, whatever remaining local you have based on the weight of the child. If the child weighs, for example, 3 kilograms, you can use 3 ml. Child is 4, you can use 4 ml of 0.5% marking without a pain plane. And then we inject, we use 2 ml before, we can inject another 2 ml after. Usually they don't require any pain medication after this procedure. Most of the children, milk itself is fine. Very rarely I can prescribe some paracetamol or some Tylenol, like 1 ml, like 3 or 4 times a day, but most don't require anything. Just milk is fine.
The local is going to help you through that casting phase where you're stretching as well. So it just gives pain relief for the amount where you're doing tenotomy until you finish casting.
Any questions about tenotomy?
Needle tenotomy.
Like I said, that is not what Ponseti taught me. So I don't do it.
With the needle, most of the time you don't end up cutting the tendon in one go. So if you're doing it in the OPD setting and you know you have to keep digging to get the tenotomy done, it's going to be painful for the child and the parents also.
I agree, because the needle takes multiple things. You can't cut it with one stroke. And you're doing in clinic, it's harder. Yes, but if you use the cataract blade, it's the most safest. One cut, you're done. Okay, so especially if you're doing it in clinic. Okay, but like I said, don't try to modify the technique. Okay, because we all try to do that all over the world, and then you want to put our name. Belthor tenotomy techniques. I mean, no, stick to Ponseti's technique. It'll work completely. Okay.
No, tenotomy is just one simple cut. So it is not L shape. It is percutaneous and you're just snapping the tendon completely.
It's just a stab.
Complete transaction of the tendon. It will regenerate. There's a well documented thing, it regenerates very well.
So ultrasound studies have been done before and after. Following them, by 3 weeks, it's all completely healed.
So you can actually see this. I don't know how clear you all can see it, but this is a child who has undergone a TA lengthening procedure later on.
Turn the lights down, please.
Gopi, can you turn the lights off? Gopi, lights off. So this is a child who has undergone another procedure later on, and when we have opened and seen the TA tendon, she's already undergone a tenotomy way back. So the tendon is as good as new. So it heals completely without much scarring. Without suturing.
No suturing.
No suturing. We are not going to suture the tendon.
There's no repairing or anything like that.
Even almost 15, 20 years.
Even after that, like for example, previously, when they kept people like in prison, like people, the Britishers used to keep them in the Andaman and Nicobar Islands. To prevent them from running, they used to cut the tendon, heel cord. But then it regenerated within a few months in adults. Okay. In a child, it will regenerate in 3 weeks. So no need to repair, no need to do anything. Nature will take care of itself.
Actually, even a closed tendon rupture, if it is not open and you can treat it with just cast with, dorsiflexion, plantar flexion, and it heals well, even in adults. It's only when you open and you disturb the local pathology that the healing doesn't happen.
Okay, any other questions on tenotomy? Right away? At the end of the procedure, you put it on. Sorry? Like I said, you have to wait pressure until it doesn't bleed.
It usually takes about 5 minutes. Wait for 5 minutes. Or if it's a busy clinic, you ask the parents to give the pressure, go feed the child and come back. By then the bleeding would have stopped.
If your technique is good, it won't bleed. Like I tell you, I've done like 800 of this, it won't bleed. Very rarely, if you have just hold pressure 5 minutes, you'll be fine.
So the casting after tenotomy is in maximum abduction, that's about 70 degrees of abduction, and maximum dorsiflexion, that's more than 10 to 15 degrees of dorsiflexion. And this cast is kept for 3 weeks.
So if you don't put the foot in that position, when you come to brace, it's like putting a square ball in a round hole. So you can't kick, you can't have the foot in 30 degrees abduction because the brace is going to be in 60 degrees of abduction. You can't then abduct the foot 60. You have to have the foot in that position. If it's not in, that's where they'll have brace incompliance, or somebody was saying like sores and things. That's why that happens. If you haven't gotten 10 degrees of ankle dorsiflexion, again you'll get a sore on the heel because you've not corrected it fully. Okay? But we'll talk about that in bracing. Any other questions? Not at this time. For relapses, yeah, we can talk about that, but not in the initial thing. No. Okay, so we're going to take a break. Yeah, I think.
I really thank Dr. Mohan for his patient listening to all the questions posed by our orthopedicians. Thank you, sir. Thank you for so much for it. We have our project director, Dr. Srinivas, who's very young, energetic in the entire Arogya Sauda. So he was so keenly interested. He was at Delhi, just got back late night, and then we just got to know that he's back. Actually, he was scheduled to come back on Monday, but luckily we have him here. Sir, we welcome you for this particular session. So thanks for joining us on this day, and we require your kind address. Kindly address the camera.
I'll take only 5 minutes. I know it's very lunchtime. Dr. Mohan, please, sir. Pleased to see your biodata, sir. Hands up. Be seated, sir. So, respected Dr. Mohan, sir, and our most active, very cheerful, always Dr. Veena madam, and all the participants. Kannada barutta, sir? Kannada? You Kannada. So, because I am always talking in Kannada, I like to talk in Kannada. So, Daimadi, NHM, all orthopedicians, all orthopedicians from? In this districts? Okay. KC General Hospital, Dr. Mohan Jadhav? Yarappa? Naveen Doctor, okay. Then SNR Hospital? Mask tegeyappa, now mask is off, no? Okay. Then Tumkur District Hospital? Suresh sir, okay. I spoke to you, Suresh, regarding that one case. And Koppal? Okay, sir. You are in a medical college or our side? No, you are a teaching faculty. Very nice, sir. Oh, great, sir. Happy to see you. And Hubballi? You are in teaching side? No, both are in faculty, or and there are the medical college. We have our orthopedicians also posted. Okay. Hubballi, where are working, sir? PGs. Oh, this is not run with. No, PGs come see our program will go on for like they have only PGs, they will finish their course and go. Insist just for representation they would come because they are helpless. HOD has posted them, they have come. Neevu tavyaro? No. Who are you? Who? Be seated. No. To represent, anybody can represent. To get into the program, see, program go on for a long time, no? No, we have to train a right person, no. They are PGs, no. They finish their job and go. They need not get involved in our program. And how long they will be? Which year, sir? Second year, they will pass out and go. Chikbalapur, in a medical college or this side? District hospital. You are a regular orthopedician? Or bond doctor? Okay, right. And Gadag? Tavu, sir? Gadag hospital, Allah, Taluk hospital, yavadu, sir? Shirhatti. Okay, right. And the Megan? Again here, Megan hospital? No representation. Shikaripura. Okay, right. Anyway, you are representing Shumaga district, not Megan Hospital, no? Okay. Then Karwar Teaching Hospital, KIMS. Who has come? See, madam, why I am asking is the NHM program ideyalla. I was a physician for 20 years in Yelahanka Hospital. Nobody has told anything about any program. Ella ittalla. I was there since 2002 to 2019. So now NHM program involve ಮಾಡಬೇಕು ಅಂದ್ರೆ ಅದೇನು additional work ಅಲ್ಲ. So it's NHM has to ask them to do the work. They will be doing. Clubfoot ಒಂದು ಮಾಡ್ತಾ ಇರ್ತಾರೆ. TB ಬಂದರೂ ನೋಡ್ತಾ ಇರ್ತಾರೆ. ಡಯಾಬಿಟಿಸ್ ಬಂದರೂ ನೋಡ್ತಾ ಇರ್ತಾರೆ. ನಮ್ಮ ಪ್ರೋಗ್ರಾಮಲ್ಲಿ ಇನ್ಕ್ಲೂಡ್ ಆಗಬೇಕು ಅಂದರೆ ವಿ ಹ್ಯಾವ್ ಟು ಗೋ ಆ್ಯಂಡ್ ರೆಪ್ರೆಸೆಂಟ್. ನೋಡಪ್ಪ ಈ ಥರ ಪ್ರೋಗ್ರಾಮ್ ಇದೆ, ಗೆಟ್ ಇನ್ವಾಲ್ಡ್ ಇನ್ ದಿಸ್, ರೆಕಾರ್ಡ್ ದಿಸ್, ಆರ್ ಎನಿ ಪೇಷಂಟ್ ಕಮ್ಸ್ ವಿತ್ ಎ ಸ್ಟ್ರೋಕ್, ವಿ ಹ್ಯಾವ್ ಎ ಸ್ಟೆಮಿ ಪ್ರಾಜೆಕ್ಟ್ ಅಂತ ಇದೆ, ಅಲ್ಲಿ ಮಾಡಬೇಕು. ಒಂದು ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್ ಬಂದರೆ ಸ್ಟೆಮಿ ಪ್ರಾಜೆಕ್ಟ್ ಇದೆ, ಬ್ರೈನ್ ಇನಿಷಿಯೇಟಿವ್ ಅಂತ ಒಂದು ಪ್ರೋಗ್ರಾಮ್ ಇದೆ, ಗೆಟ್ ದೆಮ್ ಇನ್ವಾಲ್ಡ್ ಅಂತ ಒಂದು ಮಾಡಲಿಕ್ಕೆ ಒಂದು ವೇದಿಕೆ ಮಾಡಬೇಕಾಗ್ತದೆ ಮೇಡಮ್. ಅನ್ಫಾರ್ಚುನೇಟ್ ಇಟ್ಸ್ ನಾಟ್ ಹ್ಯಾಪನಿಂಗ್ ಇನ್ ದಿ ಮೋಸ್ಟ್ ಆಫ್ ದಿ ಪ್ಲೇಸಸ್. ಈಗ NCD ಪ್ರೋಗ್ರಾಮ್ ಇದೆ. Nobody go and tell to every doctor that 30+ ಇರೋ ಡಯಾಬಿಟಿಸ್ ಆರ್ಥೋಪೆಡಿಷನ್ ಹತ್ರ ಹೋಗ್ತಾರೆ. ಇನ್ಸಿಡೆಂಟ್ಲಿ ನೀವು ನೋಡಿದಾಗ ಒಂದು ಶುಗರ್ ಚೆಕ್ ಮಾಡಿಸ್ತೀರ 400 ಇರುತ್ತಲ್ವಾ, ಅವಾಗೇನು ಮಾಡಿದೆ, ನಿಮ್ಗೆ ಏನಾದರೆ ಫಿಸಿಷಿಯನ್ ಹತ್ರ ಕಳಿಸ್ತೀರ. ಅದಂಗಲ್ಲ, NCD ಎನ್ರೋಲ್ಮೆಂಟ್ ಆಗಬೇಕಾಗ್ತದೆ. ದಟ್ ಯು ಆರ್ ನಾಟ್ ಬಾದರ್ಡ್ ಬಿಕಾಸ್ ಯು ಆರ್ ನಾಟ್ ಬಿನ್ ಟೋಲ್ಡ್. ಸೊ NHM ಪ್ರೋಗ್ರಾಮ್ ಯಾವುದೇ ಮಾಡಬೇಕು ಅಂದರೆ ವಿ ಶುಡ್ ಹ್ಯಾವ್ ಬಿನ್ ಲೈಕ್ ಎನ್ ಏಜೆಂಟ್, ಇನ್ಶೂರೆನ್ಸ್ ಏಜೆಂಟ್ ಹೋಗಿ ಮನೆಗೆ ಹೋಗಿ ಇನ್ಶೂರೆನ್ಸ್ ಮಾಡಿ ಅಂತ ಕೇಳಿದಾಗ ಅದು ಬೆನಿಫಿಟ್ ಬರುತ್ತೆ. ಬಟ್ ಹಾಗೆ NHM ಪ್ರೋಗ್ರಾಮ್ನ ಇನ್ವಾಲ್ವ್ ಮಾಡ್ಕೊಬೇಕು ಅಂದರೆ ರೆಗ್ಯುಲರ್ ಡಾಕ್ಟ್ರಿಗೆ ಅವರ್ ಟೀಮ್ ರೆಪ್ರೆಸೆಂಟೇಟಿವ್ ಅಟ್ ವಾಟ್ ಎವರ್ ಲೆವೆಲ್ ಶುಡ್ ಗೋ. ಈ ಥರ Clubfoot ಈ ಥರ ಇದೆ, ಮೋಹನ್ ಈಸ್ ಕಮಿಂಗ್ ಆ್ಯಂಡ್ ಡೂಯಿಂಗ್ ದಿಸ್ ವರ್ಕ್, ದೆನ್ ಓನ್ಲಿ ಮೆಟೀರಿಯಲ್ ಈಸ್. ಅದರ್ವೈಸ್ ಐ ಆಮ್ ಫೇಸಿಂಗ್ ಲಾಟ್ ಆಫ್ ಪ್ರಾಬ್ಲಮ್ ವಿತ್ ಮೈ ಓನ್ ಡಿಪಾರ್ಟ್ಮೆಂಟ್. ಒಂದು ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ಸರ್, NHM ಈಸ್ ಎ ಬೂನ್ ಟು ಅವರ್ ಡಿಪಾರ್ಟ್ಮೆಂಟ್. ಇಟ್ಸ್ ಅ 3.5 crore ಪ್ರಾಜೆಕ್ಟ್. ದಯಮಾಡಿ ಅರ್ಥ ಮಾಡ್ಕೊಳ್ಳಿ, ಇದು 3,500 ಕೋಟಿ ಪ್ರಾಜೆಕ್ಟ್ ಗಿವನ್ ಟು ಸ್ಟ್ರೆಂಥನ್ ಅವರ್ ಡಿಪಾರ್ಟ್ಮೆಂಟ್. ಇಸ್ ನಾಟ್ ಪ್ಯಾರಲಲ್, ಇಟ್ಸ್ ಸ್ಟ್ರೆಂಥನಿಂಗ್. Another 1.5 year for all youngsters. 1.5 year, if you don't show good progress, they may withdraw the project. It's a great loss to our poor people. Please, ದಯಮಾಡಿ, there are many schemes been unused, sir. So many schemes are not been utilized, not able to use the. We are surrendering 700-800 crores back to the central government. Please pass on this benefit to them. So ದಯಮಾಡಿ ಇದಂತಲ್ಲ, I will not take anyway, sir is there, I will not go into the details of what is being told here. Is an expert. ಒಂದೇ ಒಂದು ಅಂಗವಿಕಲತೆ, ಯಾಕೆ ಒಂದು ಮಗು ನಾವೇ ಒಂದು ಹಿಂಗೆ ಹುಟ್ಟಿದರೆ ಹೆಂಗಿರ್ತಿತ್ತು. ಯು ಶುಡ್ ಹ್ಯಾವ್ ನಾಟ್ ಸಿಂಪತಿ and empathy. Post graduate, what's your good name, sir? Tell me what is the difference between sympathy and empathy. Sympathy is ಕರುಣೆ. ಯಾರು ಬೇಕಾದ್ರು ಅಯ್ಯೋ ಪಾಪ ಅನ್ಬೋದು, ಹೌದಪ್ಪ. ಬಸ್ಸಲ್ಲಿ ಹೋಗ್ತಾ ಇರ್ತೀರ, ಹಿಂಗೆ ಕೂತಿರ್ತೀವಿ, ಅಜ್ಜಿ ಬರ್ತಾರೆ, ಅಜ್ಜಿಗೆ ಸೀಟ್ ಇಲ್ಲ ಅನ್ನೋದು ಸಿಂಪತಿ. ಎಂಪತಿ ಏನು ತೋರ್ಸೋಕ್ಕಾಗುತ್ತೆ? ಲೆಟ್ ಮಿ ಸಿ. ಅಲ್ಲಲ್ಲ, ಅದು ಆ ಪ್ಲೇಸಲ್ಲಿ ಇದ್ದರೆ ನೋವಾಗ್ತದೆ ಅಷ್ಟೇ. ನೀನು ಕೂತಿದ್ಯಾ, ಒಮ್ಮ ನಿಂತಿದೆ, ನೆಕ್ಸ್ಟ್ ಏನಾಯ್ತಪ್ಪ, ನೀ ಎದ್ದು ಸೀಟ್ ಕೊಡ್ತೀಯಲ್ಲ, ಅದು ಎಂಪತಿ ತಮ್ಮ. ಅನ್ಫಾರ್ಚುನೇಟ್ಲಿ ಈಸ್ ನಾಟ್ ಬೀನ್ ಟಾಟ್. ಐ ವಿಲ್ ಜಸ್ಟ್ ರಿಮೈಂಡ್ ಆಲ್ ದ ಡಾಕ್ಟರ್, ಐ ಹ್ಯಾವ್ ಟ್ರಾವೆಲ್ಡ್ ಎಂಟೈರ್ ಎಕ್ಸೆಪ್ಟ್ Karwar. All doctors only know. Now I am free to talk certain thing about ourselves. We have to have introspection. When I joined medical college in 1981, just get the picture how medical college was. That's why a village boy able to stand in front of you, talk like this. There was a strict teacher. Have you heard about Kanta madam? Anatomy. She is very strict. All strict teachers are bad teachers. ಹೌದಪ್ಪ, ಆಲ್ ಸ್ಟ್ರಿಕ್ಟ್ ಟೀಚರ್ ಆರ್ ಬೇಡ. ಅದೊಂದು ಸಾಂಗ್ ಇದೆ ಮೇಡಮ್, ಭಾಳ ಒಳ್ಳೆಯ ನಮ್ಮಿಸ್ಸು ಊರಿಗೆಲ್ಲ ಫೇಮಸ್ಸು, ಯಾಕೆಂದ್ರೆ ಏನು ಕೇಳಿದ್ರು ಎಸ್ಸು. ಅದಾಗಬಾರ್ದು. ನಾವು ಎ ಟೀಚರ್ ಶುಡ್ ಬಿ ಎ ಸ್ಟ್ರಿಕ್ಟ್, ಎ ಡಾಕ್ಟರ್ ಶುಡ್ ಬಿ ಸ್ಟ್ರಿಕ್ಟ್. ಇಫ್ ಐ ಆಮ್ ಸ್ಟ್ರಿಕ್ಟ್ ಇನ್ ದ ಸೆನ್ಸ್ ಫಾರ್ ದ ಬೆನಿಫಿಟ್ ಆಫ್ ದಿ ಪೇಷಂಟ್. ಅವಾಗೆಲ್ಲ ನಮ್ಮದು ಶಂಕರ್ ನಾಗ್, ಅನಂತ್ ನಾಗ್ ಸ್ಟೈಲ್, ಸ್ಟೆಪ್ ಕಟ್ಟಿಂಗ್ and ಗೊತ್ತಲ್ಲ, we went like that medical college. It reminds me that one word made you a better doctor. She was a very strict teacher. There is a rule in medical, you may laugh at this issue. Those are the point. I am standing in front of you. I am a very rich man today, but just practicing that. I am a very popular physician, just following the simple words of a teacher. ಹಿಪ್ ಕಟ್ಟಿಂಗ್ ಎಲ್ಲ ಮಾಡೋದು. ದೇರ್ ವಾಸ್ ಅ ರೂಲ್ ಇನ್ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ದೋಸ್ ಡೇಸ್. ಹುಡುಗಿಯರೆಲ್ಲ ಸೀರೆ ಹಾಕಲೇಬೇಕಾಯಿತು ಕಂಪಲ್ಸರಿ. ನೋ ಇಯರಿಂಗ್ಸ್, ನೋ ಫ್ಲವರ್ಸ್, ನೋ ಈ ದ್ರೌಪದಿ ಥರ ಬಿಟ್ಕೊಳಂಗಿಲ್ಲ ಎಂಥದ್ದು ಬಾಬ್ ಕಟ್. ಇಟ್ ಶುಡ್ ಬಿ ಟೈಟ್ ಬಿಕಾಸ್ ದ ರೀಸನ್ ದ್ಯಾಟ್ ಶುಡ್ ಟು ಬಿ ಲೈಕ್ ದಟ್. ಹುಡುಗರು ಶೂ ಇರಬೇಕು, ಇನ್ ಶರ್ಟ್ ಇರಬೇಕು, ಐರನ್ ಶರ್ಟ್ ಆ್ಯಂಡ್ ಎ ಗುಡ್ ಹೇಪ್ರಾನ್ ಆ್ಯಂಡ್ ನೀಟ್ ಹೇರ್ ಕಟಿಂಗ್. ದಿಸ್ ವಾಸ್ ದಿ ಅನ್ಟೋಲ್ಡ್ ಥಿಂಗ್. ಆವಾಗ ಹೇಳ್ತಾಯಿದ್ರು ಶಿ ವಾಸ್ ಸ್ಟಡ್. ಅವೆಲ್ಲ ಓನ್ಲಿ 4 ಮೆಡಿಕಲ್ ಕಾಲೇಜ್, ಬ್ಯಾಂಗ್ಳೂರು, ಹುಬ್ಳಿ, ಮೈಸೂರು ಆ್ಯಂಡ್ ಬಳ್ಳಾರಿ. There are only 2 medical in the, I'm talking of 1987. Hubli, Ballari, KLE and Manipal. There are only 7 medical colleges. So naturally all government merited students invariably from rural background, where most of them are very poor. Most of them are very poor. Some 10% people are very rich, they are affluent. ಅವರೆಲ್ಲ ಬಂದರು. ನೆಕ್ಸ್ಟ್ ಡೇ ಹೇಳಿದ್ರು, ಮೇಡಮ್ ಎವ್ರಿಬಡಿ ಹ್ಯಾಡ್ ಎ ನೀಟ್ ಹೇರ್ ಕಟ್ ಆ್ಯಂಡ್ ವೆನ್ 2 people didn't win. One is a son of an MLA, another is son of some forest officer. I have friends, they are working here, I don't tell their name. They didn't come because they had an audacity, what this professor done. Every we followed like this, we came. They called those two students, doctor. They used to talk like that. Hey doctor, some word I forgot. If you can't do this, think that you are chosen a wrong profession. Better change your profession now. You are jubilant now. When the moment you get into medical college, all will be jubilant. After one exam, one test, all are equalized. No, first rank student as tense as the last bench student. In fact, last bench student very happy because he knows how to face life. The first rank is always worried because he can't maintain it. In medical colleges, everything is leveled there. This is the word I tell you. That's a way we have pruned. Empathies, sympathies, bedside manners not been taught in medical college. They should have been. They should have been. I'm sorry to say, madam, I'm praying God to get retired very fast because I can't tolerate these certain things. But if I shout, I become a bad doctor. If at all, if you want to be empathetic to the patient. Why quacks are thriving? Because they're sympathetic. We are sympathetic. Okay? You got my point, doctor? ಅಜ್ಜ ತಾತ ಅಲ್ಲಿ ವಯಸ್ಸು ನೀನು ಎದ್ದು ಜಾಗ ಬಿಟ್ಟಾಗ ತಮ್ಮ ನನಗೆ ಒಂದು ಹಿಂಗೆ ಕ್ಲಫ್ಫುಟ್ ಅದು ಹಿಂಗೆ ನಡೀತಾ ಇದ್ದರೆ ಏನು ಬೇಡ, ನೀವು ಇಮ್ಡಿನ 2 ದಿನ ನಡೀರಿ ಸರ್. ಒಂದು ಮುಂದೆ ಏನೋ ಹೆಬ್ಬೆಟ್ಟಿಗೆ ಗಾಯ ಆಗಿರುತ್ತೆ, ಇಮ್ಡಿಲಿ ನಡೀರಿ ಸರ್ 2 days. ಬೇಡ, ಹೀಲಲ್ಲಿ ಒಂದು ಪೇಯ್ನ್ ಆಗಿರುತ್ತೆ. ಯು ಟ್ರೈ ಟು ವಾಕ್ ಇನ್ ದ ಟೋಸ್. You know the difficulty. I request all of you, you come across these things many times. No, you come across. Please be empathetic. Now government scheme is there. There are people. Just bridge. You should become an ambassador of all this program. That's all I can. Odida odu odalla. Meda kabbina sippe. Odida odanariದರೆ ಆ ಸಿಪ್ಪೆ ಕಬ್ಬಾದಂತೆ ಸರ್ವಜ್ಞ. You got my point? ನಾನು MBBS MD ಮಾಡಿದೆ, ಬೋರ್ಡ್ ಹಾಕ್ಕೊಂಡೆ, ಎವ್ರಿಬಡಿ ಸೋ MD doctor. But unless I see patient, my MD has no value. MD person, metformin ಎಲ್ಲರೂ ಬರೀತಾರೆ ಡಯಾಬಿಟಿಸ್ಗೆ. If a chronic diabetic comes to me, writing metformin is a quackery to me. Pick up chronic diabetes, whether he has an exertion of breathlessness, has aches and pains somewhere, or developing a premature senile cataract, or think that urine has an albumin, then MD might qualify. Because urine albumin is the first stage of diabetic nephropathy. You can reverse. So Daimadi specialist, I have a lot of vision to your there is a saying, MBBS is a given degree. Given degree. It has to partially second, third and MD degree should be earned. This is what the word was told. One intelligent one of my classmates was failed. Then incidentally I knew the professor. He said, sir, he is a rank student. No, he has a rank student, but he has a lot of audacity. Now he failed just to trim his this thing. I don't want to give such a powerful degree for the young man. That was the thinking. Now, you know the systems have gone. That's why, unfortunately, we don't have a good teachers like that. No, we have to teach, learn by ourselves. ನಿನಗಾರು ಗುರುಹಿಹರು, ನೀನೊಬ್ಬ ತಬ್ಬಲಿಗ, ಉಣುತ ಕೆಳದಿ ಕೂತ್ಕೊಪ್ಪ ಪ್ಲೀಸ್ ಬಿಸಿಟ್, ಉಣುತ ಕೆಳದಿ ಸಿಕ್ಕಿದ ಎಂಜಲಗಳನ್ನು ದಿನವಕಳೆ, ಗುರು ಶಿಷ್ಯಗಳ ಪಟ್ಟಗಳು ನಮಗೇಕೆ, ನಮಗೆ ನಾವೇ ಗುರು ಓ ಮಂಕುತಿಮ್ಮ. ನಾವು ಏನೋ ಎಂಪತಿ ಅಲ್ವಪ್ಪ, ನೀನು ಸೀಟಲ್ಲಿ ಬಂದಿರ್ತೀಯ, ಒಂದು ಇಲ್ಲಿಂದ ಅಲ್ಲಿಗೆ ಹೋಗೋ ಅಷ್ಟೊತ್ತಿಗೆ ಒಂದು ಹಾಫ್ ಆನ್ ಅವರ್ ಆಗ್ಬೋದು. ಇಫ್ ಯು ಆಫರ್ ಎ ಸೀಟ್ ಫಾರ್ ಹಿಮ್, ಸ್ಟ್ಯಾಂಡ್, ಈ ಮೋಸ್ಟ್ ಆಫ್ ದಿ ಟೈಮ್ ಈ ಮೀನ ಡಾಕ್ಟ್ರು ಪರವಾಗಿಲ್ಲ ಕೂತ್ಕೊಳ್ಳಿ ಸರ್ ಅಂತ ಇರೋದು, ನೆವರ್ ಸಿಟ್. ಯು ಆಫರ್ ಎ ಸೀಟ್, ದನ್ ಇಸ್ ಅನ್ ಎಂಪತಿ. So whenever a patient come, my mother come with this thing, maybe she came for backache or some orthopedic problem, just pick up and try to bridge. This all my request, sir. Rest if you show the way, they will way. If you diagnose the diabetes, then let him take wherever a treatment. Show that is 400 sugar. Like that, whenever a patient come with, we have a lot of ashas, they bring the patient to you. Please, whenever Asha brings to you a patient, whenever field staff bring the patient, think that they were with them for a long time. Please respect their service. That's all my request. If any reference from the lower doctors, fortunately you all come up straight away to specialist. We know the pain of being a PSC doctor. One penicillin reaction, we didn't have money to get some medicine. We used to purchase medicine in those times. One penicillin reaction, we used to spend 100 rupees on those days. We used to get 2,000 rupees salary. But penicillin was the only tool for us. We started career with kerosene stove and a glass syringe. I think if I retrospectively see that Lacvina made me a better doctor. Because of no option, because patient can't prescribe, there was no medical store, and there is no affordability. There is no transport. If I look back, I think I have done a great work. That's the way one doctor should evaluate yourself. How much you do. Fracture ಮಾಡೋದು ಎಲ್ಲರೂ ಮಾಡ್ತಾರೆ, ಹೌದಾ? Fracture ಮಾಡೋದು is inevitable. When you pick up unsigned in these things, when a patient come with an extra, yesterday I had a patient with locaicta, what's his son is a lawyer. He came with the extra, then ಡಿಜಿಟ್ ಬರ್ತಲ್ಲ, ಪಾಲಿಡಾಕ್ಟೈಲ್. ಐ ಸೆಡ್ ಯಾಕಪ್ಪ ಹೀಗೆ ಮಾಡಿದ್ದೀರಾ? ಇಲ್ಲ ಸರ್ ತೆಗೆದ್ರೆ ಹಿಂಗಾಗುತ್ತೆ ಹಂಗಾಗುತ್ತೆ. ಐ ಸೆಡ್ ಯು ಆರ್ ಎ ಲಾಯರ್. The ಮಗುಗೆ difficult it is, somehow caught in, may get pain. I only get him nothing will happen. I convince them. So this is a way. He came for something else. But how much pain undergo the baby, and they go to school also, they make a fun of that. No? ತುಂಬ ಗೇಲಿ ಮಾಡ್ತಾರೆ ಹುಡುಗರಿಗೆ. ಸೊ ಆ ಥರ ಎಂಪತಿ ಇಟ್ಕೊಂಡಾಗ we can do a lot of things in our department. So what is to chief complaint is the patient who has brought the patient. What are the other things when you take a family history, when you take the general physical examination, you do find a lot of things. Sir, anemia, 65.5% crores of rupees spent on anemia. ಅನಿಮಿಯಾ ಮುಕ್ತ ಭಾರತ ಅಂತ ಹೊಡ್ಕೊಳ್ತಾ ಇದೀವಲ್ಲಪ್ಪ. ಅನಿಮಿಯಾ ಮುಕ್ತ ಯಾರೆಲ್ಲ ಟ್ರೀಟ್ ಮಾಡಬೇಕು ಗೊತ್ತಾ? ಎನಿಬಡಿ? It's everybody should involved. Any doctor come with a general physical examination. It's a must for any case, sir. You have to find out whether anemia is there, icterus is there, pedal edema is there, cyanosis is there. For anybody, it's a must. General medicine is a mother of all medical branches. Suppose a patient is a jaundice, you can't operate. Or who knows HbA1c positive. Or patient with an HbF6, he may be heart failure. He is unfit to be son. Say, please correct the. Or patient incidentally diagnosed a diabetic. Please see that. Don't just wash your hands. So like that, I request all the orthopedicians, Daimadi, Bandaga, there is a called bilateral, looking beyond the problem. Patient come for something, you have to look beyond the problem. Fracture agide, yake, old age fracture, maybe is a hypertensive. No? Our patient maybe have a double vision. Patient may be an vertigo. No, sir. Patient have a neuropathy. Fracture is your problem. But why is that problem? Why falls are more dangerous in old age rather than cancer? Cancer is treatable or patient is to die. If the patient have a fracture neck of femur, being a physician, I know how much problem one fracture in a small family, the economy of the family is destabilized. ಗೌರ್ಮೆಂಟಲ್ಲಿ ಮಾಡಲ್ಲ, ಪ್ರೈವೇಟ್ ಹಾಲ್ ಆಗೋಲ್ಲ. ಸೊ ದಯಮಾಡಿ ಪ್ಲೀಸ್, ವೆನ್ ಎವರ್ ಎ ಪೇಷಂಟ್ ಕಮ್ಸ್ ಟು ಯು, there should be a holistic approach. Should be a holistic approach. Then only things will move. Keeping this, sir, thank you for your gesture shown to us, sir. Definitely, ನೀವು ಯಾವಾಗ ಇದನ್ನು ದಯಮಾಡಿ ಈ ಸ್ಕೀಮು ಅಲ್ಲಿ ರೀಚ್ ಆಗಬೇಕು ಅಂದರೆ ಯು ಆರ್ ದ ಓನ್ಲಿ ಪರ್ಸನ್ ಟು ಪಿಕಪ್ ಥಿಂಗ್ಸ್. ಶಿರಾಟಿ ಯಾರ ಡಾಕ್ಟ್ರು? ನೋಡಿಯಪ್ಪ, ನಿಮ್ಮಂಥವ್ರು ಅವ್ರಿಗೆ ಗದಗ ಕಳ್ಸೋದು ಬೇಡ, ಅಲ್ಲೇ ಮಾಡಿ. ಆದರೆ ಒಂದು ಕ್ಯಾಸ್ಟ್ ಹಾಕೋದು ಇಂಥ ಫೈಟ್ ಇದೆ. ವಿ ಹ್ಯಾವ್ ಎನಫ್ ಮನಿ ಟು ಡೂ ದ್ಯಾಟ್. ದಯಮಾಡಿ ನಾನು ವೈ ಹ್ಯಾವ್ ರಿಕ್ವೆಸ್ಟ್ ಯು ಈಸ್, ನಿಮ್ಮ ಶಿರಟ್ಟಿ ಫಕೀರಪ್ಪನ ಗದಗ ಕಳಿಸಿದ್ರೆ ಹೋಗೋಲ್ಲ ಅವನು. ಹಂಗೆ ಇಡ್ಲಿ ಬಿಡಿ ಎಲ್ಲ ಅವ್ನಿಗಿಲ್ಲ ಸ್ವಾಮಿ, ನಮ್ಮ ಐನವ್ರು ಹೇಳೋರೆ ಈ ಕಾಲು ಹಿಂಗೆ ಮಾಡಿದ್ರೆ ಸರೋಗತ್ತೆ, ಇದು ಪುಣ್ಯ ಕರ್ಮ ಏನೇನೋ ದೇಹ ಲಾಟ್ ಆಫ್ ಸ್ಟೋರಿ. ಸೊ ದಯಮಾಡಿ ಅಂತ ಮಾಡಿ ಕೊನೆಯದಾಗಿ ನಾನು ರಿಕ್ವೆಸ್ಟ್ ಮಾಡ್ಕೊತೀನಿ, ಮಣಿ ಮಂತ್ರ ಬಿ ಸಿಟೆಡ್ ಸರ್. ಮಣಿ ಮಂತ್ರ ತಂತ್ರ ಸಿದ್ಧಿಗಳ ಸಾಕ್ಷಿಗಳು ನಿನಗೇಕೆ ದೈವದ ಅದ್ಭುತವ ಮನಗಾಣಿಸಲು, ಮನುಜರಲ್ಲಿ ಆಗಾಗ ತೋರ್ಪ ಮಹನೀಯ ಗುಣ ಬೊಮ್ಮನ ಅನುವಾದ ಮಂಕುತಿಮ್ಮ. ಮಣಿ ಮಂತ್ರ ತಂತ್ರ ಯಾವುದು ಬೇಡಂತೆ ದೇವರು ತೋರಿಸ್ಲಿಕ್ಕೆ. ನೀವು ನೋಡಿರ್ಬೋದು, ಯಾವುದೋ ಒಂದು ಫ್ರ್ಯಾಕ್ಚರ್ನ ರಿಪೇರ್ ಮಾಡ್ತೀರಾ, ಲೈಫ್ ಲಾಂಗ್ ನಿಮ್ಮ ಹೆಸರು ಹೇಳ್ತಾರೆ. ಸೊ ಡೈಲಿ ಯು ಬಿಕಮ್ ಎ ಗಾಡ್. ಮನುಷ್ಯರು ದೇವರಾಗೋದು ಗೊತ್ತಿಲ್ಲ, ಬಟ್ ನಾವು ದಿನ ದೇವರಾಗ್ಬೋದು ಅಂತ ಸಿಚುವೇಶನ್ ನಮ್ಗೆ ಕ್ರಿಯೇಟ್ ಆಗ್ತದೆ ಸರ್. ಐ ಹೋಪ್ ಯು ಅಂಡರ್ಸ್ಟ್ಯಾಂಡ್ ದ ಪೇಯ್ನ್ ಬಿಹೈಂಡ್ ಮೀ. ಸೊ ಅಂಥ ದಯಮಾಡಿ ಅಂಥ ಶಕ್ತಿ ನಿಮಗಿದೆ. ನಾವು ಆಫ್ಟರ್ NHM ಅವರ್ ಹಾಸ್ಪಿಟಲ್ ಬಿಕಮ್ ಟಾಪ್ ಹಾಸ್ಪಿಟಲ್ ಸರ್. ವೇರ್ ಲಕ್ಕಿ ಟು, ಅಲ್ವಪ್ಪ? ನಾವು ಸೇರಿದಾಗ ಒಂದು ಚೇರ್ ಇಲ್ಲ, ಒಂದು ಕೂರಕ್ಕೆ ಒಂದು ಕುರ್ಚಿ ಇರಲಿಲ್ಲ, ರಿಫ್ರಿಜಿರೇಟರ್ ನೋಡಲೇ ಇಲ್ಲ, ಸ್ಪಿರಿಟ್ ಲೈಫಲ್ಲಿ ನೋಡಲೇ ಇಲ್ಲ ನಾವು, ಹೌದಾ? ಸೊ ವಿ ಹ್ಯಾವ್ ಎವ್ರಿಥಿಂಗ್ ಇನ್ ಎವ್ರಿ ಹಾಸ್ಪಿಟಲ್. ಪ್ರಾಬ್ಲಮ್ ಈಸ್ ನೋ ಟೇಕರ್. ಪ್ಲೀಸ್ ಬಿಕಮ್ ಎ NHM ಅನ್ನೋದು ತುಂಬ ದೊಡ್ಡ ರಾಷ್ಟ್ರೀಯ ಆರೋಗ್ಯ ಅಭಿಯಾನ. ಇದೊಂದು ಅಭಿಯಾನದಲ್ಲಿ ಎಂಥದ್ದು ಸರ್, ಎಂಥ ಯೋಗ ಮಾಡಿದ್ರೆ ಅಶ್ವಯಂದ ಯೋಗ. ಅದರಲ್ಲಿ ನೀವೆಲ್ಲ ಕರ್ತೃಗಳು ಆದಾಗ ಮಾತ್ರ ಇದಕ್ಕೊಂದು ಯಾಗಕ್ಕೊಂದು ಬೆಲೆ ಸಿಗುತ್ತೆ ಅಂತ ಹೇಳಿ ಎಲ್ಲರಿಗೂ ನನ್ನ ಮನವಿ, ನಿಮ್ಮ ಲಿಮಿಟಲ್ಲಿ, ನಿಮ್ಮ ನಾಲೆಡ್ಜಲ್ಲಿ ಏನು ಬರುತ್ತೋ ಟ್ರೈ ಟು ಡೂ ದ ಬೆಸ್ಟ್. ದೇರ್ ಇಸ್ ಒನ್ ಕಾಮನ್ ಸೇಯಿಂಗ್ ಇನ್ ದ ಡೂ ಕಾಮನ್ ಥಿಂಗ್ಸ್ ಅನ್ಕಾಮನ್ಲಿ ವೆಲ್. ವೆನ್ ಐ ಡಿಡ್ ಮೈ MD, I knew I am going back to hospital. I didn't concentrate many issues because in in-service speech is difficult to read certain things. So I didn't know how to treat an arrhythmia. I don't know how to manage acute cardiac coronary in a taluk hospital. It's difficult. In best of the hospital, the mortality is very high. I looked upon anemia. I looked upon fever, all respiratory diseases, all abdominal cases. Yeah. I am very happy. 10% cannot be treated. Chalta hai. So dayamadi still is all non-operative, no sir. Most of them are. Most of them not easy to treat at their level. Definitely. No, nim level ಅಲ್ಲಿ ಆಗುವಂಥದ್ದೆಲ್ಲ ಅವ್ರ ಲೆವೆಲಲ್ಲಿ ಆಗುವಂಥದ್ದೆಲ್ಲ. there is no need to refer such cases. So dayamadi, thank you for the gesture. Where are you, sir? I couldn't. Very nice. BMC student. We are all BMC alumni, sir. Okay, right. So keeping this in you. So ದಯಮಾಡಿ ಇದನ್ನೆಲ್ಲ ನಿಮಗೆ ನೀವು ಗುರುಗಳಾಗಬೇಕು. ಯಾರು ಯು ನೀಡ್ ನಾಟ್ ಬಿ. ಅಂಡ್ ಕೆಲವು ಟೈಮ್ ಅರ್ಥ ಆಗ್ತದೆ, ದೇರ್ ಆರ್ ಲಾಟ್ ಆಫ್ ಇಶ್ಯೂಸ್ ಇನ್ ಗೌರ್ಮೆಂಟ್. ದೇರ್ ಇಸ್ ಓನ್ಲಿ ಒನ್ ಸೇಯಿಂಗ್, ಗೌರ್ಮೆಂಟಲ್ಲಿ ಕೆಲಸ ಮಾಡಬೇಕು ಅಂತ ಇಂಟ್ರೆಸ್ಟ್ ಇದ್ದರೆ ಬೇಕಾದಷ್ಟು ಕೆಲಸ ಇದೆ. ಮಾಡಬಾರ್ದು ಅಂತ ಇಂಟ್ರೆಸ್ಟ್ ಇದ್ದರೆ ದೇರ್ ಇಸ್ ನೋ ವರ್ಕ್ ಅಟ್ ಆಲ್. ಹೌದಪ್ಪ? ಇಫ್ ದ ಪೇಷಂಟ್ ಯು ಕ್ಯಾನ್ ರೆಫರ್ ದಮ್ ಫಾರ್ ಮೆನಿ ರೀಸನ್ನು. ಅಟೆಂಡ್ರ್ ಇಲ್ಲ, ಅನಿಮಿಯಾ ಇದೆ, ನಮ್ಮಲ್ಲಿ ಮೆಷಿನ್ ಇಲ್ಲ. ನೋ ದೇರ್ ಆರ್ ಮೆನಿ. ಇಫ್ ಯು ಹ್ಯಾವ್ ಎನ್ ಇಂಟ್ರೆಸ್ಟ್ ಎವ್ರಿಥಿಂಗ್ ಕಮ್ಸ್. ಸೊ ಅದಕ್ಕೆ ನಿಮಗೆ ನೀವೇ ಗುರು ಆಗಬೇಕು. ನಿಮ್ಮ ಎಂಪತಿ ಫಾರ್ ದ ಪೇಷಂಟ್, ಫಾರ್ ಸಚ್ ಪೇಷಂಟ್ ಡೆಫಿನೆಟ್ಲಿ ಗಿವ್ಸ್ ಎ ಲಾಂಗ್ ವೇ. ಆ ಲೈಫ್ ಲಾಂಗ್ ನಿಮ್ಮನ್ನು ನೆನೆಸ್ಕೊತಾರೆ ಡೆಫಿನೆಟ್ಲಿ ಸರ್. ಬಿಕಾಸ್ ಇಸ್ ಎ ಡಿಫಾರ್ಮಿಟಿ ಕರೆಕ್ಟೆಡ್ ಫಾರ್ ಲೈಫ್ ಟೈಮ್. ಸೊ ದಯಮಾಡಿ get involved in this thing. Please take down my number. I have a lot of funds to give an innovation ತುಂಬ ದೊಡ್ಡಿದೆ ನಮ್ಮ ಹತ್ರ NHM ಅಲ್ಲಿ. If anybody come forward with a document, definitely I am there to support you. 944-984-3005. ಮೇಡಮ್ ಅಂಥದ್ದೇನೋ ಇದ್ದರೆ NHM ಅಲ್ಲಿ ಇನ್ನೋವೇಷನ್ಗೆ ಸಾಕಷ್ಟು ಫಂಡ್ ಇದೆ. ಅದು ಯಾರು ಇನ್ನೋವೇಟಿವ್ ಆಗಿ ಯೂಸ್ ಮಾಡಿಲ್ಲ. ವಾಟ್ ಇನ್ನೋವೇಷನ್ ಯು ವಾಂಟ್ ಟು ಡೂ, ಪ್ಲೀಸ್ ಪುಟ್ ಅಪ್ ದ ಡಾಕ್ಯುಮೆಂಟ್. ಏನು ಬೇಕು ಐ ಡೋಂಟ್ ನೋ, ಗೊತ್ತಿಲ್ಲ. ವಾಟ್ ಎವರ್ ಇಸ್ ದೆನ್ ಲೆಟ್ ಇಟ್ ಕಮ್ಸ್ ಥ್ರೂ ಯುವರ್, ನೆವರ್ ಬೈಪಾಸ್ ಯುವರ್ ಅಡ್ಮಿನಿಸ್ಟ್ರೇಷನ್. ನನಗೊಂದು ಕಾಪಿ ಹಾಕಿ, ರೈಟ್ ಎ ಲೆಟರ್ ಟು ಅ DHO ಆರ್ ಟು ದ ಡಿ ಮೇಡಮ್, put a copy to us, or you address the letter to the MD through DHO, I want this is hospital to do this. So definitely there are many crores are unspent. ಸೊ ಆ ಎಕ್ಸಿಕ್ಯೂಟಿವ್ ಕಮಿಟಿ ಅಂತ ಇದನ್ನು ತಮ್ಮ ಸ್ವಲ್ಪ ಕೇಳಿಸ್ಕೊಳ್ಳಪ್ಪ, ಆಮೇಲೆ ಮಾತಾಡಿವ್ರಿ, ಪ್ಲೀಸ್ ಬಿ ಸೀರಿಯಸ್, ಯು ನೆವರ್, ದಿಸ್ ಆರ್ ಆಲ್ ಮೈ ನಾಟ್ ಮೈ ವರ್ಡ್ಸ್, ದರ್ ಆರ್ ಮೈ ಗ್ರೇಟ್ ಗುರೂಸ್ ವರ್ಡ್ಸ್, ಐ ಆಮ್ ಜಸ್ಟ್ ಗಿವಿಂಗ್ ಟು ಯು. ಏನಪ್ಪ ನೀವಂತೂ ಲೈಫಲ್ಲಿ ಓದಲ್ಲ ನಂಗೆ ಗೊತ್ತು, ಈಗಿನವರು ಓದ್ತೀರ ಬೇರೆ ಏನು, ಇದೆಲ್ಲ ನನ್ನ ಗ್ರೇಟ್ ಗುರು ಕೊಟ್ಟಿದ್ದ ಭಿಕ್ಷೆ ತಮ್ಮ. ನಾನ್ ವಾಟ್ ಎವರ್ ಐ ಅಟರ್ಡ್ ನೌ, ಇಟ್ಸ್ ನಾಟ್ ಮೈ ವರ್ಡ್, ಇಟ್ ಹ್ಯಾಸ್ ಪ್ರೂವ್ಡ್ ವೆರಿ ಗುಡ್ ಟು ಮೀ. Definitely bear a good food, because there are all good seeds. You are a person who plant in yourself, definitely make it to grow. You can blend or you can get the benefit out of that. There are the Guru Bhikshas. So they might artha madkoli. So get involved in this way. NHM is always there to spend a lot of money on innovation. Innovation ಏನು ನನಗೆ ಅಷ್ಟು ಗೊತ್ತಿಲ್ಲಪ್ಪ, ಬಿಕಾಸ್ ಆರ್ಥೋಪೆಡಿಕ್ ನಮ್ಮಲ್ಲಿ ಕೆಲವು ಸ್ಕೀಮ್ಸು ಮೇಡಮ್ ಜೊತೆ ಇದ್ದಾವೆ. ಇದಕ್ಕೇನಾದ್ರು ಬೇಕಾದರೆ ವಿ ಹ್ಯಾವ್ ಎ ಮನಿ ಇಂಡಿವಿಜುವಲಿ ಆಲ್ಸೋ ಯು ಕ್ಯಾನ್. ಪ್ರೋಗ್ರಾಮ್ಯಾಟಿಕ್ ಅಲ್ಲ, ನಿಮ್ಮದೆಲ್ಲೋ ಶಿರಹಟ್ಟಿನಲ್ಲಿ ಏನೋ ಲ್ಯಾಕ್ಯೂನಿಂದ ಮಾಡೋಕ್ಕಾಗ್ತಾಯಿಲ್ಲ ಸರ್, ಈ ಸ್ಕೀಮ್ ಇದೆ. ಇದಕ್ಕೆ ವಿ ಹ್ಯಾವ್ ಲಾಟ್ ಆಫ್ ಸೋರ್ಸಸ್, ಅನ್ಸ್ಪೆಂಟ್ ಮನಿ ಇದೆ, ಅನ್ಟೈಡ್ ಫಂಡ್ ಇದೆ, ನಮ್ಮಲ್ಲಿ ಇನ್ನೋವೇಷನ್ಗೆ ಫಂಡ್ ಇದೆ ಸರ್. ಸೊ ದಯಮಾಡಿ ಪ್ಲೀಸ್, ದಟ್ ಎವ್ರಿ ಇಯರ್ ವಿ ಸರೆಂಡರ್ ನಾಟ್ ಲೆಸ್ ದನ್ 600-700 crores ಬ್ಯಾಕ್ ಟು ಗೌರ್ಮೆಂಟ್. ಅದನ್ನು ನಾವು ಸ್ಪೆಂಡ್ ಮಾಡಬೇಕು ಅಂದರೆ ದರ್ ಇಸ್ ಎ ರೀಸನ್ ಟು ಸ್ಪೆಂಡ್. ಸೊ ಮಾಡಿ ಅಂತ ಕೇಳಿಕೊಂಡು, ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್ ಫಾರ್ ಲಿಸ್ನಿಂಗ್ ಟು ಮೀ. ಐ ಹೋಪ್ ಇನ್ನು ಹೇಳಿದ ಬೀಜಗಳೆಲ್ಲ ನಿಮ್ಮ ತಲೆಯಲ್ಲಿ ಹಾಕ್ಕೊಂಡ್ರೆ ಒಳ್ಳೆ ಮರ ಆಗಿ ಬೆಳೆದು ಆ ಮರದ ನೆರಳಲ್ಲಿ ಬೇರೆಯವರೆಲ್ಲ ಬೆನಿಫಿಟ್ ಆಗಲಿ ಅಂತ ಕೇಳಿಕೊಂಡು, ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್ ಫಾರ್ ಗಿವಿಂಗ್ ಆಪರ್ಚುನಿಟಿ.
Thank you so much, sir, for sharing your experiences, and definitely I think there's a lot of message to be taken, to be very empathetic, to treat a patient holistically, be affordable, available and accessible to the patients. With these words, I think we'll just break up for the lunch and we'll catch up again after 40 minutes from now. Is that okay, sir? 40 minutes. Please, let's all move to 8th floor where we had your breakfast. Yeah, we shall join here at it's 1:45. Yes. That's a token of appreciation, sir. A small to you from our end. Back kodi mage. Adal haki kottbidi, sir. So we'll all join for lunch at 8th floor. Thank you.
Any administrative medical officer here out of orthopedician?
serial casting for about say 4 to 5 weeks, probably a little more in little difficult foot. And then post anatomy, we put the child in 3 weeks of cast in the maximum corrected position. And then immediately after the cast is off, that is on the 3rd week when they come to you, you jump onto the bracing protocol. So there are various braces, but it is important before you jump onto a brace that you achieve at least 70 degrees of abduction and 15 degrees of dorsiflexion before you put the child in the brace. So brace is a must. It controls abduction and maintains the correction, holds the heel in position. The brace must be easy to use, must be adjustable according to the age, and shouldn't be too harsh on the child's foot and cause blistering, and it must be effective to hold it in corrected position. So based on this, how the brace must be, there are various braces that have come up over the years. We have the Dennis Brown, the Steenbeek brace, which we most commonly use, the FAB. And then you have Marcus, Mitchell's brace, Dobbs brace, and then you also have Padmapada. So various of them have told that the benefits over each other, probably the mobility, the material in which it is done, but also comes the cost factor. But ultimately, the main aim is to keep the foot in 70 degrees of abduction and 15 degrees of dorsiflexion. So I'll just be briefing about foot abduction brace, and after which I'll tell briefly about IO brace. So foot abduction brace holds the foot in corrected position, prevents recurrence, and it is the most essential part which goes on up to 4 to 5 years of age. So there are various components. One, you have the bar in between, which we expect it to be as wide as the child's shoulder or a little bigger than that. And then you have the foot part, which is in 15 degrees of dorsiflexion. You have a heel cup, which will help to hold the heel in place. The affected foot, you abduct it to 70 degrees, whereas the unaffected foot, you can keep it to about 40 degrees. And as I told, the bar is as wide as the child's shoulder. So affected at 70 degrees, unaffected 40 to 45 degrees, bar to be as wide as the child's shoulder. So how do you fit the brace? First, make sure that there's adequate correction. Once you have adequate correction, ensure the skin is dry and clean. And you always start with the most difficult foot. Now, if you have one foot which is a little more tight compared to the other, or little more rigid while casting, so you always start off with the difficult foot. First, you unstrap or you remove all the lace, keep the foot in corrected position into the brace, and then gently dorsiflex it, push the heel downwards into the back of the brace. And then you close the strap or the lace from below or down. Make sure that the heel is well seated at the base of the shoe, and make sure that the foot is not too loose or is moving inside the brace. And you repeat the whole process to the other foot as well. So always make sure you all can see there's a hole in the medial side of the brace, which helps you to assess if the heel is touching the floor of the brace. So make sure that the heel is correctly sitting. It shouldn't be off. If it is coming off, then you need to again put back the leg and again brace it up. In case they come back saying that it is not sitting properly, probably you have not corrected the foot adequately, or probably there's still some equinus left, or there is still some varus left, and you might have to start the child over with casting and repeat the process again. So if the brace is not sitting properly, make sure that there's no recurrence or there's still remnants of the deformity. Now the problem which we face with a lot of these foot abduction brace or the Steenbeek's braces, most of it is made out of leather and it is repeatedly used. We use the same brace for about 3 or 4 children before it is completely worn out. And we see that these children tend to develop some kind of rashes because of these braces. So this is one of the drawbacks that we see with our Steenbeek's brace, which we use quite frequently. So when do we start bracing? You start immediately after the cast is removed. For the first 3 months, the brace is applied for 23 hours. So you tell them probably half an hour in the morning, half an hour in the night for cleaning purposes, you can remove the brace. But 23 hours, the brace is to be put for the next 3 months. Then after 3 months, you start reducing the brace duration. You start off with 18 hours, then 16, and then you never reduce the time. You always tell the parents, put the brace whenever the child is sleeping. Associate the brace with the napping time of the child so that they don't get cranky. And eventually the child gets used to it and it knows that, oh, if I need to go to sleep, I need to get my braces on. So develop that kind of attitude in the child. And what happens is most of the parents, as soon as the child cries, they think it's in discomfort and they pull out the brace. So tell them don't pull out the brace at least the first few weeks till the child gets used to it. So once the child gets used to it, it associates the brace to sleeping. So eventually after 3 months, you reduce the duration, probably 12 hours per day, and whenever the child is sleeping. So once the child starts walking, they can be off the brace while walking, and whenever it's sleeping, it's on the brace. So always make sure you'll take confidence of the parents, convince them that, you know, this is the most important part. Your job is done with the casting. Now it is their duty to make sure the child puts on the brace. Teach them, take the time to show them how to apply the brace, and make sure that they fit the most difficult foot first. So, as I told, it should be part of their nighttime routine, and ask them to keep checking if the child is crying, if there's any rashes, if there's any soreness, or sometimes there are chances of small ulcers or blisters, especially at the heel cup part. So that one way to avoid it is we ask them to use a cotton socks, especially if you're using a FAB. They can use a cotton socks which will help protect the skin and also prevent slip off. So avoid using any synthetic or nylon socks inside which will slip out. And always teach the parents to encourage the child to kick the foot. Both the legs should be kicked. So when you kick, it pushes the foot into dorsiflexion. And you know, when it retracts, it goes into plantar flexion. So encourage the kicking movement in the child so it pushes the foot into dorsiflexion. And always ensure that you follow up the child frequently. So once you start the brace, you immediately call them the next week for the next 2 weeks to ensure that the brace is fitting properly and they are compliant with the brace. And then you can tell them to come once in a month, and slowly, once the child is accustomed probably and is doing well, call them once in 3 months to 6 months as the child grows older. So possible reasons why they don't put on the brace, most common is that the child cries or, you know, gets up in the night and pulls off the brace. So this is one more thing with our foot FAB. They have laces, which is easy for the child to pull out. It's just one pull and the whole brace is out, which is not so with the Iowa brace, which we'll show you now. And it's a difficult task for the parents to put it in, put it out, and, you know, they find it difficult for themselves and the child. And some of them, especially in our society, they have the stigma of, oh, how can I take a child out with the braces on? So always sensitize the parents, tell them, encourage them that, you know, look at the child's future rather than being worried about what other people might think. And yeah, as long as you encourage them and you keep following up with them, I'm sure they'll stick on to the brace. Bracing can be difficult, especially in the early stages, as I told. So take confidence of the parents and make them feel supported. So make sure that you insist to them that consistency is the key, and ask them to keep coming frequently. Score the child each time you see the child. So if there's any relapse, never hesitate to start back on casting. So these are the same things. Also, you teach the parents some stretching exercises. So when the child is off the braces, they can do some ankle and foot stretching exercises, which will help, you know, the foot to be a little more supple. And as I told earlier, any red flags, red marks, or, you know, any complications, ask them to come back to you at the earliest. So as I said, first 2 weeks, 1 to 2 weeks after the first fitting, then 6 weeks to ensure compliance, then every 3 months interval up to 2 years of age, and then every 6 months up to 4 to 5 years of age. So non-compliance, there are various studies which show that non-compliance of the brace significantly increases recurrences. And when correctly fitted and used properly, there's 100% efficacy of these braces. So the efficacy can depend on three things: parent factor, the child factor, and the doctor's factor. Parents, and you should, as I told, educate them, stress on the importance, find out what is the problem that they are facing and trying to find a solution rather than pushing them off saying, no, it is your job now. Help them find a solution to the problem that they are facing with the brace. If necessary, change over to a different brace which might be a little more comfortable for the child. And most importantly, doctors also tend to, once the brace, say 1 or 2 years, foot is fine, child is walking around, there are doctors who say stop the brace. So no, make sure that you advise the child to continue up to 5 years. Encourage your colleagues also to do the same. And if necessary, you all can always contact someone who's more experienced, or if there's any doubts, develop a mentorship or, referral person where you can always go back with your doubts or queries so that you are clear with what you're supposed to do. So, yeah, that's it. Thank you. Yeah.
No, not here. No, might.
No. So as I told, we have something known as Iowa brace, which is now available. So there are various braces. The most frequently, I'm sure we all have seen foot abduction brace. So this is the Iowa brace, which is a little difficult for the child to remove the straps. As you can see that they are hooks with straps and it is difficult to remove. And unlike our normal brace where we tie the lace here, which usually causes constriction and bruising, this has a flap, so it doesn't cause that constriction. And secondly, this has a silicone insole. So it is much more comfortable for the child to wear it. And it's easier for the parents to put it on, put it off also compared to the Steenbeek's brace. This is actually created in Iowa by Marconde and his team. Manufactured in, I think it's manufactured in China. And then this is available right now in India for about 9 to 10,000, if I'm not wrong. Compared to the other foreign thing, like your Ponseti brace is going to cost you around 30,000, and you have your Dobbs brace, which is going to cost almost 40 to 50,000. This is quite a cheaper variant of the foreign brace, which is much more friendlier for the foot.
So next we'll talk about the common errors that we face with in Clubfoot management. And then, so we can, I think you all got this article. So you can read, we split it up into different periods. The first thing is during diagnosis, okay? So like I said, there are different types of club feet. One was idiopathic, which is the commonest. And then there is positional club foot, I think. Abhishek talked to you about it. So there the cave deformities are not fixed. It's easily correctable. So the ankle dorsiflexion is easily correctable. And so that's how you differentiate that. And then there's different other types like atypical club feet and then neurogenic club feet, syndromic club feet. So when you examine the child, like general exam, and you see that there are some dysmorphic features, there's a tuft of hair on the back, or spina bifida or something, then that would not be like a idiopathic typical club foot. Okay, so that would be more like syndromic. If it's secondary to neurologic conditions like spina bifida or orthogryposis, which is like multiple stiff joints, contractures in 2 or more joints, then it would fall into that group. Again, those feet are going to be more difficult. So the first job is to identify which type of club foot it is, okay? And yeah, if you can. So once you see that, and then you see that if the child is able to move the great toe, if the child is able to dorsiflex the great toe, that usually is not a neurogenic clubfoot, okay? And if the rest of the exam is normal and nothing else to see, then it's usually idiopathic. So that's the first thing, examine the child properly and then see. So that's the first thing. Sometimes we make errors in that period. The next thing is like errors in manipulation. Okay, so like we talked about, how to hold the foot, how to manipulate, like some traction and then gentle abduction. Okay, so that will be manipulation, and then anything else you want to add in manipulation that we left out?
Yeah, I mean, just uncommon complications what one would not imagine, but there are reports of fracture of distal tibia. So just be very cautious that things can happen, and baby may fracture through the distal, in the casting while manipulation.
And then other errors during the casting period is, first thing is using too much force. Okay. So like I said, just two finger pressure, and also two finger pressure, and like not holding the foot in one position for long periods of time, and then like rolling the cotton, and then the plastering technique, etc. Okay, so and then no below knee casts. Okay, so if you do below knee cast, that's not going to work because it's going to slip off the child's leg. So the above knee part is you flex the knee so that the cast won't slip. That is one reason, and the second reason is it relaxes the gastrocnemius and things like that. So the cast is more likely to stay on. You get a better lever arm to abduct the foot. Okay, and then during the method you have to follow the same thing, cave. So you have to supinate the first ray by elevating it. If you pronate it, that means it's not good. So pronation, do you want to demonstrate what pronation is in the model?
If you pronate, you're actually increasing the cavus. So supination removes the cavus, but if you pronate, you can see the cavus is increasing. You're actually exaggerating the deformity.
Okay. So in the first step, so don't pronate the foot, try to supinate or elevate the first ray, so you're correcting cavus. That's one of the mistakes. And then the second thing, when you abduct, don't put your finger on the no area that we talked about, the calcaneocuboid joint. Okay, so that's going to cause mid-foot break, and also it'll stop the calcaneus from rotating. You want to show that?
So if I put it over the calcaneocuboid joint and try to abduct, the heel is not going into varus. It's going to stay, it's not going to get corrected. It's going to remain in varus. So you're basically creating a mid-foot break.
Okay. So that's called Kite's error. The other thing is, you also, if you don't put your finger behind the fibula, it can push the fibula back and make it more prominent, externally rotated. So that's another thing. Okay. And also, the parents will ask you, like, the other foot is this much, why are you overcorrecting it? So we have to overcorrect because clubfoot is a soft tissue problem. If you don't overcorrect it, the chances of it recurring is higher. That's what Ponseti, when he initially started, he was not hyper-abducting. He was only correcting to 40 because that's the normal amount of abduction. But then he saw that the recurrence rate was higher. When he started abducting to 70, then recurrence rate came down. So because he's overcorrecting it to, he knows it's going to come back, so that's the reason why he's overcorrecting it a little bit. Okay. What else? And then
that's the key message. Abduction. Abduction is the most important part in clubfoot correction with Ponseti.
Yeah, other thing is too much padding. So like I said, only one layer overlapping 50 degrees, and then just 3 layers at the start and at the end. So if you put too much padding, then the cast is likely to slip because there's more space. Okay, and not putting on a very conforming sort of cast. If you put a fracture cast, it's going to slip. Okay. those are some errors in the casting period. Okay. Okay, yeah. And then errors during the tenotomy stage. Okay, you want to talk about that?
Yeah, so
Yeah,
while the commonest error is not doing tenotomy. So if in doubt, that's the commonest cause of recurrence which we see in practice, that there was residual equinus which never got corrected. So if in doubt, rather than not doing, do tenotomy. That's okay, but the reported rate in Ponseti's paper is 90%. And so always, if in doubt, do tenotomy. So it's better to do tenotomy rather than not doing it. While doing tenotomy, one has to be cautious about the neurovascular structures around and complete tenotomy. Those are the two important things. So as Abhishek has shown, you can visibly see dorsiflexion, you should hear that pop, and you should also check for the completeness of the tendo-Achilles tenotomy. So those are the three important structures. And after tenotomy, the cast should be in maximum dorsiflexion and abduction, because that will stretch out the posterior structures and that will maintain the correction. So remember, after the tenotomy, the cast should be in maximum dorsiflexion. So that's the only point when you are going to do dorsiflexion of the foot, not before that.
And then the other thing is, say you casted and then there's still some residual, you're not able to dorsiflex more than 10 degrees, you've done the tenotomy, and then in spite of that, you're not getting 10 degrees. So don't hesitate to cast again after the, like, instead of putting the cast on for 3 weeks altogether, bring them back at 1 week, recast, change, then you'll be able to stretch a little more. That was shown by Dr. Agarwal from Delhi. He published it. So you may need 2 or 3 more extra casts if you're not able to get that 10 to 15 degrees of ankle dorsiflexion. So don't hesitate to cast some more after the tenotomy. Okay? That's another mistake that we do normally. What else in the casting or in the tenotomy phase? I think those are the main issues. So, and also check incomplete sort of tenotomy, doing a tenotomy that's too low, like I said, 1.5 centimeters above the tuberosity, or going from the medial to the or lateral to the medial side, injury to the the blood vessels and things like that. Those will all heal. Okay. I mean, those are the errors during the the tenotomy stage. Okay. Next, coming to the bracing stage, like we said, this is the protocol that you need to follow, like 3 months and 5 months. Most families, about 2/3 of the family, one thing is, like he said, 3 things, the triangle, the doctor, parents, and child. Okay. During this bracing stage, the family, they are the key. Okay. So you have to educate them from before. So usually in globalhelp.org, the website, maybe there's a free parent handout available. It's only 3 pages. And there's also a book, 33-page book in color. So you can give it to them the first time you see them. You give the book to the parents. You can also tell them, look, it's obviously most parents want their child to do well, right? So if you educate them well, most people will be able to do it. But there are about 2/3 of the parents are able to do it well. In 1/3, there may be some difficulties. It may be because the parents are getting divorced, or the child may have some other disabilities like autism or some other neuro disability, because of which there may be some difficulties. So that may be another reason. Thirdly, you've not, and doctor's point of view, you have not corrected the clubfoot completely. So it's like fitting a round ball in a square hole. Then they'll develop redness in the heel or another part of the foot, and then they come and tell you, said, no, we are done correct. But so I usually say, whenever you have to modify their behavior, you have to first of all listen to them patiently. Spend some time. Then you have to guide them. Means you have to dance with them a little bit. It's like listening, guiding, and then you have to influence. What we normally try to do is we try to influence them straight away. But instead of that, listen to them. Okay, first. Listen to their concerns. They'll say, the child starts crying. As soon as you put it on, he starts crying, so we can't sleep, so we take it off. Okay, yes, they have to sleep, right? They worked. So then you have to see, why is the child crying, is the brace not fitting okay, or is the foot is not completely corrected. Just spend some time thinking about that, re-examining the child, and then again explain to them it's good to get some photographs before the foot was corrected and after the foot was corrected. So you can again show them if you don't do this, it's going to go back to how it was before. Okay? And yes, there are some patients who are really, really difficult, especially unilateral club feet. If it's bilateral, usually it's easier to tolerate because the brace is on both feet. If it's unilateral, the parents will ask you, why do you have to put the normal foot in the brace? So then you have to explain to them why, because you need to abduct it. If you just use a one-sided brace, you can't get that abduction force. Okay, so, and then in those patients, if they're really bad, there are one-sided braces called ADM braces. We don't recommend it, but at least it's better than having no brace. Okay, so the Iowa or the bilateral brace is, the first choice brace, but if worse comes to worse, they are not tolerating it sometimes. They may also have heard on the internet, like ADM brace is unilateral brace, it's called abduction dorsiflexion mechanism brace. It's a spring-loaded brace. So even in US where I practice, they tell me, we're going to use this brace. I try to convince them, they don't listen, then yes. I'll tell them there is no evidence for this brace at this point, and if it recurs, like, you will be responsible. They'll say, yeah, no, I want to use it, okay. But usually you can predict, like in Bangladesh, they did a study where it's called patient load factor. So you can determine, for example, if they're from they have a low education status, their income, medium income is low. If they live in the rural areas, their travel is long, or if the family is divorced, you can predict who is going to be non-compliant with the brace. With those patients, you have to spend more time and then get them to use it. Okay. I can't emphasize more communication skills. So you have to listen to them, patiently, and then bring them and then influence them. You want to add something?
There is no role of using AFOs. Many places they will make AFOs and just apply a bar. That's easy to make. The AFO, the posterior aspect, it can stimulate the calf muscles and cause equinus. So don't use AFOs. Many places orthotists will make that AFO and just stick a bar. So that practice is actually increasing the chances of recurrence.
Anything else? Any other questions? And then what has also been shown is that, like, giving some training. If you've done like 10 or 15 patients with Clubfoot under supervision or with a mentor, then usually they do better job than if you just start off on your own. So whenever you have, like, what we are planning, and we were talking to Dr. Veena as well. So we are going to hopefully have like a master trainer for few districts, and then they'll be your mentor. So you can then ask them if you have difficult cases or the cast is slipping, you can then ask, what can we do? Okay, and they may be able to advise you. Okay, and if you have like a sore and things like that, sometimes you stop the casting, let the foot recover, and then you have to restart. Don't continue while pressure sore is there. Like, even I've had sores, like maybe once a year I might have one sore, but if I see that, then I'll stop. I'll let the foot recover, let the swelling go down, let the skin heal, and then again restart. Okay, so it's good to have like a mentor. If you don't have, you can find yourself on your own. If not, they'll probably, if you're in the program, we are talking to them about it. Hopefully they'll have a mentorship mechanism in place. Okay. What else? Talk about, sorry, you had something?
Any questions, or have you experienced problems with bracing, and what were those?
The other thing is managing relapses. Abhishek? You want to?
All of you, are you using, what kind of brace are you using currently? Steinbeck. Okay. And do you use anything during daytime? Because that's another common question in India. So,
well, when the child starts walking, usually walking itself provides dorsiflexion counter pressure. Other thing is you can also do, in addition to bracing, we also recommend stretching exercises, like for the heel cord, ankle dorsiflexion stretching, and then toe flexor stretching, and then stimulation of the peroneal muscles. So you can teach them. There are some YouTube videos there. If you look on YouTube, Clubfoot stretching exercises from like Nimor's, it'll show the video. You can give the link to the patient, or you can show them. I usually demonstrate and make them make a video. They'll make a video and then they can take it with them. I usually say do stretching and stimulating exercises for about 10 to 15 minutes 2 times a day, whenever they take out the brace. Okay, it doesn't have to be 1 hour for 20. It can be like 2 half-an-hour periods or 4 15-20-minute periods that the brace can be off. I think consistency is more important than exact number of hours with the brace. Okay. You want to do relapse?
So before going into relapses, just some points about difficult clubfoot. So what constitutes a difficult clubfoot? Most of them are either syndromic, atypical, or complex. You might face some rigid or resistant clubfoot, and even relapse comes under difficult clubfoot. So why are they difficult? Probably because they are less pliable tissues, or they might have some underlying bony problems, or syndromic can have some coalition or duplication, or probably some bony structural problem. In neurological, you'll have some kind of muscular imbalances. All these forces can act against your wishes to correct the deformity. So whatever the problem is, the answer comes back to Ponseti. So Ponseti is the solution for most of your clubfoot problems, whether it is difficult, idiopathic, syndromic, neurogenic, anything. So syndromic might require a little more number of casts depending syndrome, whether it is associated with contractures such as arthrogryposis, or if it is associated with some laxity of the tissue. So depending on that, the number of casts can go either up or down. So, but still continue with Ponseti. So this is another thing that you all might see is something known as atypical clubfoot, where you can see a deep medial crease due to midfoot break, and then there's a deep posterior crease, there's a hyperextended first MTP. So when you see these things, in such cases, you need to do a little bit of modification of your Ponseti, wherein instead of just elevating your first metatarsal, you elevate, this is similar to a complex, I'll just show you, instead of elevating just the first.
So if you see this crease here, it's all the way across the foot. So that's called as a transtarsal crease. It's not just on the medial side of the foot, it goes all the way across. That's very characteristic of an atypical clubfoot. Okay? So when you see those cases, then that means it's an atypical clubfoot.
So in these cases, what we do is, before going on and correcting all the other deformities, we first, after achieving about 30 degrees of abduction, we elevate the first and the fifth metatarsal head. Instead of just the first, we elevate the first and the fifth with the fulcrum over the metatarsal tarsal joint. It's not at the ankle that you're elevating it over, it's at the midfoot that you're using the fulcrum.
So for example, this is the foot. So your hand, this will be here, okay? So you put it here, okay? And then this will be above the midfoot, and then the thumbs will be here. And then you're kind of pulling the calcaneus down and pushing this up, okay? That's the method you have to do. At the same time, if you abducted it, maintain the abduction and then do that. Okay? That's called a Ponseti 2 maneuver. And I'm sure Gopi can send you some links.
And this is also one of the most seen problems why you see the cast slipping off, because there's a deep crease and the midfoot is broken. It tends to go into the cast, and eventually the foot becomes loose and comes out. So always, if you see such things and you see the first toe is getting hyperextended, you see the crease becoming deeper, do this maneuver, correct this first, and then go on with the remaining correction. So such children might require 1 or 2 more casts compared to your regular idiopathic thing. But if you still have a lot of problem, the cast is continuously slipping off and it is not holding, always don't hesitate to give a cast holiday for about a month. Let the foot inflammation come down, let it recoil back, and then you can start over with your Ponseti's treatment. So
it usually happens if your technique is kind of a little bit rough and the tissues are a little bit stretched or damaged, the foot will swell, and then from there on the cast begins to slip, and then you will develop this iatrogenic atypical clubfoot, and then you're like on a slippery slope. So in that case, just stop the casting, give the child a break, let the swelling come down, and then you can restart Ponseti after that. Rather than keep continuing with the casting, give the child a break, and then after 3 or 4 weeks it will swell. It's also called as a smashed foot. That means you've not been gentle with the manipulation, and then the foot becomes swollen. Okay.
So now we'll move on to relapses that we see. So if you can see the chart here, all the blue ones are pre-Ponseti era, where we can see there's quite high relapse rate and recurrence. But post-Ponseti, the relapse rate has drastically come down. So Ponseti does help prevent relapses and does help you maintain the foot in the most corrected position, provided you follow the protocol and the steps. So prevention is to make sure that they adhere to the whole treatment protocol, the bracing, and there's tenotomy done to ensure that your equinus is corrected, and then you can always teach them stretching exercises, advise them, especially the child once they get older, to start squatting exercises and hopping exercises that will further stretch your tendo Achilles and help the foot to be supple and more stretched out. So recognizing relapse is an important part. So here again it comes to Pirani score. So always make sure you score the child each time you see, and any time the score is tending to go higher up, start attending towards it and start doing what is required. So if you have a child with recurrence under the age of 2 years, it's most likely due to failure to wear the brace. So early recognition is important. So early presenters usually they come with lack of dorsiflexion, that is they come up back with some amount of equinus recarping, or they say the brace is not sitting properly, or the child is tending to walk on the heels, on the toes. So if in that such case you assess the child, if there's any deformity, you again go back to casting. So any child with less than 2 years coming back with recurrence, you start over with Ponseti's technique, and if necessary, you can always do a repeat tenotomy. Don't hesitate to do another tenotomy if there is a recurrence. And then once your tenotomy is done, again go back to brace. So if the dorsiflexion is limited, less than 1 year, always can do a percutaneous tenotomy. Even in more than 1 year, if child has equinus, you can always consider a percutaneous, but in certain scenarios where it is very rigid, you might have to undergo a open TA lengthening, but avoid doing your open TA lengthening as far as possible. And rebrace the child. Second recurrence or the third recurrence is always treated the same way. You go back to Ponseti's casting. A little older children, recurrence between 2 to 5 years could be due to muscle imbalance. Again here early recognition is important. So here what becomes important is you need to look for if there is any dynamic supination. So I'll just show you a video of it. So one point that you need to look for is dynamic supination, and the children start walking with weight bearing on the lateral border, and there might be a visible or variable heel cord or the tendo Achilles tightness. Could you play that? So if you notice this child walking, so look at the foot. As the child is walking, the forefoot, the great toe is going into supination once the child is walking ahead. So look at this, it's going into supination. So this is dynamic supination. This is because of overacting tibialis anterior tendon. So in such children, you might have to, apart from doing your regular casting and tenotomy, TA lengthening, you might have to add on with the tibialis anterior tendon transfer. So mainly in children more than 2 years, Ponseti casting to get the heel in valgus and plantigrade, then probably tibialis anterior tendon transfer if there's a dynamic supination. Remember, if the dynamic supination is a complete different entity from metatarsus adductus or forefoot adduction. A child can have a static forefoot metatarsus adductus and still can it may not be a dynamic supination. So doing a TAT in a child with a static metatarsus adductus is not going to help. So that might require again further casting or release of the joints there rather than doing a TAT transfer. So do not hesitate to do a TA tenotomy at any age or even if it's more than once. And tibialis anterior tendon transfer can be considered in dynamic supination where we harvest the tib anterior tendon from the base of the first metatarsal and then transfer it onto the lateral most cuneiform.
I think why you do that is, so the tibialis anterior tendon is inserts on the first metatarsal and medial cuneiform. It supinates the foot and also adducts. So you're converting a supinator to a foot pronator. So the axis is the subtalar joint. Because the axis is oblique, if you take it to the third cuneiform, then it pronates the foot. So that's the principle behind the tibialis anterior tendon transfer.
So it's always a complete tendon transfer and never a split tendon transfer. After the transfer, we put the child on a brace for about cast for 6 weeks, and then post tendon transfer, you don't need to brace the child. The child can be retrained and made to walk. Yeah, less than 5 years. So less than 5 years, you put them back on your foot abduction brace or your Iowa brace, but there's no role for AFO here. So late presenters, children presenting more than 2 years or 3 years of age. So this is another challenge that we face. The problem here is, unlike a supple young child, the bones and the tissues are much more rigid, and usually by the time you see a change in score, it might have been already 3 to 4 casts before you notice any significant change happening to the scoring. So always be a little more patient, continue with your casting, and it might be a little difficult to just do it with your one hand technique. Use both your hands if necessary, especially in bigger children. The number of casts might vary, might go up to 10, 12, 14, depends on the age of the child, but the principles remain the same. And always, irrespective of the age, above knee cast, even if they are walking 10 years, 12 years, doesn't matter, above knee cast. It might be a little difficult, especially if it is a bilateral. And it is a little bit of a problem for the parents to carry the child around and all. But eventually, the end result is what you need to focus on. And here, unlike in children where you need to achieve 70 degrees of abduction, probably a 40 degrees or 30 degrees of abduction like an adult is sufficient in these late presenting children. So always reserve all the other various methods such as Ilizaro, PMSTR and all to the worst of the worst scenarios, because 99% of your clubfoot can be treated with just Ponseti's method and simple tenotomy techniques and bracing. Thank you.
So any questions? If no questions, I think all of us can tell one takeaway point from today's session.
Bony cast to prevent loss of abduction.
I will let. I will answer.
Proper casting is prevents the good prognosis. Proper casting. Yeah.
What else? Give us one more learning thing that you got.
Early treatment is good for prevention of this deformity.
Stick to Ponseti technique. Same thing, sir. Surgery is not the ultimate. Earlier the treatment, better the prognosis. Sir, cavus first, followed by adduction, then varus, and last is equinus.
It's not necessary to start casting immediately after birth. We can give 2 to 3 weeks time interval to start bonding between the mother and the kid. Later on, we can start the casting.
So Ponseti is a gold standard method. We will follow, stick on to it, sir.
So it is very important to create the child friendly atmosphere both for the baby and the mother before applying any cast, and it creates a lot of patients all around in the hospital. Baby friendly atmosphere, we can make a mom, her baby's mother, to sit beside the baby, and we can create like play some good music for the baby, and we can console it accordingly. Feeding, we can advise mom to bottle feed the baby there, and with her consent we can also advise her for breastfeeding.
Confident enough to follow this method, sir, and this to prevent errors during casting and all.
So what is one thing you're going to do differently after listening to the stories?
Differently. First, this in chaos correction, then errors correction.
What about if you're in court, tell us something about with respect to things like anatomies. What are you going to do differently?
That after cutting, we don't suture, and after that we put cast immediately after, no suturing. Then 1.5 to 2 centimeter above the calcaneal, this thing. If so incision is more, means I'll suture. No need to tenotomy suture. Yes, sir. Yes, sir. After tenotomy, putting the cast.
So taking parents' confidence, we have to counsel the parents first properly about the treatment, and it is a correctable deformity. At any age of patient comes, Ponseti is the gold standard, and then consistency in technique and that much. Yes, sir.
Sir, I am treating on and 6 kids, sir, right now, since 3 months. Earlier, one more ortho surgeon was treating. He resigned. So, since 3 months, I had so many doubts. Today, I got cleared. So many, like you told and Abhishek sir told. So, definitely, my referrals will be less. That I can assure to Indira Gandhi. I'll try to, I'll take your number, and any doubts I can call you, sir. Abhishek sir, thank you. Sir, tenotomy. Tenotomy, like my seniors, they used to teach needle tenotomy. That's why I asked a question. But I whatever in BMC I learned with blade only, sir, 11 only. But I asked on doubt, no, that needle is a bit difficult only. So I'll just skip that needle, sir. Only blade I'll use. Yes, sir. go deep. Okay.
The other thing you can also do the mini open technique, make a little bit bigger incision. Use the hemostat, bring the tendon out and then cut it a little bit. When you're starting off, like if you're not feeling confident,
Okay, sir.
well, if you're not confident, then fine. Usually it's not difficult, but if you're not ready to do that,
And thank you all of you, sir.
This was really a very useful and informative session. We always like fail to analyze after each and every cast. We never try to score. So we again today we learned the importance why we should repeatedly keep scoring. So that's how I think this will help us in that manner, sir.
so tell us a little bit about the score. What kind of score is it?
Pirani score, which
How many elements does it have?
so the front foot, mid foot, and the hind foot, rather.
So means all you need to remember is like 6 things, okay?
Yeah, cave.
Look, feel, move. That's how
Look, feel, move. Yeah.
set up. How many things you look for in look? How many things in look?
That is the crease.
3.
3, 2.
3, 2, 1. So
Yeah.
in look, what are the 3 things you look for?
Markedly visible crease.
Number of crease, then lateral border, medial
Curved lateral border.
What about feel?
Feel for talus,
chin,
and calcaneal
chin, nose, and
feel for equinus. Move, sorry, move equinus.
So we learned that Ponseti is good for even for rigid foods. Usually we used to refer it for posteromedial soft tissue releases. We learned that it is not needed and it is good for at any age. Another thing, we used to use pedicoril as a sedative. We hope we don't use that later.
I would say that surgery is totally out of the question, but in about 98% of cases you can correct Ponseti. 1 to 2% of cases, like I said, 1 or 2 cases in a year. I treat about 60 or 70 new Clubfoot in 1 year, maybe less than what you guys treat here. But maybe once a year I might have to do like a limited posterior open lengthening in addition to tendon cases. Might have to do like an ankle or subtalar capsulotomy once a year, like an orthopedic or something like that. But usually, other than that, everybody else is correct.
Most of the idiopathic don't end up with surgery. Never.
Yeah, it's usually syndromic. Orthopedic syndromic Clubfoot, those are the ones probably need open reduction, some of them, but most idiopathic Clubfoot you don't need any other thing.
Again, that's again for the rigid and syndromic Clubfoot where it is not budging.
Not for initial treatment.
I learned that the tenotomy should be done from medial to lateral side to avoid posterior neurosacral bundle.
Yes, sir. It was like a revision again for me. That I used to hear a lot like there are only 2 rules to succeed in treating a Clubfoot. Rule number 1 is always follow Ponseti method. Rule number 2 is again don't break rule number 1.
So post tenotomy, we have to mobilize in maximum dorsiflexion for 3 weeks. At least 10 to 15 degrees from the neutral position. Then your tenotomy is not proper. Do repeat the procedure. Okay. Okay. Sir. Thank you, sir.
Here, this line. Okay, Ajay.
Sir,
Complications.
Okay, I will give you a clue. Say, parent comes to you, and then they are saying bracing is difficult. The parent comes to you, they are saying bracing is difficult. So what will you do?
So the parent should convince the child to put the
Child is 1 year old. How can they
no convince, make it a habit for the child to whenever it sleeps, it should have a brace on it.
No, but they are looking to you. What will you do?
He said something very simple, non-orthopedic.
What will you do? When you chat with the parents, what will you do? You just say, this is a rigid rule, nothing. You just either follow or leave. I don't care. You're not doing it right. Is that how you say? Or?
Reasons why.
Listen, LGI, listen, guide, and then influence. So first of all, you dance with them. Okay, that means listen. Say, okay. First listen. Say like, okay, what are the issues? You don't just brush them away. Okay, when are you not able to? And then examine the child. Make sure the correction is complete. If it's not, you have to cast. Make the foot fit the brace. Okay, and then check the brace. Is it made okay? Are there any rough areas which are pressing on the child's foot? Is the child having any sores or anything like that? Is the brace comfortable? That's all in your hand, because the parents can't do that. And in spite of that, the foot is very nicely corrected. It's very supple. Pirani score is 0. It's abducted nicely. The brace is good. Then see, okay, does the child have any other medical problems, like any other neuro disabilities like cerebral palsy or whatever else, autism, anything else? That because of that the child has hypersensitivity in the foot, things like that. Then there is a Northern Europe paper which shows that they have more brace intolerance. Okay, so that's all you can do. And then the parents, then you educate them. Like then you ask them, are you divorced, or is there any difficulty? They may be in difficulty, and that may not be the they are more concerned about living, about surviving, rather than keeping the brace on. So you have to ask them, do you have a house to live? What is the problem? Ask them. And they may not have money to buy the brace. So you have to ask them, okay, like even in US, some of them don't have insurance, like 40% don't have insurance, so they can't buy the brace. So what we'll do is we recycle from the rich patients. Like you can do that too. Like I recycle all the braces, I tell them to donate to me. And then we create it, and then we've sent, or we'll be sending it to Serve Together to donate to parents who don't have money to buy the brace. So same thing, you have to create those kind of things. Okay, so that's what I mean. So listen, then guide, then influence. You're not just surgeon like Dr. What was his name? The senior doctor's name. He was saying you have to be holistic in your approach, right? Yes. So you have to be holistic. You have to ask them, like, not just show empathy to them. Yeah, means they can't sleep, the baby can't sleep. So you have to show, okay, yes, I hear you, I'm with you. Let's work on it together like a team. That's how you do, okay? That's usually reimbursed by insurance. If they have to buy on their own, it's usually $250.
By doing tenotomy, we have to keep the knee in extension to stretch the tendon, sir. We normally keep it in extension and do it
Sure. You'll have to check it in extension.
To make it taut, and we don't do this swinging movements. We just keep it there. It cuts by itself.
Examine the baby as whole, not only the clubfoot. Look for the other syndromes, all those things.
Like, give me one example. Which part of the body will you look?
Spine. We look for the back.
Will you look
Like
for
look
spine?
for the tuft of hair, any meningocele, spina bifida, or any like downs or something like AMC, contracture bands, all those things.
Okay. Good. Next.
Never pronate the foot while casting.
Okay. What will happen?
It will exaggerate the
Cavus deformity.
foot.
Okay. Good.
Sir, in a developing country like India, I would like to remove that social stigma which is attached with the parents and the society. That is the main reason for not so good follow-up. I would like to inform the parents that this is not at all a disease. This is just a deformity which is temporary, and with proper Ponseti method and all, it can be totally reversed, and your child can be a good athlete as Carl Lewis or any other person. I would like to do that, sir.
Okay, good. Next.
Sir, if the child moves the great toe, so then we can rule out neurogenic. To rule out the neurogenic, if the child moves the toe, dorsiflexes the toe, then we can rule out neurogenic.
What is this clue? This is another clue. What did you learn from this model? Okay, kinematic coupling, what else? What does this word say here? What does no mean? Yeah, don't put your thumb on the calcaneal keyboard joint. So whose error is that? So where will you put your thumb?
Talar head, sir.
Lateral talar head. Who's next?
Sir, I learnt regarding that you said cataract blade is used to make it a less harm to the tendon. I learned that point. Thank you.
You're going to go back and talk to your ophthalmologist.
I will get the blade from her.
So this is the more informative. We will practice only Ponseti technique in our practice, and we can remove the social stigma, as well as we can make the patient not a physically handicapped.
But what else? How will you practice? Give us one thing you will do differently when you go back. That is your aim, yes.
Yeah.
What are you going to do differently?
First, if the patients are illiterate or uneducated, lower social economic status, we will convince them. Counseling the things first important. Then we will take him confidence. We will treat the patient. We will give a result.
As far as casting is concerned, there should be proper padding. Then the casting should be conforming. Then there should not be any denting after the plastering. And as far as tenotomy is concerned, medial is safer, lateral is suicidal. So,
stick to principles, Ponseti principle. Very adherence of principles of Ponseti. That's what I learned. And another thing is kinematics. That's where we used to.
So what did you understand by that?
Hold only talus and nothing else.
So what do you understand by the word kinematic coupling? What does that mean?
How the ankle moves and motion of the
subtalar joint.
subtalar joint.
Means if you move it in one direction, automatically it will move in the opposite direction. For example, the foot is plantar flexed and inverted. So if you abduct the foot, okay, at the same time it's going to also dorsiflex and even.
We never used to give importance to that, and Kite's mistake we used to do.
So coupled movement means one movement in one plane is coupled with movement in the other plane. That's because the axis of the subtalar joint is oblique.
I didn't know it was so important.
I think the whole thing is based on it. What else? What is the other principle? Why does the Ponseti method work? He said kinematic coupling, that is one. What is another property of the body that helps Clubfoot to correct?
Viscoelasticity.
So what do you mean by creep?
Just the tingle here, you make it elastic. That's
Elastic recoiling.
Yeah, I think it's time-dependent deformation. That means if you keep the foot in a cast, next time you come to cast, it will stretch more.
yes. Creeping movement. Creeping this thing. Creep phenomenon.
I learned sedation is not at all necessary. Second thing is, I thought it is a short case, but treating CTV is a main procedure. And even though it is a simple technique, but you have to follow till 4 to 5 years.
two things I learned is one is about padding, sir. As you told initially and at the thigh level, we need to put 3 layers because I used to get kids who used to get rashes, sir. So now I realized a good padding is enough for it. So I can do that, sir. And a tight padding on the this thigh region, that is enough. And no tenotomy we used to do with needles, sir. I used to do it. It used to be a little difficult. From now on, I'll try with the knife, sir. So I think that will be more helpful for us. What will you do if you miss, even though you pad well, you can still get a rash? So how will you treat it? If it's like a simple kind of abrasion, we can continue the cast, sir. If it's a more kind of a sore kind, we'll leave it open for 1 or 2 weeks, then we'll continue the cast, sir. No, if you get a rash here, so you Yes. use the desiccating cream. Okay. You know desiccating cream? Any moisturizers? Any moisturizers to tell the... You can use that if there is irritation because of the injury cast. You can use calamine also. You can even use the candid powder. Okay. No, just when they remove it, you ask them to apply it and bring it. By the time you put it, it's all gone.
Ponseti method is a very good method which we have learned today. And then, but the only thing is it has to be practiced practically with all the effective procedures. Like methodically, it should be practiced, and then it should be implemented at the root levels, like Taluk hospitals and all, without referring any patients to the other hospitals. But a very best method to be adopted at the root levels, sir. What I learned, and one more thing, what I learned is overcorrection. Again, it will reduce the recurrence. That what I learned today with this method. Relapses, yes.
What else do you guys learn apart from bracing? What another technique will help reduce relapse rate? Apart from bracing, in addition to bracing, we talked about another thing. Yeah, you want to talk about it? So stretching and stimulating exercises. So stretching of tendon Achilles, okay, and then stretching of the toe flexors, and then stimulating the peroneal muscle groups to become stronger, so they can oppose the tibia's anterior which wants to pull the foot in. That's also important in addition to just the breathing. What else? Did you know anybody? Any other questions?
Role of radiograph.
Yeah, role of radiograph, like in initial Clubfoot, if you are in doubt whether to do the tenotomy or not, then if you have C-arm, you can check and see where the movement is happening. It should happen at the ankle joint. So you have to, there's a nice paper by Heisenberg and Christoph Radler. We can send it to you if you want. We can send it to Gopi, and then you can send it. So they did that before tenotomy. They took C-arm picture, and then after tenotomy, they took C-arm picture. They saw that most of the movement was happening in the midfoot. If they're in doubt, they took the C-arm shot, and then they saw that most of the time the movement was happening in the midfoot rather than in the ankle. That's why if you're in doubt, do the tenotomy. So, and you can check with C-arm whether you're getting 10 degrees of dorsiflexion in the ankle, not in the midfoot. You get it in the ankle.
No need for looking radiographs of the foot.
Primarily, it's not required. Probably when you're doing a tenotomy, just to.
And then in a relapsed foot, yes, then you can get weight-bearing X-rays of the foot, AP and lateral, and then in those cases you may need an X-ray.
Or even if the child is not yielding to, your Ponseti's method, just to rule out if there's any other congenital anomalies, probably a coalition or, hemimelia or something that might be coexisting, which you might have missed, probably then, but not primarily.
Other questions?
What is the percentage of
Recurrence?
Recurrence going for bony correction?
Oh, going for bony correction. So I think the overall the percentage of recurrence is about, it depends on how good your initial correction is, but in Ponseti series, the recurrence rate is about 15 to 20% recur. But I think in other people's hand, if you're not following exactly his technique, it's probably a little bit higher, 25 to 30%. And then those who need bony surgery is about 10 to 15%. There's a nice paper by Matt Halansky et al., which was published in JBJS like last year. They followed patients who were treated by Clubfoot in New Zealand for 15 years. And they saw what other procedures were needed for them, apart from tibialis anterior tendon transfer. And about 10-15% they needed like cuboid shortening, or calcaneal osteotomy, etc. So again, we can have Gopi send it to you guys by email if you want.
Anything we need to add? Anything we need to add?
You can you start with the Ponseti and then see how they respond. Like I have corrected up to 14, some people have corrected even up to 20, 30 years. You can start with Ponseti, you may not be able to correct completely because it's not as viscoelastic and the bone is deformed. You may need to do, but definitely it will reduce the amount of surgery you need to do. So you can start with Ponseti technique. So the principle there is obtain correction first and then you have to maintain it.
So, most of the times it is iatrogenic. So, I would again give it a break if the child is immediately out of the cast, reassess, and then probably start casting again to correct that midfoot break. And usually it is the residual equinus, tight tendo Achilles, which needs correction, and then that rocker bottom gets corrected.
Always avoid correcting your equinus without doing a tenotomy. That's when you'll end up with a rocker bottom.
Because you try to push into dorsiflexion, you're stretching the ligaments of the midfoot and then go into dorsiflexion. So if you're in doubt, get a C arm and check where the break is happening. And if it's a really like a rigid, like a rocker bottom foot, you may have to do like reverse Ponseti technique to correct it. Okay? Or you should probably refer those cases to Isabel. Okay? So don't try to manage the complex cases. Call your mentor. Don't try to manage on your own. Like we are all like a family. We are together in this. So if you have a problem, discuss before you do anything. Take some pictures. Then call your mentor, call Uda Prasad, call Abhishek, then ask them like what would you do? And then if they don't know, they'll ask us or whatever. And then so that way, we can mentor you when you have a problem. So don't try to do it on your own. So this is where, this is where we'll need a help from the government. They had said, Dr. Veena ma'am, we had talked about creating some mentors. So yeah, so she said she has promised us she'll work with Gopi and then try to arrange that. So we are hoping to get more intensive training for like few of you people who are really interested. Like, so we hope to have some really, serious people who want to do Ponseti. We might get more intensive training. Like, we want you to really do casting in front of us. So, and then you will be mentoring some other people with you. So yeah, so that's all like incoming. Okay.
Most of the districts have some kind of Clubfoot clinic, whether it's served together or some other NGO. So there are, no, we do provide. We register them in our thing, but thing is they don't want to come each time. They'll only come the first time and then they'll drop out. So see, most of the districts have a Clubfoot center, probably except for few 5 or 6 districts which don't have Clubfoot centers. You can always refer to them the main district center, and there the braces are available.
Yes.
No, that's the reason why we are trying to improve the capacity building of the block level orthopedicians. So thereby the referral to the district hospital will come down. The load on the district hospital pediatrician will come down. Moving further, if you're done, Gopi, if I can.
Yes,
Thank you so much. I just want one single question to know that how many orthopedicians have gone to the labor room? How many orthopedicians have gone to the postnatal ward? Be very sincere to your heart and tell me how many have gone and checked as to how many clubfoot cases you have seen or any other deformity. Yes, even a clubfoot is referred to you. Is there any harm in me going at least once in a day, so that the staff there becomes more alert? Oh my God, orthopedicians comes all the way. Why don't I refer the cases? So instead of waiting for the passive cases to come to your OPD, can you make it an active referral? Let there be a little change in the way we approach. Can we? They don't give a call to orthopedician. They give a call to the pediatrician. Every orthopedician sees every baby born. I have never seen, at least in. Is it true in all other conditions? Well, I have worked at various hospitals. Orthopedician has never been, he never comes, he or she. I mean, she is never there. He never comes to the labor ward or a postnatal ward. Am I correct? They'll scold you. No, you should become the trendsetter, be a trendsetter, creating an awareness. Just create an awareness in your own hospital. Is it difficult? It may sound funny today that why should I go to the labor room because it's a gynecologist's kingdom. I do agree. She or he may not. But then putting one word in one of the CMEs that you have at your own hospital, can't we do this? It's open now. Let us think out of the box. Let us not be monotonous to say that I'm a horse with blinkers, I'm just going to be like this. No. Can we change it? ನಾನು ಅದೇ ಊಟ ಟೈಮಲ್ಲಿ ಮಾತಾಡ್ತಾ ಇದ್ದೆ. ಐ ವಾಸ್ ಟೆಲಿಂಗ್, ಈ ರೂಮಿಂದ ಹೊರಗಡೆ ಹೋದ ತಕ್ಷಣ ಮತ್ತೆ ಕ್ಲಿಯರಾಗಿ ನನ್ನ ಬ್ರೈನ್ ಮತ್ತೆ ಕಂಪ್ಲೀಟ್ ವಾಶ್ ಆಗಿಬಿಟ್ಟಿರುತ್ತೆ. ಐ ಆಮ್ ಬ್ಯಾಕ್ ಟು ಸ್ಕ್ವೇರ್ ಒನ್ ಟುಮಾರೋ. ಕ್ಲಬ್ಫುಟ್ ಇಸ್ ಗಾನ್ ಔಟ್ ಆಫ್ ಮೈ ಮೈಂಡ್. ಟ್ರೂ. ಇಲ್ಲಿ ಕೂತಿರೋದಷ್ಟೇ ನಾನು ಇದು ಮಾಡ್ಬೇಕು ಅದು ಮಾಡ್ಬೇಕಂತೀವಿ. ವಾಪಸ್ ಹೋಗಿದ ತಕ್ಷಣ your OPD routine starts. You all agree with me? Touch your heart and say, excellent. Happy about it then. Very happy. Okay. Now, I think when Dr. Mohan and myself were discussing over lunch, we thought I was thinking that you will become the master trainers for the 10 districts that we have chosen right now. We will plan and give it to you. We have all your contact numbers. Contact numbers has been collected. We will not create any WhatsApp group. Please, I have so many WhatsApp groups, I don't know which group is sending what message. So no WhatsApp group is created. Probably a mail or a letter will be sent to you. And I think we have counselors at these places who will coordinate with you. You in turn will go back to your district along with your block level orthopedicians, maybe sensitizing CHC medical officers, the PHC medical officers, and the RBSK team. Probably you can have a small CME session. Can you? To sensitize them. I have no voice coming from the other end. A simple way. Have one CME. And then once they know that, okay, the orthopedician is very interested in getting the clubfoot, referral starts pouring in. Then slowly we will ask our RBSK team or the counselor from Serve Together to address the ASHAs. Or maybe me on a SATCOM, I will address ASHAs. All the 42,000 ASHAs, I'll address on the SATCOM. Or a YouTube, na prati vaar on YouTube marta idivi. We have our own YouTube channel, set up here in the 8th floor. We have a studio also. So allinda ನಾನು ಹಾಕ್ತೀನಿ, ಅದ್ರ ಲಿಂಕ್ ನಿಮಗೆ ಕೊಡ್ತೀನಿ. ಆಶಾಸ್ ವಿಲ್ ಬಿ ಸೀಯಿಂಗ್ ಇಟ್. ಅಂಗನವಾಡಿ ಟೀಚರ್ಗೆ ಕಳಿಸ್ತೀವಿ, ಸ್ಕೂಲ್ ಟೀಚರ್ಗೆ ಕಳಿಸ್ತೀವಿ ಅದನ್ನು. ದಿಲ್ ಆಲ್ ಪಾರ್ಟಿಸಿಪೇಟ್. ಪ್ರಾಬ್ಲಿ ಯು ಸ್ಟಾರ್ಟ್ ಗೆಟಿಂಗ್ ರೆಫರೆನ್ಸ್. My humble request is, we have a unique software called RBSK Swasthya Kirana. ಎಷ್ಟು ಜನ ಗೊತ್ತಿದೆ? ಸುರೇಶ್ಗೆ ಅಷ್ಟೇ ಗೊತ್ತಿದೆ ಅಂತ ಕೈ ಹೇಳ್ತಾ ಇದ್ದಾರೆ. Anybody knows about Swasthya Kirana? None knows. It's one of the best practice in India. Till date, I think many states have come and taken that. Even the World Bank had appreciated the software that we have developed in Karnataka. You get a line listing wise of every child, right from the child, the baby is born till 19 years. I have the health record of the child. It's all digitalized. You ask me what was the child's weight last year, I can quote you. What was the child's weight next year, I can give you that data, including the health records. Of course, it is very confidential. I only share it with the child or with the mother, whatever it is. But otherwise, my teams can see which child has got what disease, whatever it is. You also have closer loop. Now, my request to orthopedicians is, whenever you get a clubfoot case, kindly take one pic before the Ponseti method and one after. One during the process. Can we have this? Please push this I can, if you can get me the, I can show them. I'll show you a beautiful documentation which we have done. It's a beautiful documentation. I think even Gopi has seen it. Gopi, I've seen that documentation which you have done. And what I request the orthopedician is that you can take the child's name, parent's name, address, contact number, from which place she's coming from. The picture, one before the procedure, one during the procedure, one after the procedure. You give it to the RBSK teams. They will upload on Swasthya Kirana. All right? From the state, we will collect all those data. We will give it to Gopi. Gopi will make a good book. I'll show you how we have made 1,000 Smiles, how we made the booklet, which it's just amazing, no words. I think the earlier ACS, Additional Chief Secretary, had penned down in saying an excellent documentation, which nobody can do it that way. So it was done, and it's really good. I'll share it with you. So what I want is that, I can boldly say my doctor has seen this patient on this day. Otherwise, very number system hogta irate. You agree? Government go number beku, neevu number kodtira. Yes or no? I can show you. My health and wellness center, CHOs, they see 30,000 patients per month. Sub-center ge ಎಷ್ಟು ಜನ ಹೋಗ್ತಾರೆ? ಎಷ್ಟು ಜನ ಹೋಗ್ಬೋದು? PHC ಗೆ ಎಷ್ಟು ಜನ ಬರ್ತಾರೆ patients? So when I look into it, then that was the time I thought, okay, why shouldn't I make a software for my sub-center too? So now we are developing a software. 6 months down the line, I'll have a software that can connect from sub-center to your district hospital. That's what we are developing right now. The world is so digitalized. I think we need to make use of this. So I request all the orthopedicians to ensure that you document the child's detail. Just push the data to your concerned RBSK team. There's an RBSK team in every taluka. Does the RBSK team come and meet you? We will ensure they come in contact with all the orthopedicians henceforth. All right? At least they come to you monthly once, or whenever they refer the case to you, they will keep in touch with you. Right? Okay, so this will be a very good documentation so that we can portray 1,000 ಮಕ್ಕಳದು ಹೆಸರು ಸಮೇತ ತಂದೆ ತಾಯಿದು ಕಾಂಟ್ಯಾಕ್ಟ್ ನಂಬರ್ದು ಅಡ್ರೆಸ್ ಸಮೇತ ನಾವು ಕೊಟ್ಟಾಗ it got more weightage than only the numbers. How many of you agree? With the photographs. ಇದಕ್ಕಿನ್ನ ಸಾಕ್ಷಿನೂ ಬೇಕಾಗಲ್ಲ. So this is what I thought we'll do a quality service. Karnataka is not lagging behind in giving service compared to any state in India. In fact, ಹೇಳಬೇಕಂದ್ರೆ we are best. But however, Government of India review ಹೋದಾಗ what I've seen is Tamil Nadu portrays 6% more than what they have done. 3% ಮಾಡಿದ್ರೆ 6% ಹೇಳ್ತಾರೆ. ನಾವು 6% ಮಾಡಿ 3% ಹೇಳೋದು. We are not vocal. We are not very good at documentation. How many of you agree with me? That is where I changed. I thought I'll document every work I do every day. And then we portrayed. So that's where probably we are trying to get good numbers. I can tell you right today, sitting here, I can tell you how many my RBSK team today screen. ಯಾವ ಶಾಲೆಗೆ ಹೋಗಿದ್ದಾರೆ, ಎಷ್ಟು ಮಕ್ಕಳು ರೆಫರ್ ಮಾಡಿದ್ದಾರೆ, ಎಷ್ಟು ಮಕ್ಕಳು ಸ್ಕ್ರೀನ್ ಮಾಡಿದ್ದಾರೆ, I have a data, live recording ಇದೆ ನನ್ನ ಹತ್ರ. So likewise, we are all doing service, you're all doing it at the facility. But how many of you are portraying it? Let's do that. That's all. Nothing beyond what you're not doing, ನಾನು ಕೇಳ್ತಲ್ಲ, ನೀವು ಮಾಡಿದ್ದನ್ನು documentation ಮಾಡಿ, we'll give it to the government, is what I request. So this is one thing I wanted to appeal. Of course, the first as a pilot, I think this month we would like to plan to visit either Kolar, Shumaga or Tumkur. I think I'll sit with Gopi the whole of next week. I don't know how I'm placed. The third or fourth week, now we'll plan up one district, either Tumkur, Kolar, or we will keep in touch with the master trainers. And you can also invite IMAs, invite private practitioners. See, for me, it is whether a postgraduate student or whether it is a private doctor, it is immaterial. For me, doctors' fraternity is one. For me, patients are one. A child born in Karnataka with a clubfoot should not suffer. So private ಮಕ್ಕಳಿಗೂ ನಾವು ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡ್ತೀವಿ. ಗೌರ್ಮೆಂಟಲ್ಲಿ ಯಾರು ಇಲ್ಲ ಅಂತೀರಾ? ಎಲ್ಲರಿಗೂ ಫ್ರೀ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡ್ತೀವಿ. So let the private doctors also give it. And end of the day, let the entire district be a clubfoot free district is what my intention is. I start with a small step. Probably one fine day I'll be able to reach a clubfoot free Karnataka. That vision is there. I hope you'll all make it come true. So thank you so much. I don't want to take much time. ಬೆಳಗಿಂದ ಬರೀ ಪಾಪ ಬಹಳಷ್ಟು lectures ಆಗಿದೆ. You've been sitting there for since morning, I understand. Any help from our end, like somebody wanted to do innovative. I think when I was a nodal officer for Chitradurga, they want one orthopedician came out with a unique scopic, ಮಾಡ್ತೀವಿ ಅಂತ ಹೇಳಿ. Yes, it has been forwarded. The proposal is in the government. So ಆ ಥರ ನಿಮ್ಗೆ ಏನಾದರೂ ಬೇಕಿದ್ರೆ, you have joint director medical. Clubfootಗೆ ಸಂಬಂಧಪಟ್ಟಂಗೆ, yes, anything you please let me know, because anything concerned with 4 Ds, that is defect at birth, deficiency, diseases in children, and developmental delay is what I'm more concerned with. I don't want a child to suffer either with a learning disability, learning disorder, or ADHD, or autism. See, quality of life is gone for that baby, right? So this is what we need to pick up at the earlier stage, which of course it's not under your purview. But as our project director said in the morning, let us examine a baby holistically, or let us examine a patient holistically. A little patient hearing to the patient, I think half of his problem is solved. I think I'm done with my note. I've asked my person to get the book, which should be circulated. You can just have a look at that book. Over to you, Gopi. And I thank everyone for having joined this session. I hope you're all very happy. As an orthopedician, I know you're all very happy to doing surgeries, but not happy with Ponseti method. I do understand, because it doesn't generate any revenue when in your private practice. I do not know. But as a fellow human being, I think this is the only way I can help a child to have a better life. Right? Thank you.
Thank you so much, ma'am. Yes, now we are in the time of closing session. Before that, I take this opportunity to extend our heartfully thanks to the Government of Karnataka National Health Mission and RBSK for your extremely good support. Thank you so much, ma'am. So not only for you, entire team.
I think I should thank Dr. Mohan sir, Dr. Abhishek, and
Ashish.
Thanks a lot. Thank you so much for coming all the way. You people have come to motivate our doctors, who are actually highly motivated they are. And this is another added feather to them. I think they'll definitely work towards this particular Clubfoot Free Karnataka.
Thank you, thank you. So, yes, dear doctors, together we can do more. So that's what we believe. That's why we are here to request you all. It is not a part of only NGO, since, for example, thinking about serve together, we can't do anything without doctors, without patients, without government support. So together we are here to serve. So we came up with Serve Together name. So kindly extend your support. And we are there, our helpline number is there. Any approach, even you have some queries relevant to the treatment wise, any concerns, feel free to approach us. We will be facilitate to you the right guidelines. Whatever somebody is asking, PPT, these all things we will facilitate. The end of the day, like ma'am said, either private or public, it is not a matter. Ultimately, we have to give the better service for the people, those who are affordable. So they can have a cup of coffee in the coffee day. Somebody can have it in the roadside. It doesn't mean that it is not a coffee. Ultimately, the purpose should be fulfilled. So we are there, stand by. If you people are really practicing in the private, you don't want to bring them to government, that is your wish. We are there in that way also, we will support in different manners. Please approach us. And even though ma'am also mentioned, I want to extend my thanks to Dr. Mohan V. Belantur and Dr. Ashish Ranade, Dr. Abhishek, for your continuous support. We look forward to see Karnataka free from the Clubfoot deformity.
Documented cleft flip surgeries that we have done with the name, address, date, everything is here, pre-surgery, post-surgery, you can see everything. Every year we make this book. And this is all from RBSK referral, where this sort of booklet is going to be. I'll just circulate this. We'll just circulate. Please circulate.
Good.
Now this is the time for issuing certificates. I request ma'am to, I request Dr. Mohan Belantur and Dr. Ashish, both of them can come forward and issue the certificates. Dr. Abhishek sir also, please.
Sir, you sit, sir. You sit one by one.
Dr. Pramod ji. Naveen S. Shetty.
Dr. Pramod ji. Dr. Gururaj NG.
Gururaj NG.
Dr. Janardhan. Nidana sir, Nidana. Dr. Santosh Kumar Rao. For this, we have a small tea session. Can you have the tea together? Dr. Balachandra D. Dr. Balachandra D. Dr. Yogesh P.A. Dr. Nischal. Yes.
Yogesh P. Dr. Yogesh P.
Dr. Shivoyogappa. You. Dr. Sadanand Pai. Dr. Purushottam. Dr. Rajendra Prasad.
Dr. Pushpata.
Purushottam and Dr. Rajendra Prasad. That is Purushottam. Dr. Krishnamurthy. Dr. Suresh Kumar. Dr. Saluddin. Dr. Saluddin. Dr. Gopi Thiru. Dr. Gopi Thiru. Dr. Niranjan Kumar. Dr. Sudhakar.
Ravindra Bor. Dr. Ravindra Bor.
Dr. Tam Hesrevi. Dr. M. S.N. Yes? Huh? S-A-M. D-R-E-R-A-N-I.
Dr. Rajendra Bhuvar, Dr. Guru Raj, Dr. Salahuddin.
I request Veena ma'am to give certificate to the Serve Together staff.
I didn't train anybody, no?
So Monica.
This is to congratulate the back-end team for really what happened yesterday. They have done a tremendous job.
Monica from Hubli. Rukmani.
Thank you, Dr.
Rukmani from Kopal. Bhagya from Tumkur.
Bhagya from Tumkur.
Urana counselors will be placed at the districts. Tumkur, Dr. Suresh, note here, Urana.
We are working together. Meenachi from Kolar.
Kolar ma'am.
And Naveen from Bangalore, so he is taking photograph. And not only that, I love to address my beloved friends, Darshan and Ashu. They are volunteering to us to telecast mission value. Thank you so much for your support.
Naveen, photographer come counselor. ಎಷ್ಟು come ಇದೆ ಅದರಲ್ಲಿ.
ನಿಮ್ದು photo ಇರ್ತೀವಿ.
Please, we all join for the group photo.
I think we'll stand like where it's.
Huh.
Because it'll be difficult to cover it.
I think first matches can sit there. We will stand at the back of them.
Okay.
Let them all sit here.
Cover ಆಗುತ್ತಾ?
Camera person. ಇವರೆಲ್ಲ ಇಲ್ಲಿ ಕೂರ್ತಾರೆ ನಾವು ಹಿಂದೆ ನಿಂತ್ಕೊಂಡ್ರೆ ಅವ್ರಿಗೆ ಬ್ಯಾನರ್ ಬೇಕನ್ಸುತ್ತೆ.